I think start now, Mala. Ask Vinod to start.
मैम डॉक्टर गरिमा नॉट येट जॉइन मैम।
नहीं, मेरी बात हो गई, वो कर रही हैं।
तो अब
हम
शुरू
स्टार्ट कर लेते हैं।
ठीक है
हम स्टार्ट कर लेते हैं।
ओके मैम, काउंटडाउन तो मैं डाल रहा हूँ अभी।
आप काउंटडाउन आप दो, मैं स्टार्ट करती हूँ।
Start, ma'am.
Good afternoon, everyone. It's my privilege and pleasure to initiate this 3-day program of Gurukul, organized by the Institute of Obs and Gynae, Sir Ganga Hospital, under the Aegis of ISOPARB Delhi chapter. This 3-day comprehensive program of Gurukul will encourage our postgraduates to interact with senior teachers and also will broaden their outlook about the subject. We have tried to include capsules on contraception, CTG, specimen, drugs, HSG, as well as case presentation in this program. And I'm sure all our PGs will highly benefit from this 3-day conclave. It's my pleasure also to invite chief guest of this program, Dr. Jral. Madam is the chairperson and HOD, Institute of Obs and Gynae, Sir Ganga Hospital. Madam has always encouraged us in all the academic activity that we do from the department. Madam is in charge of the higher pregnancy clinic. She is past president of NARCHI Delhi, past vice president of AOGD, as well as NARCHI. She has been joint secretary Indian Menopause Society. At present, Madam is the president of Fetal SFM Committee, that is the Society of Fetal Medicine. And Madam has lots and lots of publication, and Madam has given so many lectures all over the country under so many societies. And Madam is a seasoned teacher and she loves teaching all the postgraduates. Over to you, Madam, for your words of blessings.
Yes, thank you, Mala. I would say that Gurukul was your baby, initiated so many years ago. I don't know how many Gurukuls we had, 7 or 8, maybe, to the best of my memory. Pre-COVID, we had the last one. And what response we get from the students, that's very, very informative for them, because this is designed not for a high-end acad thing. It is designed what a postgraduate should know, what a postgraduate has to answer in the exams. And keeping that in mind, we really sat down together and this is for you students, that we have put case discussions of common things, what you're going to get in the exams. We have put specimens, we have put instruments, CTG, and some dedicated lectures by the specialists, which are going to benefit you. And we would want that, since we're having it online now, please give us the feedback. What were the shortcomings at the end of 3 days? You will have the mail from Vinod should give a place where they can give a feedback that what has been not covered, what was lacking, what they did not understand, and what they want in the next Gurukul. Because we always have it pre-DNB exam. The exams are scheduled on 31st of February, 31st of March, May, this month end. And the next exam probably will be in December. So we'll have one in October, November, seeing what time slot we get. So we like your feedback, what you want for next session. This is for all DNB students, Pan India. I do not know, Mala, how many have registered? How many have registered? I can't hear.
More than 100 have already registered, ma'am.
So that's a large number of DNB they have registered, and more are going to register as they get free from their clinical work. With these few words, I would say that we start the program, and over to Renuka to initiate the proceeding. Thank you very much.
Thanks, Madam, for your words of encouragement. And always you have shown us the way how to go forward in all the academic activities, what the subjects to be taken, and how to guide our students and how to benefit the academic and teaching program. Now I hand over the scientific deliberation program to Dr. Renuka. Dr. Renuka is an associate consultant Institute of Gynaecology, Sir Gangaram Hospital, and she is the member of Urogynae subcommittee of AOGD. Young, very hardworking, dedicated consultant of our hospital, and we are very sure that she will conduct the program very well as she does all her clinical work as well. Over to you, Dr. Renuka, for your scientific deliberations.
Thank you, ma'am, for your nice and kind words. So with this, I would like to start the first session of today's scientific program. So for this, I would like to invite Dr. Garima Kapoor, ma'am. She is professor at VMMC and Safdarjung Hospital, New Delhi. She is a member of AOGD endoscopy subcommittee, and she is also executive member of IFS. Welcome, ma'am. She will give a talk on the topic breech. Ma'am, have you joined, Dr. Garima?
Garima has joined. Yeah, but I hope all the PGs have joined as well.
Yeah. Hello, ma'am. Thank you for the kind introduction. I would like to thank Dr. Mala and the organizers for inviting me for this very interesting talk on breech presentation. Hope I am able to do justice to this talk. So today we are going to talk about breech. So I'll just put on a slideshow. Just a second. I hope my slide is visible.
No, ma'am, it's not visible.
Other side is visible. Just give me a minute. Yeah, okay. I'll just share it. Yeah, 1 second.
You have to share your slides, ma'am. Screen share kar dijiye.
So today we're going to talk about breech, when to decide for vaginal delivery, when to do a cesarean, and how to handle the various situations that we come across with breech. So, okay.
Garima, you're not audible. I think your connectivity is weak. And your slides are also not seen.
Yeah. So I hope you can see the screen.
Yeah, now
Yes,
we can
ma'am.
see your slides.
Yeah, is my screen visible?
Yes, ma'am.
Yeah, your screen is visible.
Okay, thank you. Yeah. And am I audible?
Yes,
Yeah,
ma'am.
very nice,
You're
nice
audible,
and
ma'am.
loud.
You can go ahead with ma'am.
Okay, thanks. So yeah, today's topic we are going to cover about what is the prevalence of breech, the types of various breech presentation, approach to management, what is the role of external cephalic version in the current scenario, and how to conduct a breech vaginal delivery, the problems we anticipate in a breech cesarean section, preterm breech, and the neonatal outcomes. So talking about the prevalence, we all know that in preterm, the prevalence is high to the order of 20-25%, and near term, it is as much as 3 to 4%. And what is interesting to know is that the recurrence of breech, after one pregnancy, previous breech, you have almost a 10% chance of having a breech, and after 2, you're almost 1 in 4. And for a woman who has never had a breech presentation, her risk is 2%. So these are things we commonly encounter in our day-to-day practice. Just giving an overview of her types of breech, which I'm sure most of the residents would already be knowing, is that frank breech we know. Here the hips are flexed and both knees are extended. This is the most common type of breech we are seeing, mostly in the nulliparous. And this is usually the more easier to manage for vaginal delivery and for the operator also to conduct this. Then comes the complete breech, in which both the hips and knees are flexed, and the prevalence of this is around 5 to 10%. And the significance of this is that because the legs are coming first, there is a chance that the patient might push through incompletely dilated, and there's a little higher chance of cord prolapse and a little head entrapment, or cord prolapse to the order of nearly 5% in these cases. And then we have the incomplete breech, which we all dread as obstetricians, where we know that both the hips, they are not completely flexed, and it is seen in 10 to 40% of the breech fetus. And yes, one of the most dreaded complication is cord prolapse, which is as high as 15% in these patients. And yes, obviously pushing through incompletely and head stuck are also the problems which we encounter. Now, what is the role of external cephalic version in the current scenario? Talking about external cephalic version, most of the recommendations presently, they are saying that you should do external cephalic version. It is recommended that you should offer external cephalic version to all patients with singleton pregnancies, should be offered, because they have seen that it decreases the chance, it causes reversion to nearly 50%. So the average success rate varies somewhere between 30 to 50%, whether you use analgesia or you do not use analgesia. And with analgesia, the results are a little higher and it reduces the incidence. So most of our guidelines are saying that we should offer external cephalic version. But having said that, we also know that in the current scenario, most of us are actually not practicing external cephalic version. Hence, it is an art that needs to be revived and learned about. And talking about the contraindications, we all know that contraindications for external cephalic versions are previous cesarean and contracted pelvis, fibroid growth restriction, placenta that we know that can prevent it. I have this slide for external cephalic version, which I plan to show in the end. I'll try and show it right now. So moving on to this, I would like to show you a video on the external cephalic version. Just try to
Ma'am,
see. Yeah. So this is, yeah. It's just going to play. Yeah. This is the external cephalic version. I will just tell you, basically, in this, you are doing a forward roll where we are lifting the buttocks of the pelvis and gently pushing on the head towards the maternal pelvis. And after you have done halfway, it is a good practice to oscillate the heart sound to ensure that there is no fetal distress. And as you can see in this, we are changing the hand after the half roll, and then we proceed from right to left hand, and then now we're again directing the head towards the pelvis, where the other hand is used to put the buttocks up. Now, this procedure, a number of times it should be done. There is no clear-cut recommendation, but they say usually you should not try beyond 3 to 4 times, and within 5 minutes you should do. Under analgesia and with uterine relaxant, the success rates are better for external cephalic version. So that is there, and the complications we all know is that you can have abruptio placentae, fetal distress. So it should always be done in an OPD setting, but availability of operation theatre and emergency cesarean services should always be available for your patients in these cases. That part you must ensure. So if a properly, in fact, most of the guidelines, the RCOG, ACOG, they all are recommending that you should go ahead with the external cephalic version unless there is a contraindication. Patient should be counseled and offered that. So let's say we planned it or whatever it happened, but your patient somehow either she reverted or she refused, or maybe she was not a candidate, and now we end up with a patient who is at term, who's a singleton breech, And what do you do? Now, how do we counsel our patients who are term breech and now who want to know their mode of delivery? So looking through the guidelines, most of the guidelines, RCOG, HCOG, and all the other guidelines, they recommend that you should do planned vaginal delivery of a term singleton breech fetus is a reasonable option under specific protocol guidelines. So this is very important that it is a very safe method and breech vaginal delivery can be offered. But they have specified that you have to do an appropriate case selection. The availability of skilled attendant is very important because training is very important and management according to strict protocol. So studies have actually shown that if you do not follow the protocol or if the attendant is not skilled, you may actually have higher morbidity. So it is actually a very good method as per the standard recommendations also. Then how do we manage this patient? Now, this is not a very jargon, it's a very simple thing. And I would just like to tell you, I'm just going to repeat this slide in my subsequent presentation slides also to make it simple to you. So it's very simple. You want to see whether you want to offer your patient a vaginal birth for cesarean. Okay, first you see whether your patient is suitable or not. Do you think she's fit? So my first step is that you choose your patient right. That is the first and the foremost important thing for your patient. So how do we choose our patient right? So here is a list of it, which will go one by one. What are actually you should ensure that there is no contraindication to vaginal birth. So first, there should not be any fetal anomalies. We all know that may cause dystocia. Hydrocephalus also, they say you should do by cesarean because yes, it can cause dystocia or an abdominal tumor. What about the fetal weight? What do the guidelines say? The actual value varies, but we all agree that between the 10th centile to 3.8 kg, somewhere between 1.5 to 3.8 kg is the ideal weight for a baby to deliver vaginally. If the baby is lower than that, 2.5, if the baby is lower than 2.5 kg or the weight is more than 3.8 to 4 kg, it is reasonable to offer them cesarean. Then coming on to gestational age, yes, we do say that you have to offer cesarean for preterm fetuses if they come electively. We'll also discuss that in detail in the subsequent slides. And one very important thing is there should be no hyperextension of the fetal head or neck. An extension of greater than 90 degrees is known to be deleterious. There have been studies which have shown that extension of neck or the star gazing, here you take an angle between the occiput and the central axis of the and the neck, and if you see if it is more than 90 degrees, studies have shown that in more than 50-60% there have been cervical spine damage, because of which there have been long-term sequelae. But but if you do an ultrasound, this is something you usually pick only if you do an ultrasound beforehand. And there should be adequate amount of fetal head flexion with adequate liga. Then the frank or complete breech, they are more favorable. The footling breech, we all know, or the incomplete breech as we commonly say, here the chances of cord prolapse are higher to the order of 10 to 15%. And obviously there's always a risk of incompletely dilated hips and passing through while head getting stuck on. So it's not a very safe mode. So for these presentation, we do not prefer. And obviously you should have a facility where your staff is trained. You have 24 hours emergency cesarean facility, that goes without saying. What about spontaneous labor? Though I'll talk about what are the recommendations for induction. Spontaneous labor itself, if patient is not, doesn't necessarily mean that you cannot offer her vaginal birth. You may still offer her vaginal birth. And previous LSCS is a relative contraindication because we are scared that when we are going to maneuver, we'll have to give suprapubic pressure, which may exert a pressure on the scar. And there's a new risk factor that has come, which is by the RCOG, where they say that there's no persistent breech. If there's a persistent breech, if you're examining a patient and you find there's persistent breech, you must look her for other risk factors. And if you find other risk factors, you should refrain because it may be associated with some sort of uterine anomaly or fetal anomaly. So you must assess your patient. So this is one of the new indications that RCOG has come in 2017. And any evidence of antenatal fetal compromise before labor itself means you go ahead with the cesarean section. And obviously the pelvis should be adequate, and the pelvimetry using only clinical pelvic assessment is what is recommended. We do not recommend any imaging or anything for this. So having scrutinized your patient and ensuring that your patient falls into this category, it is a reasonable option that you may offer your patient a vaginal birth. But before offering her, you must ensure that your setting is obviously has a facility which is adequate in maintaining and is can do a cesarean section, and your staff is skilled for handle a breech vaginal delivery. So having ensured that, now you discuss and you have to counsel the patient. Again, it has to be stressed time and again that it is a shared decision. It is not the patient's decision, it's not the physician's decision alone. The patient also has to agree for it, and therefore you have to counsel the patient. So how exactly do we counsel the patient? What all do we need to tell her? That is important for us to know. You have to tell her that LSC is after 39 weeks. We are one advantage is we're avoiding stillbirth after 39 weeks. We are avoiding intrapartum risk of delivering a fetus. There's an intrapartum risk of 1 in any way. Cephalic low baseline risk is there. And we are also avoiding the risk of vaginal birth. But again, you have to tell her that the risk of perinatal mortality is actually, if you look in the absolute values, not very high. If you compare the various data, you see that with cesarean, it is 0.5 per 1,000 births. With a vaginal delivery, it's 2 per 1,000 births. And with a planned cephalic, it is 1 per 1,000 births. So if you actually see the absolute numbers are not very high, so this can be a reassuring to a patient, and she may be counseled that she can opt for a vaginal delivery. So you can tell her that this is as safe as a planned vaginal cephalic birth. But when you come to the long-term effects, the patient, what are the short-term effects on the neonates? The LSCS after 39 weeks, we know that it decreases it improves the APGAR score of the baby. So the immediate effect is good. But how does it affect the long-term? We should counsel the patient that regardless of the mode of delivery, with a breech delivery, there's a risk of cerebral palsy to the order of 1.5 to 1,000, which is not high. And any abnormal neurological development, which may not be as severe as cerebral palsy, can occur in 3 per 100. That is a minor one. So, and if you look at the long-term outcomes, the various studies have found that there have been no effect on the planned vaginal birth. There's no increase in the risk of long-term morbidity in patients who undergo planned vaginal birth. So this is a very reassuring data if you tell the patient that the perinatal mortality is not very high. There may be some short-term benefits in mortality and perinatal morbidity, but long-term effect is not significant. So that is also reassuring. But you also need to counsel her on the woman's immediate and future health. That planned cesarean section for breech, it carries a small increase in the immediate maternal morbidity, which is in the immediate post-op. If you look at 2 years, if you follow these patients for long-term in 2 years, you will find that the morbidity is actually not increasing. Be you talk of SUI, be you talk of depression, be you talk of health of the mother, it's absolutely, the studies have shown it's similar. And you also need to tell her that it's not only about comparing a planned cesarean and a planned vaginal birth, because in 40% of the women who are planned for a breech vaginal delivery, they may end up in a cesarean birth. So you need to tell her that her risk of complications would be highest if she lands up in the category where you have counseled her for vaginal, and then she lands up in a cesarean, then the relative risk is higher. So all these points must be told to her patient for her to make an informed decision. Another interesting point with the RCOG has pointed out in 2017 is that you also need to tell her about the risk of future pregnancies, because once she has a scar, she will have the risk of vaginal birth after cesarean. She will be more prone for adherent placenta, more prone for rupture and counseling. So these things also should be told. But again, you should not just scare her on that. You have to individualize your patient and see her risk profile, her obstetric risk profile, and then you should take a call, because it's a shared decision with the patient. And obviously, there's a very interesting thing that after this cesarean, patient has a small increase in the risk of stillbirth. The odds ratio is 1.47 for subsequent babies. And this is majorly suspected due to risk of uterine or scar dehiscence in the subsequent pregnancy. So coming back to my table, I'm just going to demystify. So first we saw our patients and we saw that is there any contraindication to vaginal birth? Yes or no? If we found no contraindication, we assessed our center, we can handle a vaginal birth, that's good enough. We talked to the patient, we discussed the risk and benefit, and we showed her that the data is very encouraging for a patient to undergo a breech vaginal delivery. So that's also a good thing. Then you offer a patient. So patient may opt for a breech vaginal delivery or she may opt for a cesarean section. So if she opts for a breech vaginal delivery, we'll go ahead. And what if she opts for a cesarean? We'll let you know. So again, just one point I would like to discuss here, that if your patient opts for breech vaginal delivery, we'll monitor the patients, we'll go ahead. But at any point we find slow progress or non-reassuring, you may again revert for cesarean. So with this understanding, you may offer her a breech vaginal delivery. Now I would like to demonstrate to you how to conduct a breech vaginal delivery. It's a simple. Now this video that we are going to show you is an assisted breech vaginal delivery, which is uncomplicated. So here I'm going to just show you an uncomplicated assisted breech vaginal delivery, how to conduct. And if the audio is low, I will speak right here. So just let me know if the audio is low. Thank you. So basically, this is just to demonstrate to you how to conduct an uncomplicated breech delivery. I'll just get down to my 1 second. Just give me a minute. Yeah. So the basic principle now that they are it's very much stressed upon is that you should not give traction from below. That is not recommended, because they say that if we do a traction right now, it's going to cause extension of the head and cervical spine injuries, and it may also lead to a nuchal arm. So that is not what is being encouraged now. And the other point that is that you should not elevate the baby's fetal trunk, because they say that if you elevate, you should always keep the baby horizontal. That is also being stressed upon, because if you elevate the baby's fetal trunk, then it is likely to cause extension of the neck, and you may end up with a nuchal arm. So these are some of the principles you should always remember while conducting this. Now, what is the management of your patients of breech presentation in labor? Now, the management depends upon whether your patient is coming in labor. What if she comes in labor? Now, this is something we are planning and conducting. So if she comes in labor, it depends on what is the stage of the labor, what are the factors associated with increased complications, availability of appropriate clinical expertise, and informed consent. So if your patient comes in labor, it does not necessarily mean that you have to do a cesarean. One thing you should be very clear that this is not even supported by guidelines. And especially if your patient is almost fully dilated, she is in the second stage or near second stage, you should not just tell her you are, just because you are breech, we are going to put you through this. You should actually, in fact, offer her vaginal delivery if you think that your patient is suitable for that. And you should, if you have facilities, you should do ultrasound for fetal neck, legs, and fetal weight. And women should be counseled with vaginal birth. Now, this is actually recommended by most guidelines that you should offer your patients you should offer them an ultrasound before you go ahead with the either decide the mode of delivery, because you should always rule out the extension of leg. And the SOGC guidelines 2019, it actually says that if you do not have the facility for ultrasound, it may be reasonable to offer a cesarean to a patient who comes to you with breech at term. So anyways, the significance of ultrasound is there. Now, you've decided to take your patient for labor. Now, how do you manage the labor? So going into the evidence-based approach, that how is it that you're going to manage your patient's labor? So talking about the epidural analgesia, you can give epidural analgesia. It is very much recommended. But the only thing that you have to take care while giving epidural analgesia is that may likely to increase cesarean because the labor gets slow. But the other option they say is that you keep the patient calm, because maternal pushing efforts are very important to conduct a good breech delivery. So giving her maybe giving her an analgesic, keeping a calm environment, and encouraging your patients might be better. But if required, you may give her. Talking about fetal heart monitoring, most of the guidelines, they are recommending continuous electronic fetal heart monitoring. But if it is not possible at your center, intermittent auscultation as per the your recommendation of labor protocol is also an acceptable method. Where should vaginal breech delivery be taken? The one that I showed you, the uncomplicated, it should take place in the labor room. It should take place in the labor room in a hospital with facility for emergency cesarean, which I think most of the centers will be able to meet. Then how do you manage the first stage of the labor? The principle is same for the first stage of labor as it is for the cephalic presentation. The only thing you should be careful is that you should not do a routine amniotic or routine rupture of membranes. However, if your membranes do get ruptured, it is recommended that you must do a vaginal examination to rule out cord prolapse. That is extremely, extremely important. And as far as induction of labor, the guidelines are silent as of now, because whatever literature is available, they are not recommending it. But I believe that in selected cases, this may be done, because there have been studies which have shown that yes, it may also be done. But as a standard of care, it is still not very clear. As far as augmentation of labor goes, the RCOG says that augmentation, now it's a two-pronged fork basically when we talk about augmentation of labor. On one end, it is that most of the authors and clinicians, they believe that if a labor is progressing slow, it's actually giving you a red warning sign that something's not okay, and you actually need to look into your patient. So what they normally practice is that if you observe the progress, if you find there's a slow progress or it is not progressing, you take it that it is not, there's an element of fetal-pelvic disproportion, and you prepare your patient for section. And this is something which I found uniformly across the guidelines and studies. But the other says that you can do, if your contractions are slow, you can give her a little bit of oxytocin, and this may actually help. And if you still feel that the labor is not progressing, you may go ahead. Sorry, ma'am. You may go ahead and conduct cesarean section. So the RCOG is recommended that oxytocin be given if contractions are slow with epidural. But SOG is saying that yes, you may give. So I think it's a reasonable option. If you're finding slow progress, you may consider giving oxytocin. But if you find that in spite of good contractions, the progress is slow or it's not progressing, we should go ahead with the cesarean section. Then coming on to the birthing position. The birthing position, the studies have shown that there is more wider space and easier birthing in semi-recumbent or patient on all four, and some also say on hand and knee posture. But this doesn't mean that you start delivering your breech delivery in this position, because it is a little difficult to do maneuvers in this position. Even if you're taking your patient on all four on hands and knee, at the time of delivery, you will have to revert back to the standard position of care, because that is how you're comfortable with. So this is suggested. You may or may not do. You may stick to your semi-recumbent. Then what about the duration of second stage? What does it say? They say that there is some amount of time is required for the passage of breech through the birth canal. So a time of around 2 hours they take, as per the RCOG, is for the descent of the head. If you do not find an adequate descent of the baby after full dilatation for 2 hours, then it may be an indication for C-section. And SOGC say that passive second stage should be 90 minutes, while active pushing phase should be 60 minutes. Otherwise, you should resort for a cesarean. And the principle across the guidelines is assistance without traction. And as far as episiotomy is considered, episiotomy is selective. They are not saying that you should routinely give episiotomy. If you only feel the need, if you feel that the perineum is not lax enough to allow it, only then you should give an episiotomy. So many times in a multigravida patient, you may deliver breech without even an episiotomy. And what are the cases that you need assistance or you need to deliver her? They say that any evidence of fetal distress in terms of poor fetal tone or color, or delay of more than 5 minutes from delivery of buttocks to head. If there's more than, if after delivery of buttocks to the head, the delivery interval is more than 5, or after delivery of the umbilicus to the head, it is more than 3 minutes, then you may consider that you need to assist and you need to expedite delivery. And otherwise, SOGC says that if your passive stage is more than 90 minutes and active pushing phase, even after 60 minutes, the baby is not, the buttocks, the climbing is not occurring and the baby is not delivering, you should go ahead with the cesarean. So these are the evidence-based guidelines as per the literature. And obviously, the choice of maneuvers used is required to assist the delivery should depend on the individual experience, expertise. You should have the appropriate skill and you should do what is comfortable. So this is the sequence of events that actually happens is that you start with the, when you see the anterior buttock, you may give a pudendal block. If you haven't, patient is not under epidural analgesia, you can offer a pudendal block. When you see the anus at the time of climbing, if you want to give episiotomy, that's the right time. When the posterior buttocks is seen, basically hands off. The basic principle I'm stressing again and again is that you have to do assistance without traction, hands off. And after the, when you see the buttocks, you have to deliver legs. Again, for, sorry, for the frank breech, you may have to assist leg delivery by Pinard's maneuver, as has already been shown. And if umbilicus is coming from below, you need to generally pull down the loop of cord to prevent cord compression. And when you see the scapula, it's the right time to deliver the arms. And at the nape of the neck, we are delivering the head. Just a second. So these are the maneuvers for assisted breech vaginal delivery, which I've already shown to you. The only thing I would like to stress is that you should keep the baby's back to the horizontal and should not extend it. Otherwise, it will cause hyperextension. That is there. Just 1 second. One second. I'll just log in through the other device. I'll just log in through the other device. Just give me 1 minute break. I'll just proceed from there. Sorry for the interruption. 1 second. Yeah. So can you see the screen? Just a second.
Yes, ma'am.
Yes, ma'am. Okay, okay. Just 1 second. I'll unmute myself from the other. 1 second. Just okay. 1 second. I'll just unmute myself.
Kindly make it full screen.
Huh? Yeah.
Make it full screen, ma'am.
Yeah, I'm just doing that. 1 minute. Yeah, I'll do that. 1 second. Just, yeah. Okay. So, yeah. Okay. So I'll make it full screen. Is it visible? Yeah. Okay. Is it okay now?
It's okay, ma'am.
Yeah. Okay. So assisted breech vaginal delivery. So I'll stress again and again that you have to do a hands-off till umbilicus, and suprapubic pressure is to be encouraged to promote head flexion and avoid traction, that is there. And external rotation, I think that part we have covered. Then the next part is, what about the delivery of the arms? I just told you that the basic principle is that you deliver the arms by uh, Lofset's maneuver, as has already been told. But it may not be always generous, and we all know who have conducted breech delivery that you often land up in situations where the baby's hands may be extended or the shoulder is not giving away. You're having trouble with that. So the Lofset maneuver, which we technically do, is that after delivery, as I had showed in the video, that after delivery of after seeing the scapula rotate 90 degrees and with a gentle traction downwards, you are able to see you can go above the elbow and press upon and deliver it. Okay. Suppose it is not happening, then you may have to extend it and you have to give a downward traction while giving a Lofset's maneuver, and you have to turn again 180 degrees for the posterior shoulder or the posterior arm to come anterior, because we all know that the anterior pelvis is deficient, is smaller compared to the posterior. So then it is at a lower level and you can deliver. And in case it doesn't help, as I've already told, that you slide an index finger along the fetus over the shoulder into the antecubital fossa. And when you press, there is flexion of the arm and you can take out the arm and deliver it. Sometimes we come with the problem of nuchal arm, that the arm remains behind the fetal neck. Then the fetus can be rotated. You have to rotate the fetus in the direction of the arm so that it faces the pubic symphysis and helps dislodge. Just a second, I have this video of 1 second. I'll just show you the video for that. I'll show it to you in the end for the video for that, nuchal arm. And for this, we have already come the Morris-Melly-Wheat maneuver. We have already covered this, how to conduct it. Now, this is very interesting, delivery by Piper's forceps. For places where the Piper's forceps are available and for the operators who conduct delivery by Piper's forceps, they are actually very comfortable doing it, and it's a very good method. I would like you to look at this Piper's forceps here. They are actually very long forceps. And if you see, they have a backward curve. Now, this curve helps because at the breech, the operator is standing at a lower level. And because of this, you need not hyperextend the baby's body, and it is easier to conduct. So how do you do it is basically the feet are grasped up and you first insert the left plate. That is the time when the assistant is taking the breech towards the right. The assistant moves the body of the breech. I'll just minimize this. I think then you can see it. Yeah. The assistant moves the body of the operator, the body of the breech towards the right, and you are sitting in a kneeling position. You are actually at a lower level. And when you're inserting your blade, you're inserting it down. You're actually almost inserting it vertically 90 degrees to the maternal abdomen. You're putting it down and you're going below the fetal ear, and then you take a 45-degree slant up. Okay, so you're going when you're coming down, but then you take a 45-degree slant up, and then you put it over here. And that time you ask the assistant to hold it, and then the other assistant is going to push the body towards the opposite side, the left side, and then you can put the right blade, and then you need to lock it. And the main principle of doing a Piper's forceps is it is causing flexion. As you're moving it along the birth canal, it is causing flexion of the fetal head, and that is the main principle of doing a Piper's forceps. So it's actually a very good method for delivering the head. Now coming on to the what are the problems you can face while doing a breech. So the problems, they can occur at various levels. The problems can occur at the buttocks. The problems can occur at the level of shoulders, the arm, and the problems can occur at the level of head. So I would like to show you videos. Now I'll start with this. I'll show you a video at the buttocks. So what can go wrong at the level of buttocks? I'll just play this video for you. I hope it's visible. So, yeah. So I hope it's clear. Just a second. I'll just log out from here. Give me 1 minute. I'll just log out.
Dr. Garima, ma'am, are you there?
Yeah, I'm there. I'm there. Yeah. There. So basically, for if you have a difficult delivery in the arm, this simple is Dovset's maneuver. It works normally also for assisted breech vaginal delivery, and it may also work in this case when you if it's a difficult. But if you are not able to do that, you can take your finger along the antecubital fossa, press it so that your hand sweeps down, and then you can go ahead with it. And if in case of a nuchal arm where it is coming behind, you may have to convert the baby. You may have to take it towards rotate it 180 degrees ventral towards the side of the thigh, and then you need to do it. So what if there's head entrapment? So we talked about buttocks, problems at the level of buttocks. We talked about delivery with the arm. What if you get head entrapment? Head entrapment, usually it happens when there is when there's a preterm fetus and the head to abdominal circumference is more, and through an incompletely dilated cervix, the abdomen is passing, but the head is still there. Or if the mother should put the patient in McRoberts maneuver, it increases the diameter of the outlet. The patient's knee and thigh should be flexed, and you should press it against the abdomen. And you may use turbutely. If this is not happening, what we commonly do is that we use the two-sense incision, which I think most of us are aware with it. Here you can make 1 to 3 incisions, but again, avoiding the descending cervical artery, it has to be done at 6 o'clock, 2 o'clock, and 10 o'clock. And we all know we need to avoid the 3 and 9 o'clock position. And 1 or 2 fingers must be placed between the cervix and the presenting part of the fetus for the surgeon to know it doesn't extend. One of the major problem with this is that if we are not careful, it may extend into the lower uterine segment and may extend into the broad ligament, and it may lead to bleeding and further injury to uterine vessel, ureter, bladder, and severe hemorrhage. So this has to be done properly, and if done safely, it is a good method. The other we all know is the Zavanelli maneuver. Usually this is resorted to when the baby is asphyxiated and it's not a very, that it's one of the last resort. To administer a tocolytic agent, you replace the body of the fetus in the uterus and you proceed to cesarean, and there's high risk of perinatal morbidity and mortality. Coming on to symphysiotomy, since it is mentioned, I don't think anyone of us is actually doing it. So I'll just give a brief description of this method. Basically, here what they are doing is they are making a fibrocartilaginous area of the symphysis pubis. They are infiltrating it with local analgesic after putting a catheter inside the urethra, and the women is asked to abduct. and after displacing the urethra with a small scalpel, they are cutting out on the cartilaginous portion between the pubic symphysis. This leads to a modest separation in pubic bones, which is actually permanent, and this outlet then you can deliver the baby. It is obviously most of our days and mobilization on crutches and weight bearing is comfortable, and patient is asked to avoid to abduct for 7 to 10 days. And the complications can be many. We all understand that lacerations of the bladder, the urethra, the vagina, urinary incontinence, psychovaginal fistula, or long-term pelvic pain and instability may also be there. Then coming on to the management of preterm breech. How do we manage a preterm breech? Now we do know that if you're planning a delivery, if it's an elective delivery, it's advantageous to do a planned cesarean section. This is the thing which is recommended by almost all guidelines, that if it's a preterm breech and we know that the baby is salvageable, you should go ahead with a planned cesarean section. We know there's a decrease in 41 to 49% risk of death, and even IVH, intraventricular hemorrhage reduction is there. But what if a patient comes in labor? What if a preterm baby breech is coming in labor? Again, routine cesarean section is not recommended. If it's in labor, you need to individualize and assess your patient. If you think that your patient can deliver comfortably, you might as well offer her vaginal delivery if she's coming to you in labor. And as far the labor protocol is concerned, the management is essentially similar for a preterm breech as it is with a term breech, and we have discussed previously. And if there's head entrapment, obviously we are giving loose incision because this is more common here. And sometimes even in cesarean, when the uterus contracts and retracts, if you're not able to deliver the head in a very limited time, so you may have to extend the incision or give propolis to your patient. Now, what about if the twin pregnancy comes with a breech presentation? Then what do we do? Planned cesarean section for a twin pregnancy where the presenting twin is breech is recommended. The evidence is not very robust. Again, I would like to stress here that the evidence is not very robust, that you're really improving the morbidity and not very robust. But since we do not have a robust, till now it is safer to say that go ahead with the cesarean. So what, for a breech first spontaneous twin in labor, again, you need to assess. So the take home message is that if a breech is coming in labor, you actually need to assess. And if you think a delivery is more smooth and inevitable, you might as well go ahead with that. And again, the individualization is very important. For breech presentation of the second twin, routine cesarean section is not recommended either in term or preterm babies. So we are not recommending that you do. So what do you do for breech of the second twin? The delivery of the second twin in a non-vertex presentation, once the first twin has been delivered, is breech extraction. Basically, it is internal podalic version and breech extraction. However, in a few cases, it may be contraindicated, like in singleton non-vertex presentation. If you have any other indication for cesarean delivery, non-reassuring fetal heart rate, prolapsed umbilical cord, if you do not expect to expedite deliveries, you may do. If there's a uterine anomaly, if extreme prematurity, if there's a growth discordance of more than 25%, you may consider doing that. So what is the anesthesia? If you have to do breech extraction, ideally it should be done in the OT under anesthesia and the epidural. The setting should be in the operation theater. You must take an informed consent. You should assess the fetal heart rate, evaluate the second twin. And it is a very good thing that after delivery of the first twin, you actually take not wait, you must evaluate. If you're planning a breech extraction, you must auscultate the fetal heart to show that it is fine. You must evaluate the position of the fetal head. If you have the facility for ultrasound, nothing like it, it's a very good modality. Go ahead, do the ultrasound, look where the head is, where the feet are, where the legs are. It's going to help you. If you don't have, you should at least do a Leopold's maneuver per abdominally, and you should try and assess the position of feet, the head, the back. This may be required, not always, but yes, it is required. Now, before I go on to this, I think I have a video. I would like to just show you that video once. And I think then I will show you the video. So this is the video I would like to show you.
Ma'am, video is not visible. Video is not
Sorry?
running.
Video
Video
is,
is not running. Video is not running.
ma'am, it is
No,
running
ma'am.
here. Can you check your
No,
can you
ma'am,
check your
I
internet
can't
connection?
see it, ma'am.
Anybody else also
Can you
cannot
see
see it?
Vinod?
Anybody else also cannot see? Because I think it's usually due to an
Yes,
internet
ma'am.
No, ma'am,
problem.
no video not showing.
It's not showing, ma'am. There is no video.
You can
It's not running.
see my screen. The video is visible or it's not even visible, the video. Can you see the video?
Ma'am,
The screen on the video on the screen is visible?
No, ma'am. Only one slide is visible. Internal totalic version and breech extraction. No video is running.
Okay, just 1 second. I'll try and see now. I'll stop sharing and I'll share again. I think that is what I can do. I'll share my screen again. That is something.
Okay.
Wait a second. Just tell me, is the video screen visible now?
Yes, ma'am. We can see the screen, video screen.
I
but,
haven't played it yet. I'll just see if it. Just
started.
tell me. Okay, I'll start the video. Just tell me. Is it visible now?
Yes, my video is running, but there is no voice.
Okay, I'll tell you. Okay. Now, basically, this is how we do is internal totalic version and breech extraction. Basically, it is done for the second twin of breech in a twin pregnancy with breech presentation. So here you have to try and as I've already told that you have to assess the fetal heart and you have to go through the intact membrane. After ensuring the position with one hand, I'm taking it up to the level of feet. And this should be done tried without rupturing the membranes. You see the way I'm holding it, it has to be done in a cigarette holding fashion with the thumb and 2 fingers. And the other hand is pressed on the hand and trying to put the head. It is trying to put the head towards the abdomen, while with the axis traction, I am trying to deliver the legs, the feet of the baby out of the introit membranes, if not already ruptured. And you should try and grasp the buttocks as soon as the buttocks are delivered, because it is always more safer to grasp it with the buttocks. Whenever we are grasping with the buttocks, the same principle is that you use a femoropelvic grip. And here we are using traction. In assisted breech vaginal delivery, we were relying more on the maternal expulsive efforts. Here we are giving traction. And when the inferior level of scapula is seen, here you can see loft sets. When you're doing loft sets, you have to give a little downward push so that this helps in the delivery of the arm. If I give the push a little downwards, it helps in giving it the direction. Here again, I've reversed it, and here you give it a little bit downward push. This helps in delivery of the arm. If it doesn't, I'm taking my finger, pressing on the antecubital fossa and aiding in the delivery of the head. Then you wait for the appearance of nape of the leg. You may have to give traction because this is a case of breech extraction and the patient is under anesthesia. The operator is giving suprapubic pressure, and the delivery of the head is similar in the Morris-Smelly-Weak maneuver. I'll repeat it again with your index finger and middle finger on the cheek on either sides and the other finger supporting. And with the right hand, I am putting the middle finger on the occiput, and you were going to deliver it. I think in this video I forgot to put the finger on the occiput. So this is how you're going to deliver it. This is the breech extraction. So coming back to my presentation. So I think we have gone through this. I just put this slides in case we had a problem with the video. So you see that the other hand is supporting the head and it is trying to push the head towards the fundus, while with the axis traction device, and you see you are using your 2 fingers and a thumb to hold it in a cigarette holding fashion. And then the difference here is that I am giving traction from below. And what is the advantage of putting this towel? This towel is very important. One, it is going to inhibit the respiratory impulses because of the air. Second, it's going to help you improve the towel, and it will also prevent meconium aspiration because patient is not going to gasp. So this is how you are delivering, and the breech extraction is covered. You could use a pipe or forceps also, whatever you are more comfortable. So the complications, we have discussed that there could be fetal head entrapment. If there's entrapment, you can put a Drusen's incision as already discussed. If there's umbilical cord prolapse, You can expedite delivery by cesarean. If there's cervical spine injury, it may occur if the head is hyperextended. So you have to maintain flexion. Always keep the baby's body flat till the scapula. Do not extend it. Even after that, when you have to elevate the body, do not elevate it more than 45 degrees. Very, very important. And you can have an abruptio placentae. You have to look for fetal heart and assess whether you want to expedite the extraction or do an NSS. That is a call you need to take. They can be traumatic and atonic leakage, which have to be managed accordingly. Now coming on to cesarean breech birth, I hope I have time. I wanted to cover the cesarean breech birth as special complications. Basically, we
Yes,
schedule
ma'am.
at around 39 weeks. You have to confirm the lie before surgery. Dextro rotation has to be corrected of the uterus, more so because the wedge is often pushed before you plan to give the incision. That is very important. And if the basic principle is that you give a sufficiently large abdominal and uterine incision to allow smooth delivery of the fetus. The fan and seal incision should be 3 to 5 centimeters above the pubic symphysis. And the uterine incision, classically, they say you give a smile up incision with a smile up facing. And sometimes, especially in emergency cesarean, you may need to extend if your presenting part is not near the incision line. You may need to extend to UJ inverted. And the manner of delivery is similar to the breech vaginal delivery. I will discuss what are the differences. The principle is same, gentle, atraumatic, and you have to avoid hyperextension. Then the important point is that you have to identify the presenting part of the fetus from the incision. So you must do a per abdominal examination before a breech cesarean to look where is the feet, where is the head, how you're going to give your incision, because you have to catch hold of the buttocks if preferable. If not, then foot. So if the footling presentation is there, you have to hold the legs. You have no other option. But again, you know that there's always injury to the joints and bones is always there when we're holding the legs. Anytime buttocks is a safer option. So whenever there's complete or frank breech, please hold the buttocks. And as in footling, as soon as you approach the buttocks, hold them. In sacrum posterior position, in case it's a very rare position, you need to rotate it anteriorly and then you need to proceed further once you get hold of the buttocks. And the only thing I think I wanted to show you in this is the maneuvers are similar, that the position of the baby, if you can look in this image in the left, is flat. It's basically, you do not have to extend it up, which is a normal tendency because it will cause extension and it may also cause cervical spine injury. And the delivery of the head can be by modest belly beat, but it can also be by Brack maneuver. Brack maneuver is when fetal trunk is dorsiflexed and elevated and rotated in an arc, where the uterine incision is serving as a fulcrum. So basically, you are rotating the head against the uterine incision like an arc. I think this is something we have all done in our patients while doing a cesarean. We all know. Now, what are the specific conditions for emergency cesarean breech birth? What are the specific things we need to look for emergency cesarean breech birth? That is a non-reassuring fetal heart. Is often there due to cord compression or prolapsed cord. So I will discuss that, but then you need to expedite the cesarean. Sometimes you're doing it in emergency cases, patient is already in labor and the part, your breech or buttocks have descended sufficiently down, she's sufficiently dilated. So during cesarean, you may have difficulty and you may need to ask your assistant to push your presenting part from below. And this forcible may cause tear in the incision line, may cause extension, it may cause bleeding. And because of this traumatic handling, you could have injuries and fractures to the baby. That also can be there. The head may get entrapped, incision to J or inverted E shape. Always give a sufficient incision and breech. Never compromise on the incision. Then, if the fetus is in the transverse or it's an oblique, basic principle is you grasp the foot, and once you get hold of the buttock, you do it. And grasping the foot basically on the lateral and medial side. Sometimes what happens is that the uterine lower infimus is extended. It gets extended. So your incision may act in a much lower position than the cervix or vagina, and this fetus may get injured because of thin. You may actually give a nick on the fetus if the myometrium is too thin. So you have to be very, very careful when it comes to emergency cesarean birth. We should be aware of this complication. And just a little mention about the cord prolapse. Basically, sudden bradycardia, you can identify cord may be coming out. So you must manually relieve the cord compression with the hand, and retrograde filling of the bladder is important. Patient should be lying supine, foot end could be elevated, and you should take the patient directly to the OT like that. Please do not remove your hand, or if you're filling your retrograde bladder, and take her directly, and do not use gauze or something because that may cause stimulation. Just talking about the neonatal outcomes. For breech, we all know that congenital anomalies are increased 4.4% versus 2.4% in the vertex. Even mild deformities like frontal bossing, prominent occiput, upward slant, rosette ears, torticollis may be there. Fetal distress, the odds ratio is 2. Studies have shown brachial plexus injury, birth asphyxia. These may also be found. And for what does it mean for the mother? For the mother, it means prolonged labor, premature rupture of membranes, and postpartum hemorrhage. These are all the complications we have, and obviously higher operative interference that goes without saying. With this, I want to thank, and I want to thank my team at my unit in charge, Dr. Renu Arora ma'am. And my team at Subdivision, my team of residents who had helped me make all these videos. Thank you.
Thank you, Dr. Garima ma'am, for sharing your such an informative and elaborate slides on vaginal breech delivery with all of us. I hope all the.
Is there any questions? The time is up. I didn't see the time. I'm sorry.
I don't think there is any question in chat box.
Any questions? I would be happy to take.
Any students, if students who have joined us today, if you want to ask some questions. I don't think they have any questions, ma'am. Okay. So thank you, ma'am, for sharing your informative and elaborative slides on breech vaginal births. And I hope all the PG students are now more clear about breech vaginal delivery.
Your voice is not audible.
Hello, am I audible now?
Not audible.
Vinod, can you hear me? Prakash?
Yes.
Am I audible?
Yes, you are audible.
Hello?
Dr. Garima, can you hear me?
Yeah. Was I audible?
Yes, ma'am, you are audible.
Okay.
Thank you, ma'am, for sharing your informative and elaborative slides on vaginal breech deliveries. I hope all our PG students who have joined us today are now more clear about breech vaginal births. Thank you, ma'am, for joining us today and for giving your valuable time.
Thank you so much.
Thank you, ma'am. So next, we will have a case presentation on Rh negative pregnancy. And for the moderation, I would like to invite Dr. Professor Deepika Dekar, ma'am. She is consultant fetal medicine and genetics OBGY at Cloud9 Hospital, Gurugram. Currently, she is president DGF Dwarika. She was former professor and unit head OBGY at AIMS, New Delhi, Vice Chancellor SS University of Health Sciences, Government of Assam, and Director AIMS Kalyani, Kolkata, West Bengal. Welcome, ma'am. And next, I would like to invite Dr. Jaya Chawla, ma'am. She is Associate Professor, Department of OBGY at Dr. RML Hospital. She is member of Genetic and Fetal Medicine Committee, FOXY, Executive Member, Society of Fetal Medicine, Delhi Chapter. She has presented multiple national and international publications, chapters, and guest lectures. Welcome, ma'am. Now I would like to invite our two PG students, Dr. Aarti. She is our primary DNB first year student, second year student, and Dr. Preeti, who is our secondary DNB student. Dr. Aarti, Dr. Preeti, are you there? Dr. Aarti, Dr. Preeti. Dr. Aarti, have you joined us?
मुझे gestation sac size चाहिए बाहर वेट कर लो मैं बताऊँ
child है 8 weeks
नहीं measurement में
28.6
Dr. Aarti, say hello.
Dr. Aarti, Dr. Preeti, please start your case presentation.
Dr. Aarti, unmute yourself.
Good morning, good afternoon, Dr. Deepika. Nice to see you here, ma'am.
yes
You start.
yeah
मैं screen कैसे share करूँ?
You can take off your mask, Dr. Preeti.
Ma'am, I'm Dr. Aarti.
Ha, Aarti.
I think you can start your case presentation, start sharing and start your case presentation.
Yes,
You need to slide share, Aarti. You need to share your slide. Screen share पे चले जाओ.
ma'am, हुआ क्या? Share हुआ?
Screen already visual. Make it full screen, ma'am.
Full screen कर दो बस उसको.
Ma'am,
Yes, we can see it ना. चलो, just start your presentation.
ma'am, screen दिख रहा है?
Yes, we can see the screen. लेकिन screen भी ना color ऐसा हो रहा है जैसे कि पढ़ाई नहीं जा रहा है. We are not able to read.
Next slide लगा दो जो next slide.
हाँ,
Please
now
get
we
to
can
the
see
next slide.
Mrs. X. Yeah.
Good morning, ma'am.
Hello,
Good
Dr. Jaya. Yeah.
Hello, ma'am. Good afternoon, I'm Rekha.
Yeah.
Ma'am, my name is Dr. Aarti. I'm primary DNB second year from Ganga. So my patient is Mrs. X. She's 26-year-old resident of Mayur, Bihar. She's 10th pass, a homemaker, and wife of Mr. A, who's engineer. They belong to middle socio-economic status. At present, my patient is G2, P1, L1 with 38 weeks of POG. Her LMP is 24 August 2022. Her EDD is 31st of May 2023. Her blood group is O negative. Husband's blood group is B positive. She is admitted at present for safe confinement. So history of present illness. In first trimester, her pregnancy is a spontaneous conception. She was diagnosed pregnant by UPT, followed by confirmation by dating scan. During her first trimester, there was no history of nausea, vomiting, fever with rash or bleeding or spotting PV, drug or radiation exposure. History of folic intake was present. Her NT-NB scan was done, which was normal. Dual marker was low risk for aneuploidy scan. Baseline investigations were normal and ICT test was done, which was negative. For second trimester, quickening was felt at 5th month of gestation. Anomaly scan was done, which was normal. OGTT was done, which was normal. First dose of TT taken according to the patient. She took iron, folic acid, and calcium regularly throughout the second trimester. There was no history of bleeding or spotting PV throughout the second trimester. Third trimester, perception of fetal movement were present. Growth scan was done, which was normal. History of iron and calcium intake was there. Repeat ICT was done at 28 week of POG, which was negative. There was history of intake of anti-D 300 microgram around 28 to 30 week of gestation. History of injection Tdap was there, present, which was taken at 32 week of gestation. Throughout third trimester, there was no history of bleeding or spotting PV. Her menstrual history, she had her menarche at 40 years of age. Her menstrual cycle were regular around every 28 days. She used to bleed for 4 to 5 days, which her blood flow was average and her cycles were painless. Her LMP is 24th August 2022. Her EDD is 31st of May 2023. So according her POG is 38 weeks. She is married at 22 years of age around 2017. It was non-consanguineous monogamous. Her obstetric index, she is gravida to para when cohabitating with husband since marriage. Conception never used. Past obstetric history. First pregnancy at 24 years of age. Throughout the first pregnancy, all the trimesters were uneventful. Anti-D was taken during her first pregnancy around 28 to 30 week of POG, which was 300 microgram intramuscular. She delivered vaginally, female baby. Her birth weight was 2.5 kilos. Baby was alive and healthy. No postpartum complication after delivery. Her first baby blood group was B positive. Postpartum anti-D was given, which was 300 microgram within 72 hours of delivery. There was no history of any blood transfusion. Her past history, no history of hypertension, diabetes, or TB, or repeated blood transfusion. Surgical history, there was no history of any previous surgery. Personal history, she had normal bowel and bladder habit, normal sleep pattern, and no adverse social habits. On the basis of 24 hours recall method, her daily calorie intake was 2,250. Her protein intake was 56 grams. Family history, known case of diabetic since 20, her father is a known case of diabetic since 20 years on treatment. Socioeconomic history, husband is a graduate working in private sector belonging to middle class of on modified Kuputswamy scale 2020. General examination, patient is conscious, oriented to time, place and person. She is moderately built and nourished. Her height was 160 centimeter. Pre-pregnancy weight was 55 kg. Her BMI, according to pre-pregnancy weight, was 21.5. And her current pregnancy weight is 64 kg. So her weight gain throughout the pregnancy was 9 kilo. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or pedal edema. Her breast examination was no abnormality detected. Thyroid, there was no enlargement present. Her teeth, gums, tongue was normal. Spine was normal. Gait was normal. Her respiration was 16 per minute. It was a normal abdominothoracic. Her BP was 120/80 in both the arm in sitting position. Her pulse was 82, which was regular, good volume. All peripheral pulse were palpable. There was no radiofemoral or radio-radial delay. Her temperature was 97.6 degree Fahrenheit. She was afebrile to touch. Now CVS S1, S2 was heard. There was no murmur. RS bilateral air entry equal, no added sounds. And then her cranial examination was within normal limit. Obstetric examination. Her abdominal was longitudinally distended. Flanks were full. Umbilicus was midline, everted. Linea nigra stria gravidarum present. There was no scar, no sinus, no dilated veins seen. All quadrant move equally with respiration. Hernial sides were normal. Her uterus fundal height corresponds to 36 weeks of gestation. There was flank fullness. Symphyzofundal height was 36 centimeter. Abdominal girth was 37 inch. Fundal grip was broad, soft, non-ballotable. Fetal part probably breech felt. Lateral grip, right-sided multiple small nodules, probably limbs. Left-sided smooth curvilinear with uniform resistance felt, probably back. First pelvic grip hard around fetal, hard round fetal part felt in lower pole of uterus. Second pelvic grip, finding of first pelvic grip is confirmed, head engaged. Auscultation. FHR was in left spino-umbilical line. Fetal heart rate was 150 beats per minute, which was regular. Her local examination, external genitalia was normal. There was no leaking or no bleeding PB. So my patient, Mrs. X, she's 26 years of age, G2 P1L1 at 36 weeks of gestation, O negative blood group, admitted for safe confinement. She is perceiving adequate fetal movement. There was no history of labor pain or leaking PV. Her previous pregnancy was uneventful. She delivered vaginally a term baby, and she gave history of receiving IM anti-D after delivery. Her which was given on second day of delivery. On examination, there was no pallor, no pedal edema. Her BP was 120/80. Obstetric examination reveals single live fetus in cephalic presentation. Liquor appears adequate. Uterus is relaxed. FHR was 140 beats per minute in left spino-umbilical line. Provisional diagnosis is 26 year of age, G2P1L1 with 38 weeks of POG. She is RH negative, non-immunized pregnancy with single live fetus in cephalic presentation with head in lower pole of uterus, not in labor. Thank you, ma'am.
Okay. Yes, well presented. And so what is the problem in your case?
Ma'am, her blood group, which is O negative.
Okay. Anybody wants to ask any question? Is there a provision for others to ask her any questions in the chat box? I think people can ask any questions related to the, so far she has done the history and the examination. So if anybody wants to ask any questions, they can put it in the chat box. So, right. So then you can complete. How are you going to manage?
Ma'am, we have admitted her for the safe confinement since there is no, she's non-immunized, and which for her we can plan induction of labor around.
No, why are you admitting her?
For planning induction of labor.
For planning induction. Why do you want to induce her?
Ma'am, first we will get her all baseline.
Why you want to induce her?
Ma'am, because after 37 weeks, there is an increased chance of fetal-maternal hemorrhage in Rh-negative pregnancies. So we will be inducing her.
Okay. So you want to induce her at 38 weeks. She's 38 weeks, no?
Yes, ma'am.
Yeah. So what are you going to do for the induction, before the induction?
Ma'am, we will get all the baseline investigation, CBC, PT, APTT, arrange adequate blood, and we will also.
Why do you want blood?
Ma'am,
do you arrange blood for every pregnant woman?
Yes.
Or specifically you want to keep for her?
Ma'am, we will specifically keep for her.
Why? Is it she is at risk of PPH?
Ma'am, yes. All the Rh-negative pregnancies are risk of PPH if since there is increased risk of polyhydramnios and preeclampsia.
Why should there be polyhydramnios? Why should there be polyhydramnios?
No, my patient doesn't have any risk of PPH.
Yeah, you said no, you will arrange blood. That's why I'm asking.
In our institute, we arrange blood for all the pregnant female who are in labor or who are going to get delivered.
Okay, so just as a routine.
Yes,
no. Anything special about her arrangement of blood? She's Rh negative, na?
Yes.
So you have to specify that we need Rh negative blood.
Yes, ma'am.
Yes. Okay. So what else you will do before you induce her, which is different from the Rh positive patient?
Ma'am, we will, before induction, we will check her Bishop and everything. If Bishop is less than 6, we will try to give her a prostaglandins. If Bishop is more than 6, we will try to give oxytocin followed by ARM.
I couldn't hear the first line.
Ma'am, before induction.
Bishop's is?
If Bishop is less than 6, we will give her prostaglandins. If Bishop is more than 6, then we will give oxytocin followed by ARM.
Okay. You know, in earlier days, we used to do stripping of the membranes. If you find that the os is open, you know, good Bishop score, will you do a stripping of the membranes?
No, not in this case, ma'am.
Acha, why not in this case?
Ma'am, for all the Rh negative female, we should always be gentle in order to avoid fetal-maternal hemorrhage.
Yeah, in order to avoid fetal-maternal hemorrhage. Huh? And you said already that you don't want to go post-dated because there is a higher risk. So did she get antenatal anti-D?
Yes, ma'am. She was given, yes.
Yeah. So how she got it at 28 weeks?
Yes, ma'am.
She got it at how many weeks?
28 weeks, ma'am.
So how long that will cover?
Ma'am, that will protect her for 4 weeks. Her T-half for anti-D is 4 weeks.
She got how much of anti-D? 300, no? Yeah. So how much she will, how many days does it cover or how many weeks? A prophylactic anti-D given at that covers to...
Ma'am, it will protect her till delivery.
Suppose delivery occurs second day, next day, the day you gave her, it has to be a certain number of days, weeks.
Ma'am, T-half of anti-D is 24 days. So it will protect her around for 4 weeks. So if she delivers next day,
anybody else wants to see, anybody else wants to answer? I don't think this answer is correct. I can see somebody is writing.
Yes, in the chat box, ma'am. There's a
chat box. Somebody is asking, somebody is saying, I wish to see that person actually. It is 12 weeks. At least 10 weeks to hai hi. It's the answer should not be that till delivery. Okay? In fact, let's say that you have given the NTD today and the patient goes into labor 4 days after you have given. Will you repeat her NTD?
Ma'am,
RH positive baby. After delivery, you will realize that the RH is positive.
Ma'am, if she goes in labor and delivers after 4, we will repeat in that case.
No, I said after 4 days.
No, ma'am, no need to repeat because
So till when you will not repeat?
Until 24 days, because the T half is 20.
Left side person, we can't hear you.
Hello. Hello. Ma'am, am I audible?
Yes.
Yeah, ma'am.
So this injection of NTD will last for how long?
24 days, ma'am. It has a T half-life of 24 days.
24 days is how many weeks?
Around 3 weeks, ma'am.
3 weeks, 3 to 4.
Anybody else wants to add? If it is 24 days and if you're giving at 28 weeks, then you will again have to give now later. You will have to give again after 3 weeks.
No, ma'am, the half-life is around 24 days and the action is still 12 weeks.
So 3 weeks is not half of 12 weeks. Anybody wants to say anything? You're Aarti and you.
Dr. Aarti, ma'am.
Yeah. So,
Yes, ma'am.
No, that's not. Supposing a person delivers after 3 days and you don't give it. See, it acts for about 10 weeks. That's why you give it at 28 weeks. Yes, 28 or 30 weeks so that you can go up to 38 weeks. Okay, yes, I can see a question in the chat box. Why induction at 38 weeks?
Because
can she go to term?
Ma'am, it increases the risk of fetal maternal hemorrhage as the pregnancy progresses.
Yeah, so generally we do not go up to term. So we try and induce if the cervix is nice and favorable. Bishop's is good, we try and induce. Okay?
Yes, ma'am.
Okay, any other reason, any other condition where you will give the anti-D before the 28 weeks?
Ma'am, if she lands up in any episode of the vaginal bleeding.
Any abdominal trauma, ma'am.
Okay. Which sort of vaginal bleeding? Cause of the vaginal bleeding? Which trimester?
Placenta, due to low-lying placenta.
Okay, so she has a placenta previa, she's bleeding. So at what weeks placenta previas can bleed?
28 weeks, ma'am. 26.
Supposing she bleeds at 25 weeks, she has a central placenta previa, what will you do?
Ma'am, we will do the ICT again. And then if it is negative, we will give her anti-D injection.
Okay, and when will you give the next one?
Ma'am, if she bleeds in less than 24 days, we don't need to give. But if she bleeds after 24 days, the T half has gone. So we will repeat again, depending on ma'am.
Where did you read this?
Yeah, can you please quote the source in this case?
Anybody who wants to write can write in the chat box, okay? And supposing she keeps on trickling, bleeding. Dr. Jaya, you want to ask something regarding this?
Ma'am, just the same question as to what should be the interval at which it needs to be repeated in case of ongoing hemorrhage. As of now, this only, ma'am.
Okay, there are some questions in the chat box, question answer. One of them is, how can we comment on the immunized status based on history?
So we can take it. No, the question says based on history. So what in the obstetric history or otherwise will compel you to believe that this woman should be immunized?
on the immunized status, whether she is immunized or non-immunized. Anything in the history?
The hint
Okay,
is
I'm going to
obstetric
make it
history.
simpler. I'm going to make the question simpler. How can you know from the history whether a woman has RH isomnization?
We will ask her any episodes of bleeding throughout the pregnancy or abdominal trauma.
That will tell us whether she's RH isomnized.
We are trying to suggest that something in the previous obstetric performance has something to do with this, not the current pregnancy. So maybe you could look at the previous obstetric
In the current
experiences she has had.
pregnancy, what will tell you that the mother is probably immunized? Iso-immunized.
We will ICT test, ma'am, in case.
Yeah, besides ICT test, from the history and maybe,
Can a history of previous losses give you a clue?
Yes, ma'am.
So yes, can we elaborate upon that?
Ma'am, if she is immunized in previous pregnancy, we should try to take history of previous pregnancy if there was any IUD, if like if intrauterine death, if there was any history of fetus that delivered look edematous or anything in the previous history about the how did the fetal look after birth and
okay, anything else?
History of preeclampsia in previous pregnancy or
Preeclampsia, how will that tell you whether the woman is iso-immunized?
Ma'am, no, because polyhydramnios, preeclampsia, all this increase RH negative pregnancy increase the risk for all this.
But those are, that's not really specific.
Yes,
specific reason.
Specific, ma'am, but it increased the woman towards.
Maybe, but it is not specific. Think of another, any other thing in the history. This is a very intelligent question. From
Previous
the history, you have to know previous history of
blood transfusions or any undisclosed pregnancies.
To whom?
To the.
No, that is increasing the risk. How will you know that the mother is immunized, iso-immunized? What thing in the history will tell you that the woman is having RH isoimmunization? You said previous history of hydrops, previous history of IUD, IUD, any other history. As a PG, you got to know, do a thorough history.
Her, if she was given anti-D injection during previous pregnancy or after delivery, and
no, if she was given, like your patient is given, so does she become iso-immunized?
No, ma'am.
You had a hint there when Madam said, you said history of transfusion, and Madam asked to whom. That was a hint for your question.
Ma'am, previous history of intrauterine transfusions.
Yes.
Okay, intrauterine transfusion or previous history of neonatal transfusion.
After birth, previous history of
what else? What happens to the baby which is RH isoimmunization after birth?
Ma'am, after birth, if there was phototherapy given, if there was hyperbilirubinemia,
severe jaundice,
severe jaundice,
pathological jaundice,
exchange transfusions.
And if the jaundice
so from the history, you need to know very detailed, very thorough history like that. Second question was, what of the relevance of saying monogamous in obstetric history? Anything to do with monogamous?
Ma'am, paternity, to be sure about the paternity.
Okay, what?
What is the bearing of the partner status in this case?
Though it is a question which is somebody, I think, just wanted to say that what is the problem? Why do you have to say monogamous? But in RH, this is important. Why?
Yeah.
Because we want to be sure about the paternity.
Very good. Why? How will that affect?
Ma'am, because if mother is RH negative and the father is RH positive, then we have to think about the series of investigations and anti-D injection. If the father is negative and mother is also negative, then there is no
problem, huh? So whether though in our country this is not a very common thing, but yes, you know, if the father is In what other, since you are going the master of RH negative and all, in what conditions we will actually tell the mother that she should conceive with an RH negative partner? In what condition? Actually, I had a condition just yesterday. Yes. Which cases?
Ma'am, if mother is negative in that case,
Mother is?
Ma'am, ma'am, you were trying to say if the mother is negative and we should tell her to conceive with negative partner.
Yes.
Ma'am, if previous bad obstetric history, ma'am, wherein there was intrauterine transfusion, or during the first visit only there was a very high ICT titers and bad
But she's
obstetric.
already pregnant now, na? In this pregnancy, ICT titer high, abhi kya karoge? Hai na? We are talking about partner before pregnancy.
It's kind of prenatal counseling, you can say.
Yes, in case if there was history of bad obstetric history in the past pregnancy, then only we will promote her to.
Bad obstetric history could be because of anything, na? It could be because of PIH, it could be because of GDM. Be more specific.
If she had previous IUTs and then also the fetus was not revivable, or the fetal condition was not satisfactory at birth, even after trying all the measures like IUT, IVIG, so we can tell her to perform.
So if you have, in fact, I had in my whole life of doing more than 1,500 intrauterine transfusions, only once I told one patient to have an IUI with an RH negative donor. Because I tried IUT in 3 times, and 3 times they happened very, very early. It was very difficult. And yesterday I got one patient. She is RH isomnized and she's not pregnant. She's going to have an IVF. And she's asking, do I need an IVF to be done by donor sperm, a person who is RH negative? It's almost like, partner being RH negative. What do you say?
Yes,
you will encounter situations like this.
Yes, ma'am.
I'll give you the next one. Yeah, tell me.
Yes, ma'am. She should go undergo an IUI with a donor who is RH negative, because she has a history of severe isoimmunization, and the fetal outcome were not satisfactory. That's why we can suggest her.
Anything else you can think about?
Ma'am,
They
she
want
could
their
be,
own biological child.
ma'am, she could be something like not antibodies against anti-D or KEL antibodies or something, like which are very rare.
No. She's RH isomnized.
We're talking of D. We're talking of D only.
She's coming to me that I want my own biological child, but I don't want the risk of transfusion.
Plasmapheresis, we can try giving IVIG.
Those will happen after she's pregnant, na? Anything before the pregnancy.
Ma'am, we need to check the zygosity.
In this era of technology, is there something that you can do? Ensure that the baby is RH negative.
Ma'am, if the father is homozygous, then it will ensure that.
Heterozygous.
And we need to check the paternal zygosity. If it is heterozygous, 50, we can counsel that 50% chance the baby will be positive.
Said that there is no, she doesn't want to take the risk of a 50%.
See, you have the risk, you have the input of in vitro fertilization. Please focus on the details. You're giving
too many details, too many hints.
I'm just helping them out.
Okay, Jaya has given you a very big hint.
Prenatal genetic testing we can do.
For what? People are doing that nowadays.
Yes, ma'am. NIPS.
NIPS is after conception. Madam was concentrating on the prenatal, conceptual part of it.
Because somebody's asked, no, monogamous. So we are talking about now poly. Have you heard of PGD?
Yes, ma'am.
Ah, okay. I've given you a bigger hint. Now tell me.
And before implantation, we check the zygote for the before implanting.
So in this case, what you're going to check?
We will check, ma'am.
She doesn't want an RH positive baby. She wants RH negative baby.
Yes, ma'am.
You will do the RH in the PGD. Okay?
Yes, ma'am.
Go to the next question. We will reserve blood as it is tough to find negative blood. Yes. You will reserve blood. That's why you're doing the blood grouping, and you will tell the blood bank, I want negative blood.
Yes, ma'am.
Which negative blood? For whom?
For the mother.
For
the mother.
Mother, not baby?
Ma'am, baby, for baby, we will do if we need intrauterine transfusion.
No, you're delivering. Your case is going to have a delivery.
Yeah, ma'am. For the
38 weeks. Yeah.
Ma'am, for the baby, from the cord blood, immediately we can know the hemoglobin, bilirubin, everything.
No, the question is, will you arrange blood for the baby?
Yes, ma'am.
Which type of blood?
O negative, ma'am.
Yeah, and O negative is a donor. But of course, after the delivery, because we will only need to give transfusion to the baby if the baby is RH positive.
Positive, yes.
No?
Yes.
Yeah. So you can, after delivery, there is no problem. No?
Yes,
You can give compatible with the patient, with the baby's blood also. That can also be given in this case.
Okay. Somebody is saying ICT test. How often should you do the ICT? In a non-immunized RH negative woman.
According to the guidelines, we should do it on the first ANC visit, then repeat it after 28 at 28 weeks, and if there is any
supposing she had a bleeding, episode of bleeding at around 16-18 weeks, and she had a lot of fetal-maternal hemorrhage, what might happen to the baby or to her ICT?
We'll do the ICT again, and if it is because
can a bleeding can occur without any symptoms? Fetal-maternal hemorrhage.
Yes, ma'am. Fetal-maternal hemorrhage can occur without bleeding.
So what will happen to her ICT?
Ma'am, it can turn out to be positive.
Yeah, so 28 weeks may be too late. That is an old, advice. The present advice is you should do ICT every month. You have treatment now, no?
Yes, ma'am.
Yeah. Okay. You found that at 18 weeks, ICT has come 1 in 16. What are you going to do?
Ma'am, every laboratory has their different parameters.
Pardon?
Ma'am, then we'll do middle after 18 weeks. We can monitor once the ICT is positive.
Now you will treat her like an RH isoimmunized patient.
RH isoimmunized.
Okay, so you can have RH isoimmunization during pregnancy.
Yes, ma'am.
Okay, during pregnancy. So
yes,
if you wait till 28 weeks, keep 28 weeks, it might be too late.
Yes, ma'am.
Okay, because the index pregnancy is the best chance to save the baby. So it can happen. Okay. Yeah. Another question was, how long is someone said 6 weeks, someone said 12 weeks, and again Priya is saying 12 weeks. And Soni Kumari is saying no. I don't know why she said no. Okay. Somebody, Soni Kumari is saying, Madam, uncomplicated RH negative to be terminated at 40 weeks. Yes or no? We already discussed this, that we don't like to wait for so long. Okay, after you have given the anti-D, will you repeat the ICT?
No, ma'am. We will not repeat because it will be positive because of the anti-D injection.
How positive? How much?
It will be weekly positive.
How much?
1
1
is
is to 2, 1 is
to
to 4.
See, you have to be more specific. You know, some of our labs, they only say ICT positive. Is that enough?
No, we need to know the titers also.
You need to know the titers, isn't it? Yeah.
Yes, ma'am.
Okay. Somebody said, see, history of jaundice in the previous pregnancy. Very good. History of hydrops in the pregnancy. This will tell us whether the patient is immunized. History of abruption, previous abortion, not received anti-D, PPH effect on baby. So these are the high-risk factors. Okay. Okay. Dr. Jaya, you want to ask?
Yes, ma'am. So somebody did not come to you at 28 weeks. This lady reported to the hospital a little later.
Yes, ma'am.
Now she wants to inquire about her eligibility for an antenatal prophylaxis.
Yes, ma'am.
So what would be your criteria to decide now? Is she eligible? Is she not eligible now?
eligible, ma'am.
Up to what period of time?
Ma'am, we will do her ICT. If it is negative, we will give her anti-D immediately.
See, that is a very clear idea. Until and unless the indirect Coombs test is negative, she is not eligible for a routine antenatal prophylaxis. The next part of the question is, until what period of gestation is she eligible for this? If she comes at 36 weeks, should we give her anti-D?
Yes, ma'am.
Yes, ma'am. Or there is an upper limit cutoff beyond which this will not help us.
Whenever we,
Ma'am, after 35 weeks, the ICT becomes less reliable.
See, as per recommendations, because at postgraduate level, you should be talking of recommendations. So as per the current FIGO recommendations, what is the upper limit? Let me reframe the question like that. They are the by far the latest guidelines we have on the topic. So maybe you can quote those. Again, I'm trying to lead you to the answer. So maybe it comes out from you. I'll be happy with that.
36 weeks.
Well, as per those guidelines, it's 34.
Yes.
As per and the guidelines I said so, that will be 34. Now, the next thing is, this lady, you said middle cerebral artery, you were trying to go to that after madam said 1:16 titer.
Yes,
so can you elaborate upon how do we do these Dopplers? You have any idea about that?
Ma'am, the principle is that whenever the fetus has anemia, her fetus circulation become hyperdynamic, the more blood goes to the brain in order to protect the brain. At the same time, there is decrease in blood viscosity due to anemia. So whenever we do middle cerebral artery Doppler, there will be increased blood flow that will be depicted in terms of moms. So if the middle cerebral artery Doppler more than 1.5 of moms, that means there is a significant fetal anemia and we should try to do the intervention as soon as possible.
Okay, so let me again come to a practical point. Supposedly a lady came to you for middle cerebral artery Dopplers. This lady is 24 weeks of pregnancy and the middle cerebral artery is 52 centimeters per second. The velocity that you talked about, I'm giving you the velocity. Now, how will you decide whether this is 1 mom or 1.25 mom or 1.5 mom? How will you decide that?
Well, we have a like fixed pre-decided chart, so we should try.
What is the name of the chart? Who gave us that chart? Because most radiologists will offer us reports like so many centimeters per second.
Yes.
So what will you type on Google to say how many moms is this? You may not remember the chart, but how are you going to look for it?
Who was the person who started? I think, Jaya, you'll have to teach them.
That's Mari's chart. And there are certain names which have created history, so they should be remembered.
Yes, ma'am.
Right? So, supposingly now she has crossed 1.5 multiples of median.
Yes,
and this is an opportunity for you to learn, because madam is the god of that intrauterine transfusion thing. So the question is, now madam, you are assisting madam for an intrauterine transfusion. Madam says arrange blood.
Yes, ma'am.
So what will you do now? You will go to the blood bank, fetch O negative, whatever you get, and say, here is it, madam? Or do you say that there is a difference between the blood that you transfuse to a mother or a blood that you transfuse to a baby?
It should be freshly packed PRBC, which should be O negative.
But see, hang on. See, everything, God is in details. So when you say fresh, abhi ke abhi kisi ka blood nikal le? How many hours is permissible? Be very clear about this.
Yes, ma'am. 7 to 10 days. Freshly, matlab, it should not be old blood. Within 7 to 10 days extracted.
Again, you will have to quote the source, beta, when you give us an answer like that. Tell me, where did you read this? All right, we will come to this later. So one is the duration, right? How old or how fresh the blood should be. The second thing you said was
O negative, irradiated.
O negative, irradiated. Irradiated. What? There are so many radiations on this
You will
planet.
have to tell us also why
irradiated.
fresh, why irradiated.
Yes.
Post response. Ma'am, and the fresh blood has more of 2D, this DGP, which helps in ATP and everything.
What happens to blood which remains stored in the blood bank for a very long time? There must be some blood components which get affected. Again, that is a hint for you.
Hemolysis, ma'am, and there are increase. Ma'am, there is blood. There is increase in 2D TGP, which causes.
Beta, I am getting the point of what you are saying, and I'm still saying something else.
Hemolysis.
2,3 DGP, I can understand. Now I am asking you, what happens to blood components on prolonged storage? Achha, okay, fine. There is a lady with thrombocytopenia. Do you give her old blood? You insist upon fresh blood for those cases also when you give transfusion to the mother. So now let us just copy and paste that idea to the fetus and decide the answer.
Yes, ma'am.
Why do you need fresh blood?
Ma'am, because old blood will have some hemolysis going on.
Arey beta, come out of the RBC thing. It is the platelets. Which is why thrombocytopenia was given to you. Okay. Okay, now which radiation? You said some irradiation has to be done. What irradiation? And why? Because madam has said everything has to have a justification.
Ma'am,
So,
we will the blood under radiation to kill irradiated to reduce the WBC in order to prevent graft versus host response.
see, beta, do not get confused with gamma irradiated and leukodepleted. These are two different ideas. Okay. So first of all, gamma irradiation. The answer to the first part was that. And the second part is why gamma irradiation?
To prevent graft versus host response, ma'am.
Now the third thing you said was leukodepleted.
Yes, ma'am.
What will happen if we do not leukodeplete it?
Ma'am, it will stimulate the immune system to cause reaction, leukocytes.
Okay, anything else that we require?
Ma'am, viruses, we should also check for the viruses.
Which specific virus are we talking? Or we should check for just about, because blood banks have a standard protocol. They check for a couple of things already for every pack they have.
Usually we check for all the viruses, but specifically CMV, ma'am.
Okay. Okay. And is there anything else that is very, very pertinent to intrauterine transfusion?
Ma'am, the speed at which we give the transfusion.
The speed is operator dependent. I am saying when you request the blood bank for something, and we are still at the blood bank taking blood. Should it be very dilute or should it be very concentrated when you are giving it to the fetus?
How much should be the Paxil volume?
Should it be a higher than normal thing or a lower than normal thing? Let's come to that. That'll be easy.
Lower than normal.
Lower than normal, viscosity. Concentration, what are we trying to suggest?
Higher than normal.
See, what do you give a person, adult, who is very severely anemic, what type of blood you give? Or a pregnant woman in labor, severe anemia, 5 grams, what sort of type of blood you give?
PRBC.
Pack cells, huh?
Call it pack cells.
Yes, ma'am. Yes, ma'am.
Pack cells. So
Yes,
in the fetus also, you don't want to give too much blood. You want to increase the hemoglobin. So how much should be the hematocrit?
ma'am, in the RBC, the packed blood cell which we will give the hematocrit should be around 80 to 90%.
90 is going to be like toothpaste. So at least, 75, 75 to 80. Okay. Then where do you give this blood?
Ma'am, we will give it towards the on the umbilical vein towards the placental side.
So why don't we
Any
give it in
other
the
place?
artery?
We can give in umbilical artery also, and hepatic vein also in case of difficulty.
Who said umbilical artery? Why do we avoid umbilical artery? Why we prefer vein instead of artery?
Ma'am, because of the ma'am, it is because of the diameter we can easily.
Yeah, I think Jaya, we might be asking two very technical. Let's go on to simpler questions.
Yes.
And we'll ask this sort of questions in fetal medicine presentations. So,
yes.
Yeah. So, but then you must know a little bit about all this. So you know that we give transfusions to the anemic fetus. What would be the indication of giving an intrauterine transfusion?
Ma'am, first middle cerebral artery Doppler, if once it is more than 1.5 median of moms, the next step will be doing chordosynthesis, and we will send the fetus blood to know the hemoglobin hematocrit. Once the hematocrit is less than 30%.
No, I was okay. So I just wanted to say that you will do middle cerebral artery, and then you will do chordosynthesis, and then you will wait for the report to come.
Ma'am, we can start.
Okay, you can just let us skip that part. It's too technical. So you will do if the hematocrit is less than 30.
Yes, ma'am.
Okay, fine. Any other? You see hydrops? No, that is more. So if there is hydrops on ultrasound, then this is a fetus which is definitely very, very severely anemic.
Yes,
and you will need a blood transfusion. No?
Yes, ma'am. Yes, ma'am.
Earlier days, do you know the history where there was something called amniocentesis, spectrophotometry?
Yes, ma'am.
You have any idea about it? Though
yes,
it may be historical, I still know that some places people do that because they're able to do it. And then they do the amniocentesis and refer after that. What is done?
Ma'am, we used to do amniocentesis. We used to take out the amniotic fluid, and we used to chart it as photospectrometer, wherein we used to see a deviation bulge at 450 of wavelength. And then we used to plot it on the Lily's chart, which used to give us zone 1, 2, and 3. Depending on that, we have to decide whether to transfuse or how to monitor also.
Any other charts you know of? One is Lily's charts.
Quinon's chart has also come. Basically, Lily's chart is used only after.
Has also not come. It has been there for
very long.
30 years. 40 years.
Basically, Lily's chart allows us to chart after 27 weeks of gestation. But Quinon's chart helps us to chart after 14 weeks of gestation also. 14?
No, we never do IUT so much. When does the fetal reticuloendothelial system develop? There was a very interesting question about PGD and when actually the RH group, the antigen develops.
Ma'am, antigen develops at 38 weeks of gestation, and reticuloendothelial cell becomes mature at 18. Ma'am, no, 38 days. Ma'am, 38 days. 38.
So the question was, can you do PGD so early?
Ma'am, yes.
Yes. Very intelligent question somebody is asking.
Yes.
You can do. There's lots of literature now wherein they are doing PGD. Okay, yeah. So coming back to your question.
Ma'am, reticuloendothelial cell develops around 18 weeks of gestation. Yes, ma'am. 18 weeks of gestation, 18 to 20 weeks.
It can develop. What exactly happens? When a woman is Rh negative and the husband is Rh positive and the fetus is Rh positive, what exactly happens?
Ma'am, basically the Rh antigens are the antigens which are present on fetal RBC. So whenever there is episode of fetal-maternal hemorrhage, that antigen crosses the placental barrier and it goes into mother circulation. They stimulate the mother circulation and immune system to produce the antibody against the D antigen. So first antibody which is produced is IgM, which is not going to cross the placenta, and so the first pregnancy is always safe. And the later antibody which is produced is IgG, which is small and it can readily cross the placenta. So after delivering of the first child, the baby is safe and mother has just stimulated her immune system and develop antibody. On the second conception, her immune system will recognize the antigen very fast and it will hamper and produce IgG antibody that will cross the placenta and it will cause hemolysis on the fetal RBC. So it will create a cascade of anemia and then hydrops and then hyperbilirubinemia, everything.
Okay, that is there. What about the fetus? What happens in the fetus?
The fetus will have.
Can a fetus become anemic at 12 weeks?
Ma'am, on the next pregnancy, fetus can become anemic depending upon if there was a large fetal-maternal hemorrhage or if the anti-D given on the first pregnancy was not adequate if it was inadequately.
No, the question is different. The question is, you said that the fetal cells will become, and then the immune system of the mother, the IgG comes in, but the cells are taken up by the fetal reticular endothelial system. So when is that formed?
18 weeks.
So
18
it will only happen after that, no, fetal anemia.
Okay.
Not 18 exactly. It can be any time from 15, 16 weeks also. I have seen fetal anemia occurring in even 14 weeks. Okay. Okay. So any other reason there could be that the first pregnancy is affected?
Ma'am, any history of previous blood transfusions or undisclosed?
Yeah, Rh positive blood transfusion. Any other thing?
Any undisclosed pregnancies?
Undisclosed pregnancy, even abortions. You know, a woman doesn't even know. She just thinks that I was overdue, and then many people don't know. And then the first pregnancy, I've seen so many cases where first pregnancies have been affected. What is grandmother theory?
Ma'am, grandmother theory is the one wherein mother, when she was herself a fetus, she was Rh negative, but her mother was Rh positive. So the antibody came from her mother to her during intrauterine life. When she became pregnant, she transferred that antibodies to her fetus during the first pregnancy itself.
Yeah, yeah. I have seen cases, you know, well, like that. Okay. What are the indications of giving anti-D before 28 weeks?
Ma'am, any episodes of bleeding PV? Any
yes, we were talking about it.
Trauma?
Yeah.
Accidental trauma?
Aarti, it would be great if you could organize your answer as a first trimester and a second trimester. That always gives a better idea.
Will you give in threatened abortion?
Threatened abortion, ma'am.
Yes.
Will you?
Yes.
Yes.
Okay. And if you have given it once at, say, 12 weeks, when will you give the next one?
According to RCOG guidelines, it is recommended to repeat like after 6 weeks.
6 weeks is a little too early. You repeat up to 10 weeks. But if there is bleeding, if there is no bleeding, you repeat up to 28 weeks. At 28 to 32 weeks. Okay. Well, nowadays we are doing a lot of amniocentesis, CVS. No? Don't you think? Do they need prophylactic anti-D?
Yes, ma'am.
Yes.
How much?
Ma'am, according to RCOG guideline, if anything done between 12 weeks, we will give 50 microgram. After 12 week, we will give 300 microgram.
You know how much anti-D is covered by 300 microgram covers? How much of fetal blood?
15 ml of fetal RBCs, ma'am. 30 ml of fetal blood.
And if it is more than that?
Ma'am, then we need to calculate it according to the KB test or There are multiple tests, Rosette test, which is a screening test, and then KB test will tell us the exact how much has fetal-maternal hemorrhage occur, followed by fetal flow cytometry, which is the best and the specific test.
So how much? How
Ma'am,
much extra?
Ma'am, we will take the maternal blood and we will give if we are doing KB test, we will mix acid phosphate, and if
No, I'm not asking you about the technique.
Madam is asking you to quantify the
How
dose
much?
of anti-D.
Supposing you find that it has excess, it is more than 15 ml.
1 ml, we will give 10 microgram. 1 ml of fetal blood or 0.1 ml of RBC will give 10 microgram of anti-D. 1 ml of blood or 0.5 ml of RBC is equal to 10 microgram of anti-D.
So you will give more accordingly. Okay.
So what is the mechanism of this anti-D? How does it help the mother or the baby for that matter?
Ma'am, basically, whenever mother's blood get anti-D, those anti-D will go and bind to the D antigen which has come from fetal circulation, even before it can stimulate mother's immune system to produce mother's antibody against the D antigen.
So, so you're talking about theory. You didn't answer the question. How will anti-D? You're giving the anti-D and there is some fetal-maternal hemorrhage. What will the anti-D do to that RBC?
Ma'am, it will hemolyze fetal RBC.
So you have to say that, huh?
Before that,
before it is able to excite an immune response.
Yes, ma'am.
Oh, you can't hear. Yeah.
What happens to conditions like ectopic pregnancies, molar pregnancies? What is your take on these?
Ma'am, we should always give anti-D in case of ectopic, partial mole, or in molar pregnancies.
So you are trying to suggest that we should give it to only partial moles?
No, ma'am, we should give to moles and ectopic pregnancies.
Okay, why should we give it to every molar? I'm sorry, ma'am.
Yeah, Jaya, go ahead.
So are we trying to suggest that molar pregnancies, all of them should receive anti-D? If yes, why?
Ma'am, because molar pregnancy, either they go in abortion or we do suction evacuation.
So we are very unanimous on the idea that we have to terminate these pregnancies. Yes, the only bone of contention is between partial and complete moles.
Yes, ma'am.
So do you agree that we should give anti-D to both? Or you want to be selective and give only to partial?
Partial mole, ma'am.
You do not want to give it to complete moles?
Partial mole.
I'm sorry?
Ma'am, partial mole we will give.
No, but you have taken a lady for suction evacuation. You have to write the prescription there and then.
Yes,
what will you write? What will you write?
Ma'am, we'll give it to all the moles.
Why? That is exactly what the question is. Why will you give it to a complete mole? That's exactly what the question is. You agree that a complete mole does not have RBCs? It does not have any fetal parts, right?
Yes, ma'am.
Even then, we are trying to suggest that we will give it to this pregnancy, irrespective of the status, complete or partial, right? So the question is why? You are right. Let me give you that piece of confidence that you are right. Now you have to answer, why will you do it?
I think, Jaya, you tell.
See, you do not know the histopathological diagnosis at the time of evacuation.
Yes, ma'am.
Right? That is the reason why you give it to both.
Okay, ma'am.
Okay, there will have a woman who is delivered, and somehow, you do get cases like that, especially in big hospitals, that they did not do the RH grouping, and it's later on when the baby was anemic and all, or having jaundice, you found that the mother is RH negative. Will you still, she comes to you after 20 days, I delivered an RH positive baby, what will you do?
Ma'am, we will give we can give an anti-D up to 28 days because it offers some safety. Ideally, it should be given within 72 hours of delivery, but 28
days having jaundice, anemia. Do you think she's immunized already?
Not because ISO immunization has already occurred. So now
you don't know. So what will you do? Maybe jaundice was because physiological.
Ma'am, we will know the baby blood group also.
I said positive.
Acha. Ma'am, if there is a jaundice on the first day of life, if there is severe jaundice requiring IUT and everything.
Yes. Have you not had babies requiring extended starvation after delivery?
Ma'am, we have heard, but ma'am, we will
You
also
will do ICT. You will do
on
ICT.
the ICT test.
I've had so many cases like that, okay? And supposing she's negative, then you don't, if she's negative, then you still give antigen. As your partner said that you will still give. Rule of the thumb, when in doubt, give. Okay, rule of thumb is when in doubt, give.
Yes, ma'am. Yes, ma'am.
Okay, I think I saw a very interesting case. In cases of missed abortion, what will you do? Will you give antigen?
Yes, ma'am.
Ma'am, in case of missed abortion, we will not give unless and until we are doing suction evacuation or anything, because there is
if you are doing suction evacuation, if you are doing medical,
then we will give, because
why? What is the difference?
Ma'am, because any procedure, anything will increase the chance of feto-maternal mixing. But if the missed abortion,
yeah.
Yes, ma'am.
No, we are talking. Let us be clear. We are talking about a missed abortion. Okay?
Yes, ma'am.
10 weeks missed abortion. Antigen to be given or not? It's a question in the question box.
Yes.
Ma'am, I think we should give it.
Yeah,
Because
why you will give it in a VA and not give it in a medical, or was it the ulta? What is the difference in giving antigen, whether it was a vacuum aspiration or a medical abortion?
Ma'am, and if we do any uterine manipulation procedure, it increases the chance.
Then tell me, if you're doing a medical abortion, you don't need to give antigen.
Ma'am, if we are
medical abortion, negative, Alice negative, ICT negative mother, will you give antigen or not? In fact, when you were answering, I was asking you the indications for antigen. One of them should have been after an abortion. Which type of abortion? That's one of the commonest indications, you know. Which type of abortion?
Ma'am, we will give if we are doing medical abortion.
Acha, if you're doing surgical, you will not give.
No, ma'am, still we will give.
So you don't have to differentiate between medical and surgical. You will give either way. Yes or no?
Yes, ma'am.
Are you convinced?
Yes, ma'am. Yes, ma'am.
I think this is to be so convinced.
Somebody collected a cord blood. They say that cord blood should be collected at birth, right?
Yes, ma'am.
And that helps us decide whether we should administer anti-D or not. So how will this cord blood help us decide whether we should give anti-D or not?
Because we will send the cord blood for blood grouping, hematocrit, bilirubin level estimation. So blood grouping will tell us if the baby is negative, then the story gets over. There's no need to give anti-D.
We have sent it for all these 3 tests. See, blood group is positive.
Direct home test also.
So how do we interpret that?
Ma'am, there was a break in voice.
How do we interpret the direct Coombs test? The idea is to decide the eligibility of the mother for anti-D post-delivery.
Yes, ma'am.
How do we decide?
Ma'am,
based on cord blood testing.
Yes. Ma'am,
okay. When you're delivering a patient, like your patient is now 38 weeks, and you're saying you will induce her. So how will you induce her?
Ma'am, same, depending upon the bishop, ma'am. If the bishop is...
So you said that, okay.
Yes.
She's gone into labor. Will
Yes,
you do an ARM? Is it a contraindication?
No. No. ARM is not a contraindication.
It is not a contraindication. In fact, you do better do ARM if you can. And
Yes,
avoid oxytocin. Why?
Ma'am, because oxytocin again can cause vigorous uterine contraction, and ma'am,
it
it
can
will.
cause irregular, it can cause hypertonicity. Okay.
Yes, ma'am.
Now the woman is delivering.
Yes, ma'am.
Tell us what precautions you will take in a vaginal delivery.
Early cord clamping, ma'am.
Okay.
Ma'am, first of all, in the second stage, we will tell her not, there should be no fundal pushing.
Yes.
There shouldn't be any, then after the baby delivers, there should be early cord clamping. There should.
Ma'am, in order to prevent the more blood going from mother to fetus, because that will have more antibody.
She's RH negative, ICT negative.
Still, that is the time when we have risk of hemorrhage maximum, ma'am.
Which hemorrhage?
Feto-maternal hemorrhage, ma'am.
So from where will the fetus go to the? But why?
Yeah.
No.
It is
Some
feto-maternal.
things have changed, you know. So we have very good tests now, and you're depriving the fetus of so much cord blood.
Yes, ma'am.
Okay. Now, will you clamp the maternal side of the cord?
No, ma'am.
Fetal side cord karke bhej diya baby. Okay, you hand it over. Will you clamp the maternal side of the cord?
Ma'am, we will like, ma'am, maternal side towards maternal side will clamp. We will leave 15 centimeter of the cord towards the fetus, because
I am saying that we should not clamp. What will happen if you clamp? And the patient is having contractions and the retractions, placenta is going to be delivered, and the blood is going backwards and is being pushed through the sinuses into the mother. Why do you want to do that? So don't clamp. Don't clamp the maternal thing. What you should do? Will you just put the cord over the abdomen and start stitching your episiotomy?
No.
Why?
Ma'am, saying we have to be gentle and.
Yeah, why gentle? Why? Why you should be gentle? The whole thing is to prevent the RH positive blood going into the maternal cell.
Yes, ma'am.
So leave the cord open, let it hang. The RBC should not even go to the episiotomy. No, it can get absorbed that way also.
Yes, ma'am.
Okay. Will you do active management of third stage?
No, ma'am.
What will you do?
Ma'am, we will let the placenta come out on its own. We will not try to do any manual removal or anything.
Yeah, fine. So you check that. Okay, you're doing a cesarean.
Yes, ma'am.
Negative patient. Any extra precaution you want to take?
Ma'am, we will pack. Firstly, we will pack the abdomen with the sponges. Why? So that there's no spillage of blood.
Yeah, so because through the maternal abdomen also RH positive cells can be absorbed. What else? You clamp the baby surface, you gave the baby.
Ma'am, for this placenta, we will have a controlled cord traction with gentle
Why
control.
You want to do? That is the difference.
Spontaneous expulsion. Like, we will
not
try.
You have a tendency, you put in your hand and do a manual removal of placenta. Yes. No? Yeah. You should never do that. Okay, then. So that's how you do it. Okay. The cord should always be hanging at a lower level than the abdomen.
Yes, ma'am.
And then after that, definitely you will give the anti-D if the baby is RH positive.
Yes, ma'am.
So how do you give anti-D? What is the route of administration?
Intramuscular, ma'am, 300 microgram given IM, but on the deltoid given by the doctor. And we should, in case we are suspecting fetal-maternal hemorrhage to be more than 30 ml, or we should give the we should do confirmatory test, KB test. To in case if we suspect that patient might need more anti-D.
This lady somehow has a contraindication to intramuscular injections. Maybe she's thrombocytopenic, she is HELP syndrome. You cannot give intramuscular injections. So now will you deprive her of anti-D because of this, or you will choose an alternative?
We can give IV route also. IV route is also available.
10 microgram.
Yes,
per
so how will you modify the dose if it is an intravenous?
We'll give,
route?
ma'am, 8 hourly. It is given 8 hourly.
Right. Okay, I think Dr. Jaya, we have exceeded
Yes,
the time.
Right
So
now.
I will just ask one last question, which is in the box.
Yes, ma'am.
Which I think is a very obvious answer, which let them answer nicely. And will you, the question is, will you give anti-D after a complete spontaneous abortion?
No, ma'am.
Why not?
Yes, yes. Will
Yes
you
or
give?
no?
Yes,
Yes,
ma'am.
ma'am.
Yes or no now?
Yes, ma'am.
See, what is the problem actually? What are we trying to avoid?
Any, ma'am, prevention of anti-D, like, ma'am, fetal-maternal mixing.
We are preventing fetal cells going into the maternal circulation.
Yes, ma'am.
You think in a complete abortion, there is no fetal cell going to the maternal circulation?
There could
is.
be.
There
There could
always will be.
Yes,
In
ma'am.
fact, there will be more because she will be contracting, retracting. Okay? Yeah. Thank you. I think Dr. Mala, we have exceeded the time or what? It's 3 o'clock and thank you very much for the invitation. Okay, both of you have done well, but I think you need to read more.
Yes, ma'am.
Let me if you want.
Yes, ma'am.
Thank,
And Dr.
thank you so much for the invite.
And Dr. Jaya.
And Ma'am Dekha, it was a pleasure uniting with you after such an honor. Thank you, organizers.
Thank you, Dr. Deepika Dekka ma'am, and thank you, Dr. Chawla ma'am, for such an elaborative discussion on RH-negative pregnancy. And I congratulate Dr. Aarti and Dr. Preeti on their presentations. Thank you, ma'am, for joining me today.
Yes, all the very best of luck to both of you.
Dr. Deepika, Dr. Deepika ma'am, can you unmute yourself?
मैं वीडियो हटा देती हूँ and
No. Thank you, ma'am. Okay, next we will have, now we will start our next session. In the session, we will talk about
12-week scan. What a PG should
and
know.
Doppler scans.
Then Ashok Rana hai ki Dopplers made easy. Okay.
Dr. Deepika, ma'am, can you unmute yourself? Okay.
Okay. I don't know, I believe she's a gynae.
Okay. Then next we will talk about NT&B scans and Doppler scans in the next session. For this session, I would like to again invite Dr. Kaval Gujral ma'am. Dr. Mala has already introduced her to moderate the session. First, Dr. Alok Vashne will talk about NT&B scans. Sir is Senior Consultant Radiology and Director of Central Diagnostic Center, Dwarika, New Delhi. He is a member of IRIA, SFM, and Joint Secretary of Delhi State Chapter of Society of Fetal Medicine. And he is also editor of newsletter of the Delhi Chapter of SFM. Welcome, sir. Dr. Alok.
Good afternoon, Dr. Alok. Are you there?
Yes, ma'am. Can you hear me?
Yes, fine. Nice to see you. Well, Dr. Alok has been introduced, but he's going to speak on a very, very important topic, what a PG should know or what an obstetrician should know in the first trimester scan. Just to give a brief on that, you know, today the pyramid of antenatal care has inverted. It is first trimester, 12 weeks. We can do aneuploidies, we can do preeclampsia, we can predict growth restriction, GDM, even placenta accreta spectrum, and of course, a major chunk of fetal anomalies. But you should have the expertise of Alok and Ashok to do that. So with that, I hand over to you to speak on, you know, your topic.
All right. So, good afternoon, everyone, and I thank the organizers for inviting me to present this talk. I hope you can hear my voice and see my slides.
Yeah, I can see you all. Very nicely said.
All right. So my topic is 12-week scan, what a PG should know. And first of all, I thank God that I'm not a PG anymore, because when I was a postgraduate, every day felt like I was walking on in a minefield, and everything could have tripped me. Okay, and because one of the reasons is the unending syllabus, and a PG does not know what he's supposed to know actually. So as a rule of thumb, a first year PG should know something about some things. A second year PG knows something about everything, but an exam going PG is expected to know everything about everything. Okay, so in the next 30 minutes, I'm going to present something about some things in about the NT scan. So the first thing a PG should know that it is the most important scan today a woman can undergo during pregnancy. It is performed between 11 weeks to 13 weeks, 6 days of gestation, when the CRL is 45 millimeters to 84 millimeters. We generally do it through a transabdominal route, but nowadays, increasingly, we are using a transvaginal scan to evaluate the fetus at 12 weeks because it gives us so much more information. And whenever we think of a 12-week scan or an NT scan, we always think of that it is for the aneuploidy risk assessment because it started as a method for aneuploidy risk assessment only. But today we have a very good method called cell-free fetal DNA, which is highly accurate, which has a very low false positivity rate. So the days of an NT scan as an aneuploidy screening tool are numbered. Today we are not doing cell-free fetal DNA in all of our patients because the cost is too high. But as the cost is going to come down, probably we'll not do an aneuploidy screening via the route of the NT scan. But when we look at the various complications during pregnancy, we find that aneuploidy forms actually a very small part of the complications. We have fetal defects, preeclampsia, fetal growth restriction, preterm delivery, and we can use the NT scan or a 12-week scan to evaluate all of these conditions. So do not think that a 12-week scan is only for the aneuploidy risk assessment. It can be used for dating of the pregnancy, counting the number of the fetuses. It is for early anomaly detection, pre-eclampsia risk assessment. We can also use it for screening for placenta accreta, screening for vasa previa. But what it cannot do very well is the screening for preterm delivery. So that is why, as ma'am alluded, we are nowadays talking about the inverted pyramid of care, in which a pregnant woman receives a 12-week fetal evaluation, and then we decide whether this patient requires a specialist care, and we send her on the specialist care track, or the patient can have a normal routine antenatal care, which extends to the anomaly scan, the growth scan, and the color Dopplers. Why not less than 11 weeks? So because the fetus is very small, less than 11 weeks of gestation, there is difficulty in visualization of the fetal anatomy. Plus, there are confounding factors less than 11 weeks. So we have physiological gut herniation, the ossification of skull bones, less than 11 weeks is very poor. The heart is too small to be evaluated at before 11 weeks of gestation. Plus, if we are using ultrasound to screen for aneuploidies, then again, there are confounding factors because the nasal bone does not ossify that early, and almost half of the fetuses will show an atrioventricular regurgitation. But to be frank, this does not stop at 11 weeks. So even from 11 to 12 weeks, the visualization of anatomy is difficult, and some of the confounding factors will persist, which is why I would recommend that the best time is around 12 to 13 weeks, when we can see and evaluate every fetal structure quite decently. Another reason why we do not want to do it before 11 weeks is because if there is any abnormality, we cannot do any definitive testing because CVS is performed only after 11 weeks of gestation. A CVS performed before 11 weeks of gestation has a high risk of transverse limb reduction defects. Why not after 13 weeks, 6 days? Because NT becomes difficult to measure. We have a more vertically aligned fetus, and it is difficult to get an appropriate plane. The nuchal fluid, the thing which we are trying to measure, it reduces after 14 weeks of gestation. The double Marcus test, the sensitivity reduces after 14 weeks, and we want to provide the women with the option of first rather than the second trimester of termination if anything goes wrong with the fetus. So we start with a basic survey. We take the history. We decide whether the patient is a high-risk patient or a low-risk patient. And we use this opportunity to answer patients' expectations, whether some defects can be diagnosed or not. Then we look that the baby is viable or not. It's alive, moving around quick, well. We check the number of fetuses. We assess the placental location, amniotic fluid, and because the uterus at this stage is not very big, we can look for the uterine adnexal masses very well. So biometry in the first trimester is performed by measuring the crown rump length. So we take a mid-sagittal section of the fetus, make sure that the fetus is horizontally oriented, it's in the neutral position, and we check it's in the neutral position by noting that there is a small pocket of fluid between the chin and the chest of the fetus. And the image should be sufficiently magnified and the caliper should be properly placed. Why we are stressing so much upon a proper CRL is because accurate CRL is the reference measurement which defines the normal ranges for all the other measurements. We are not using gestational age as the reference criteria. It is the CRL which is very, very important, whether we want to know that the NT is abnormal or not, or uterine artery PI is abnormal or not. Which is why whenever we see an image for CRL, we must check that it is appropriate image for the crown rump length. So this is a good image for crown rump length, but all these other images, these are not at all appropriate. There is a high chance that the measurement is going to be incorrect. So in here, we have a fetus which is flexed. We do not see any fluid underneath the fetal chin. This image has not been magnified properly, and here the fetus is in extension. We see a lot of fluid under the fetal chin. Now, today in the newer guidelines, it is recommended that we do an extended biometry in the first trimester itself. We use biparietal diameter, head circumference, abdominal circumference, and femoral length to do an extended biometry. But the purpose is not for dating, because dating is done only through the crown rump length. We want to detect other abnormalities. So I'm going to give you just an example. So this is a case in which when I tried to take an abdominal circumference, I found that normally we should have seen a stomach bubble here in the same section, but the stomach bubble was missing. So when I tried to locate where is the stomach bubble, I found it in the left side of the chest. So this is a case of congenital diaphragmatic hernia on the left side, diagnosed at 13 weeks of gestation, because I was paying attention to the abdominal circumference section. Another case, extended biometry was done in this 13 weeks of fetus. The biparietal diameter and the head circumference, they were all within the normal range, but abdominal circumference, it was less than 12 weeks. CRL, it was less than 12 weeks. And the estimated fetal weight was actually very, very low. And when we look at the fetal image, we find that the head is little bigger, the body is little smaller, the abdomen appears comparatively smaller in size. And the only other abnormality I could find was an aberrant right subclavian artery. No other abnormality was there in the fetus. But then the double marker test also showed a surprising result. And we saw that the markers, the hormones, were very, very, very low in this case. So extremely low hormones and growth restriction in the first trimester, we suspected a digynec triploidy. So the result is still awaited. So the take-home message here is we consider genetic cause in a very early fetal growth restriction, and such babies should be evaluated genetically. Now, coming to dating, it is one of the primary indications for 12 weeks of gestation of scan. It is essential for appropriate follow-up of pregnancies and prevents iatrogenic preterm delivery. We use only CRL for the dating purpose because it is highly accurate. At this stage, the accuracy is plus minus 5 days. But if the difference between the gestational age by LMP and by ultrasound is more than 7 days, we need to reassign the gestational age. And then we consider the gestational age by ultrasound as superior to compared to the gestational age by the last menstrual period. Now the aneuploidy screening so the main purpose has been the aneuploidy screening, which are the numerical abnormalities of chromosomes. So some chromosome can be missing or extra. The common aneuploidies are trisomy 21, 18, 13, and monosomy X. And out of which we are more bothered about trisomy 21 because that's the most common genetic syndrome. It is survivable in utero, and the survivors have a relatively long lifespan. And we have been using various techniques to screen for Down syndrome prenatally. And for the past many years, we are using this serum biochemistry and ultrasound markers. But today, much of the burden of screening is shifting towards the NIPS, the non-invasive prenatal screening. So coming to the nuchal translucency, this was a brainchild of a charismatic Professor Kypros Nikolaidis from UK. And in the 1992 in the British Medical Journal, he opined that this fetal nuchal translucency can be used for ultrasound screening for chromosomal defects in the first trimester. But look at these images. These images are not going to pass muster today. Today, we are expected to give images like this. Okay, so the Fetal Medicine Foundation has a very strict criteria about how to take NT. We have to have a fetal CRL between 45 to 84 millimeters. Fetus should be in a neutral position. The image should be properly magnified, and we should take a good mid-parietal section. And we have to place the cursors properly and distinguish between the skin and the amnion. So again, because NT is a very important measurement, whenever we see a report of any person, we have to check that the section has been taken appropriately to see the appropriateness of the nuchal translucency. So normal nuchal translucency increases with gestational age, and abnormal NT, we call it abnormal NT if the NT is increased more than 95th percentile for the CRL. And the 3.5 millimeter is considered as 99 centile, irrespective of the gestational age. In trisomy 21 fetuses, NT is increased above 95th centile in 75% of the cases, and which is why it is very helpful to note the nuchal translucency for Down syndrome screening. But apart from aneuploidy, an abnormal NT is also associated with congenital heart defects, genetic syndromes, skeletal dysplasia, and connective tissue disorders. So, which is why whenever we see an abnormal NT, we have to do a detailed morphological assessment, including that of the fetal heart in a fetus with a high NT. And as the NT increases, the chances of aneuploidy and congenital malformations also increase. So, these are the chromosomal defects. So as the NT is increasing, the percentage of chromosomal defects and major fetal abnormalities also increase. But always remember that even if the NT is high, there is a chance that the fetus is going to be alive and well. So abnormal NT is not an indication for termination of pregnancy. It is just a sign that this fetus requires more evaluation, more testing. Now, nuchal translucency can pick up 75% of the cases of trisomy 21. So how do we increase the yield? So first is by using other ultrasound markers. We can use fetal heart rate, nasal bone, ductus venosus flow, and tricuspid flow. So the nasal bone, it is absent in 60 to 70% of the fetuses with trisomy 21. But remember that it is also absent in 2% of normal fetuses as well. So again, an absent nasal bone is not an indication for termination of pregnancy. It just means that this fetus will require further testing. And this is the ductus venosus and tricuspid flow. This is the normal DV flow. And when we see an reversal of A wave, that is abnormal DV flow. And when we see tricuspid regurgitation more than 60 centimeters per second, that is also considered abnormal. But again, These are not indications for termination of pregnancy. Again, these are signs, which means that the fetus requires more detailed evaluation. So how do we use these markers? So this is one case I thought I should share. So this is a case in which the NT appears quite normal, and this case could have been missed for Down syndrome screening had we used only the nuchal translucency. But look at the case, we see there is absence of nasal bone. The ductus venosus shows reversal of A wave. There is also tricuspid regurgitation. So multiple markers in the same fetus with a normal NT. We did a CVS and it turned out to have trisomy 21. So when we use additional markers, this increases the detection rate of trisomy 21. The markers which are not used for screening these days are the frontomaxillary facial angle and the aberrant right subclavian artery. Frontomaxillary facial angle is very difficult to take, and aberrant right subclavian artery we can assess in the first trimester itself, but the value of it in the aneuploidy screening is still not known. Now the other method is that we club the nuchal translucency with biochemical parameters, which is called as the dual screen. We measure two analytes, which are the free beta HCG and PAP-A. And depending on the various abnormalities and aneuploidies, the value of the beta HCG and PAP-A is either increased or decreased. And note that in cases of triploidy, depending on whether it is diandric or digynic triploidy, the value can be very, very high or very, very low. But today we do a first trimester combined screening, which combines the maternal age and history, the serum biochemistry, fetal free beta HCG and PAP-A, and we use ultrasound markers, the nuchal translucency, NBDV, and TR, and we combine all this data and run it through a risk calculation software, and which gives us the final risk for aneuploidy in a fetus. And if we do these tests well, we are expected to find 85 to 95% of the cases with a false positive rate of 5%. And if we use the other markers like nasal bone, DV, or tricuspid flow, the detection rate is enhanced only slightly, but the false positive rate reduces considerably. Now, this is all about the aneuploidy screening. So a very, very important part of the first trimester's ultrasound is the assessment of the fetal morphology. And we have now very, very good machines. The technology has improved quite a lot, that we can assess fetal morphology in very good detail in the first trimester itself. We can detect and exclude many, many major abnormalities, almost half of them in the first trimester at the 12-week scan itself. And this gives an early reassurance to at-risk mothers. And when we find an abnormality, it initiates the genetic workup quite early. And it also results in an early and easier pregnancy termination if required. But because not every structure has formed by that stage, and we can have evolving abnormalities, so this does not exclude every abnormality at this stage of gestation, which is why the second trimester or anomaly scan, which is done at 18 to 22 weeks of gestation, remains the standard of care. And these gross abnormalities will always be detected in much better way. So these are some of the abnormalities which are always detected. The anencephaly, in which we see the orbits, but we do not see the calvarium or the brain parenchyma over it. Anencephaly, in which the neck is very, very hyperextended. This is a star-gazing fetus. We see an abdominal mass, mass along the abdominal wall. So that's amphiloceal. We see floating bowel loops anterior to the abdominal wall, gastroschisis, a monoventricle abnormal shape of the skull, lobar hollow presencephaly, a body stalk anomaly in which we see a malformed fetus. Part of it is outside the amniotic cavity. Megacystis, in which we see the bladder is over-distended, and some limb reduction defects. So this was a case of Robert syndrome, in which all the limbs were partly absent. So these are the abnormalities. Because these are very, very gross abnormalities, they should always be detected. And because the NT section is so much well standardized, we can pick up many other abnormalities through that section only. So this is a case in which there was a maxillary gap, which is due to a cleft lip palate. And in this case, the IT, the intracranial translucency, which is a fluid-filled space in the posterior fossa in the fetal head, this was obliterated, and this is due to a open neural tube defect. So these cases can be detected in many cases. Also, we can detect other abnormalities like single umbilical artery, polydactyly, and clubfoot, even at 12 weeks of gestation. So ISOPARB says that these are the minimum requirements for the first trimester. So we have to evaluate these structures in every case. And if we want to have a detailed evaluation, these are the guidelines and the checklist which has been provided by ISOPARB in the current guidelines. And what is very important is that we evaluate the fetal anatomy using a checklist approach. And these are the sections we have to take if we want to evaluate the anatomy properly. But even after following the checklist, so these are the abnormalities which we are not going to detect at this stage of gestation: microcephaly, leukoencephaly, corpus callosum agenesis, esophageal and small bowel atresia, achondroplasia, multicystic dysplastic kidney, and ambiguous genitalia, because these abnormalities are going to manifest either in the second or third trimester of pregnancy. Now, very important part of first trimester ultrasound is the preeclampsia screening. This is one of the most common life-threatening conditions in pregnancy, which occurs in about 2% and more of pregnancies. And what we are worried about is the early onset preeclampsia and the preterm preeclampsia, which are the severe forms of preeclampsia. And we can screen for these abnormalities in the first trimester. And the rationale is whenever there's a defective placentation, there is incomplete transformation of the spiral arteries. So when the placentation is good, the spiral arteries are wide in caliber, and we see low resistance flow in the uterine arteries. And when the placentation has not occurred properly, the spiral arteries are going to be very narrow, and we see high resistance flow in the uterine arteries. And we can identify the uterine arteries near the uterocervical junction on both sides. We have to take a pulse wave Doppler of the uterine arteries. We have to make sure that the PSV of the waveform is more than 60 centimeters per second. We measure the pulsatility index in both uterine arteries and calculate the mean PI, the average of the PI of the both uterine arteries. And if the mean PI is more than 98th percentile for gestational age, this suggests a high risk for preeclampsia. But this method is an old method. Today, we use the first trimester combined screening for preeclampsia, in which we use the maternal factors and the history, the serum biochemistry, PAPE or PLGF. We measure the mean arterial blood pressure of the patient and combine it with the uterine artery Doppler. And all these data is run through a risk calculation software, and we arrive at a final risk for preeclampsia screening. And as per the ASPIRATE trial, a risk cutoff of 1 in 400 is considered as a screen positive test. And why do we want to go for preeclampsia screening in the first trimester? Because this allows initiation of the aspirin prophylaxis in high-risk women before 16 weeks of gestation. And because this is the only available therapy which we have, which prevents the preeclampsia. And if we start it after 16 weeks of gestation, it does not have a significant benefit. And if we do this screening well, we can identify 90% of the women who are going to have a severe preeclampsia before 34 weeks of gestation. Now, twin pregnancy. So there are some things which we do in the first trimester scan as we do for any other pregnancy and a singleton pregnancy. But it is very important when we want to determine the chorionicity and amnionicity, estimate the risk of aneuploidy, and prediction of twin-to-twin transfusion syndrome. So chorionicity and amnionicity, it is very important that we determine it at that gestational stage, because less than 14 weeks of gestation, the accuracy is 100%, but as gestational age advances, the accuracy reduces. Okay, so we can identify dichorionic twin pregnancy by this twin peak or lambda sign, which is the invagination of the placental tissue between the amniotic membranes. So that's the lambda sign which we see. And in monochorionic diamniotic twin pregnancy, the amniotic membrane inserts perpendicular to the chorionic plate, and this is called as the T sign. And this is how we identify the monochorionic and the dichorionic pregnancies. And in monochorionic monoamniotic pregnancy, we do not see any intertwin membrane, and both the fetus lie in the same amniotic sac. And it is very easy to identify the entangled umbilical cords, which are present even at that gestational stage. So we can identify entangled umbilical cords and know this is a monochorionic monoamniotic pregnancy. Now, aneuploidy screening in twins is a little complicated because the risk assessment in twins is different than in the singleton pregnancy, and chorionicity plays a very, very important role. In dichorionic twin pregnancy, we calculate the risk for each fetus by using biochemical markers and NT for each fetus. So we can give a fetus-specific risk in dichorionic twin pregnancy depending on how big the nucleotranslucency is. In monochorionic twin pregnancy, we calculate the risk per pregnancy, the pregnancy as a whole. And we give same risk for both the twins by using biochemical markers, and we need to average the NT of both the fetuses. But when we have a vanishing twin with a measurable fetal pole, and we have more than 2 fetuses, then this combined screening cannot be performed, and we have to do the screening with maternal age and NT only. And whenever we find there is a discordance in the NT, so one fetus has a normal NT, in the other fetus has an increased NT, which is more than 20%, and it's a monochorionic twin pregnancy, we must consider that we may be dealing with a twin-to-twin transfusion syndrome. And the other predictors are abnormal flow in the ductus venosus. If there's a CRL discordance of more than 10 millimeters, or sometimes the amniotic fluid in one sac is lesser compared to the other sac, we should think of monochorionic twin pregnancy that this may be an early TTTS, and such fetuses should undergo an early surveillance from 14 to 16 weeks onwards. Screening for preterm labor. So this is controversial in the first trimester. We know that a preterm birth correlates with a shorter cervix, and if we measure the cervical length and add personal history, we can identify a group at risk. But it is challenging to measure true cervical length because in the first trimester, the cervix is curved and the lower uterine segment is not that well formed. And we do not yet know whether this first trimester screening improves the outcome or not, which is why this is something which is controversial, and cervical length measurement during the second trimester is currently the best method which we have for screening for preterm labor. Now, till now, this is what everybody PG should know, but some PGs want to know a little more. So we can also screen for vasa previa in the first trimester only, so that we do not get nasty surprises during delivery. So because the fetus is of very small size and it moves around quite a lot, it is very, very easy to identify the cord insertion. And if it is implanting in the substance of the placenta, we are good. But sometimes we can see that the cord implants very, very near to the internal os, and the vessels are running across the internal os. So this is a case of vasa previa. And the Nicolaides group has, they have given a 2-stage screening program for diagnosis of vasa previa. But the upshot is that we need to screen the umbilical cord. We need to see where it is inserting in the first trimester itself. And if it is a velamentous cord insertion, we have to follow it up and in the second trimester or later and find out whether there is vasa previa or not. And similarly, we can also screen for placenta accreta in the first trimester. So whenever there's a history of LSCS and we find an anterior or low-lying placenta, that is a high risk for placenta accreta spectrum, and these cases need to be followed up. And many signs of placenta accreta spectrum can be found in the first trimester itself. So sometimes we can make a confident diagnosis in the first trimester only. So to summarize, 12-week scan is not just an aneuploidy screening, but it is a window of opportunity to screen for many conditions. If we are focusing only on the aneuploidy, we are going to see only the tip of the iceberg, and rest of the problems we are going to miss. A high NT and absent nasal bones or other markers are just markers which warrant further investigations, and these are not indications for termination of pregnancy. It is very important to follow guidelines and standardized protocols if you want to increase the detection rate of various abnormalities and minimize errors. And if we do not follow protocol, this happens. So in this case, the NT scan was done elsewhere. It was reported the NT was normal. There was normal nasal bone. The second time, the combined screening test result was normal, but in the third trimester, absent nasal bone, dysmorphic facies, this turned out to have a Down syndrome because the NT scan was not done properly. Thank you so much.
Well, thank you, Dr. Alok. Wonderful as usual. Covered almost 120%. And Renuka, can you introduce Dr. Khurana?
Yes, ma'am. Can you please show his slide? Vikas? Prakash, are you there?
We can see the slide now. Yeah.
I would like to introduce Dr. Professor Ashok Khurana. Sir is chairman and consultant in reproductive ultrasound at the Ultrasound Lab, New Delhi. Sir was past president of Society of Fetal Medicine from 2018 to 2020 and former ISOPARB ambassador in India. Welcome, sir.
Thank you. Thank you very much.
Well, nice to see you again, Dr. Khurana. And for PGs, well, he's the master ultrasonologist, and that's what I can say about him. And when I take a class for PG, Dr. Khurana, I always find they're confused. Which vessel to use, when to use, should I use SD, should I use PI, should I use RI, how frequent should I report? And I think repeat the ultrasound. So I think this is what a PG really needs to know. And I've heard your lecture before, and I know you're going to make it very easy for them in your own style. Welcome.
Thank you. Thank you so much. Congratulations for putting such a marvelous program together again for the PGs this year. I think they are really lucky to have you and the entire team that you have at Ganga for putting this into perspective. And it's a pleasure for me to be invited here.
Same
I will
here.
go right ahead and share my screen so that we can start off on my talk. I promise you that there's going to be a very minimal amount of physics because I know what physics really means to the postgraduates. There is a little bit that perhaps might be asked for by some of the professors, but honestly speaking, a lot of it is not asked for anymore. And so we will just tell you as much as is necessary. I bring to you greetings also from the Society of Fetal Medicine, and you'll be happy to know that fetal medicine is now a field by itself, and that's where Dopplers now feature themselves. But that does not mean that it can only be done by a specialist. What you and me really need to do is to have an understanding so that we can use it in our daily life. There are two ways to actually end up using Doppler. One, to understand what a report implies, and the second one, to try and understand not what just that the report implies, but in terms of how you can actually do it yourself. When you get a feel of a technique, when you're doing it, please understand that is the time that you will know how to use it the best, because not every technique is infallible. There are considerations that you must use, and when you've done it yourself, you understand, okay, this is how much I can depend on this. So in your daily practice, it's going to make a difference. And my talk will be on both these levels. One, to prepare you from an exam point of view, B, to even at this stage change your thinking so that you can appropriately use this information. The Doppler bit, of course, and I promised you just a few slides. The principle was discovered many years ago, and it was based on a mathematical equation. But what it really means is that when an object comes closer to you and is producing a sound, it will be at a different pitch. And when it's going away, it produces a different sound, and it will be at a different pitch. And this is because sound waves are reflected back, and therefore when an object is moving away or coming towards you, if it's coming towards you, the frequency is higher, and as it moves away, the frequency becomes lower. And exactly the same thing is translated into the movement of blood cells in the vessels, and that's what it achieves. I will not discuss that famous equation just now, but much later on, and we will understand why this equation is not so important. But I may as well tell you something very simple about this dear equation of ours, that apart from all the normal figures of flow, etc., and the frequency, because there is an angle involved, which is the alpha angle, which is the angle between the beam and the vessel, this angle then therefore changes in value. And if you don't angulate correctly, you will get no signal in the vessel. That is the only thing that you need to learn from this great equation, that if you don't angulate it correctly with relationship to the vessel, you will not get a signal in the vessel. Moving on, let me tell you that there are many more indications than the ones that you probably traditionally know in terms of hypoxia, acidosis, fetal growth restriction, and preeclampsia, and their management and follow-up. And those are in the first trimester, where we can diagnose an unsuccessful pregnancy. We can use it in the management of ectopic pregnancy and differentiating between products of conception when you use it along with HCG levels. We use it for recurrent pregnancy loss evaluation, and we use it in two ways, and we don't have time to discuss that today because that's really a topic by itself, but we include it in the section on reproductive loss. And then we use it for first trimester genetic diagnosis, as you've heard, and I will emphasize. We will talk a little more on uterine artery studies from a physics point of view. I will discuss briefly fetal anomalies, and then of course some of the stuff that you've heard already from Dr. Alok Varshney, which was a beautiful talk. Really, you're very lucky to have him as a speaker today. The areas of utility, really much more than the list that I've told you, is how I want you to tune your mind and remember to answer this question. One is that every time you see a fluid mass, you want to exclude whether this particular fluid mass is blood or clear fluid, and you switch on Doppler, and which means you switch on color, and if it's a liquid, it will remain clear, and it might even have enhancement of vessels in the periphery. And if it is a blood vessel, you will pick it up as a blood vessel, which shows color. You then can use it for assessment also, vascularity in the fetal mass. You can also assess it to see the vessel of origin of vascular supply. It is, of course, a very integral part of fetal cardiac evaluation, and I'll show you an example. And then to assess the ductus venosus and tricuspid regurgitation at the 11 to 14-week window. Uterine artery studies, which are done all the way from 12 weeks now to term, and multivessel Doppler, which is a third trimester event. And I will teach you how to judiciously use this so that you can understand as well as utilize this on a regular basis. Now, this was that famous photograph, which we've replaced the famous ambulance with, which tells you that yes, depending on the direction, we have something called a Doppler shift. So as the structure moves towards the transducer, then the frequency shift increases. And then as the structure moves away, the frequency shift decreases, and therefore you find a different situation. Therefore, when you find that you have a moving source, that means you have a moving source such as the red blood cells, they will be quite different, and they will also then give you a different color. Traditionally, we have red when it is coming towards the transducer and blue when it is going away, but this would also depend on how you place your transducer, and we will discuss that very, very briefly. Now, when it comes to actually understanding this relationship, remember that in the same transducer that you use for routine ultrasound, if it is a Doppler machine, there is the physics and the geometry to use it as a Doppler unit. So a series of pulse waves gets transmitted, then these get scattered back from moving scatterers, which is like blood. Of course, you could also use it to look at urine coming out of the urinary bladder or into the urinary bladder. And you could use it for fetal breathing when it comes in and out of the nasal passages. But the real place where we do use it is blood. Now, echoes from these moving scatterers exhibit slight differences, which are understood by the machine, and then it gives it a color code and it gives it a particular noise. And therefore, this is the business of getting a Doppler sonogram. The essential part of the Doppler sonogram is in all this kind of stuff with physics like this, but no, you don't have to worry about that, except to know that the vast majority of uses in obstetrics is pulsed wave Doppler. And when you're looking at very high velocities and you want to study those, then we use something called continuous wave Doppler, which really today is almost not used anymore. So essentially we use a pulse wave Doppler and it works on the same principle. The important thing to do is to find out what gives you the best image. We used to depend on physics a lot to see what gives us the best image, but we've understood a new way of understanding this. As technology has evolved, it has become very difficult to try and remember in your mind how I can pick the best, and therefore machines have now made it simpler, and either on the basis of a menu that drops down on the machine or a simpler machine like this, which gives you a touch screen, all you have to do is to look at a particular transducer. Okay, this is my 3D transducer with a high frequency. I'm doing an obstetric scan. I want to do a second trimester obstetric scan, and it will automatically tell me, okay, just press this and the preset works. If I wanted, for instance, to do a obstetric scan using my transvaginal, again, I have a preset. Previously, I used to have to reduce the window. I used to have to alter the frame and do 6-7 steps, which were real killers in terms of trying to do it. Also, what was happening with those was that a lot of us were spending so much time making these adjustments that we absolutely did not even realize that we were exceeding what we're supposed to be doing. So in trying to get the signal right, we were exceeding the time allowed for the safe amount of frequency. Otherwise, of course, ultrasound is pretty much safe. The other thing that you sometimes get confused about on what is 2D and what is color, a standard image is called a 2D. This is known as color Doppler, but really this is a color flow map where vessels are outlined. And these waves are known as the waveform, also known as spectral Doppler. So color flow maps and spectral Doppler is what are the two words you should remember. But remember, the basic principle is anywhere you see fluid space, including the umbilical cord, switch on color. It might give you a clue on whether you have a single umbilical artery or not. And then you will start looking for anomalies. So it's something that flows naturally as you go along. The business about that famous angle was this, that if you have a vessel like this and the beam is coming from on top and the beam is parallel to the vessel, you will pick up a signal. But if you have a beam which is perpendicular to your beam of ultrasound, then in that situation, that vessel will not show color and therefore it will change. What will also change is as you tilt your transducer compared to the RBCs that are flowing in that vessel, you will get a change in the diagram of that flow velocity waveform. So if you notice that when you are at about this angulation, you get a nice waveform. This angulation also gives you a waveform, but there will be times when that waveform will become muffled because that angle is now disappearing. And of course, once it starts going away, because now compared to the transducer, this is the level of flow, it will actually change direction. So you have to be aware of the fact that things will change when you tilt the transducer and whether you're at this end or you're at that end. But the important thing to remember about that angle is the famous business of making sure that you insonate angles along the long axis of the beam. Now, the only place where you must remember this beam angle more importantly is the fact that it comes into calculation, not when we're doing the indices. The indices are ratios where you divide one velocity by the other, and we will discuss these. And then that tells you, yes, this is to be divided, and then the angle doesn't matter. However, when you have to calculate a velocity, and the place where we use velocities are only two. One is to detect anemia in the middle cerebral artery of the fetus, where if it exceeds a 1.5 multiples of median, you know that that fetus is likely to be anemic. Or in the uterine artery, where if the velocity is less than 60 centimeters per second, then you do realize that you are not insonating the vessel correctly, and therefore you might be insonating a wrong vessel, which is too far down into the uterus and not the main uterine artery. So in those situations, you have to be careful that you either do an angle correction, making sure what is the perpendicular compared to the angle of the velocity, and then calculating the velocity, or better still, change the angle of your transducer so that it always falls along the long axis of the vessel. So that's the best way to truly go about this. Now, I will briefly then take you through a little bit more mathematics where it's needed, some safety issues, some of the fact that Doppler actually helps you to understand pathophysiology, and a little bit more information on how it can be used for fetal anatomy and the diagnosis and prognosis of anomalies, the markers for some anomalies. And actually, I'm not going to use this talk to talk about machine settings, knobology, and techniques, because what I've told you really is all you need to do. Select a preset and go, and the rest of it should be how to interpret the flow velocity waveform that you see. And it's certainly not going to be an atlas to show off to you or to tell you what you haven't learned. This is going to be a support lecture that teaches you how to think Doppler. So do remember that Doppler is not used only for information on fetal physiology, but also for the appearance of vessels and further information on fetal anatomy. And therefore, it's something that could be very, very useful. Remember again that this is color flow mapping and this is spectral Doppler. So the waveforms are spectral Doppler and the maps are color flow mapping. The important thing that we must realize is that yes, you use it in a lot of scenarios, not just a simple thing like the middle cerebral artery I told you about for peak systolic velocity when we're looking for fetal anemia, but we'd also try to make sure that we analyze the amount of flow at the end of diastole, which indicates whether it's a high impedance or low impedance flow. So as the resistance to flow goes up, you actually end up getting less flow at the end of the cardiac cycle and ultimately reversed flow. And therefore you will get to know this is a low impedance flow, this is a very high impedance flow circuit. Anatomy delineation, like I was telling you, the urinary bladder, you switch on your color, you see one vessel on one side, you don't see the other one, and you know then therefore that you're looking at a single umbilical artery. When you're looking at the heart, we always use color, and we know that yes, a lot of information will be available on color, and you can use it even as far back as the 7th or 8th week of pregnancy to delineate anatomy and ectopia cordis here, and a bulging of bowel just in the upper part of the abdomen, the cord insertion here, and an abnormal relationship of the uterine arteries indicating an anterior abdominal wall defect. Or a mass here in the fetal thyroid, and you get a hyperechoic pattern in that mass, knowing for sure that this is a goiter that's likely to be a troublesome goiter. So you actually have a wide variety. You should just think Doppler every time you see anything abnormality and see whether physiology or more information on anatomy is important for you. The principles of color Doppler are quite simple. When we use routine, standard, old-fashioned color Doppler, it depends on flow direction, mean velocity and range of velocities. But in a lot of times in early pregnancy, for instance, and when we want to look at blood vessels within an organ, we have slower flow and we end up using power Doppler. It detects energy, which means packets of RBCs, and displays them as an intensity. It has very good slow flow sensitivity and detects omnidirectional vessels. And therefore, like I said, we use it for small vessels. Originally, we used to detect it by a single color, like an orange. Now we have directional power Doppler, and therefore we're able to see much more than we ever used to see before. Remember that flow is now available at a very high-end technology level, and it's called slow flow. And even at the level of the 12-weeker, you can see how beautifully you can actually see the entire circle of Willis and the middle cerebral arteries. And later on, of course, much better delineation. So clean flow velocity waveforms are available through high-end technology, but basic stuff is available even through standard technology. So don't pretend to yourself that you can't do it on a low-end machine. Try Doppler on every information that you get, but use it as low as is reasonably achievable. Remember that you can even use it for confirming anomalies. For instance, if I don't see the kidneys properly, I switch on Doppler at 12 to 14 weeks, and I pick up renal arteries and I see them so well. And depending on what you anticipate the values to be, you can alter the velocities and pick them up. And you can even magnify and get much more detail with the technology. This takes practice, and it's something that I would encourage you to do as you grow up. Remember that cardiac evaluation is completely indispensable, and it's not only used with 3D that I've shown here, but even with 2D on a regular basis to look for structure, to look for flow, and to look for abnormalities as we go along. But again, the more you use it, the more you will learn, but you must sensitize your mind to the fact that you could be actually using this. In fact, there's a lot of new technology, and you will get confused with these names as you go along in life. But silhouette means outlines, and you actually can move a knob on your machine and get only the outline instead of the whole vessel being filled up. So these are different ways of being able to see through an organ to get a very good idea of vascular anatomy. So like I said in the beginning, not just vascular physiology, but vascular anatomy as well. Some very simple applications. We have here a mass in the lung. And I say, okay, now what is this? Is this a sequestration, or is this a CPAM? When I look at my aorta, I realize that there is this vessel going up from here and going into the mass. When I see this kind of a vessel going up there, I say, okay, I know for sure now that this is sequestration, because CPAM, as you will see in this slide, is truly supplied by a pulmonary vessel and not by a aortic vessel. So simple things like that will help you to differentiate. Remember that ultrasound Doppler is basically safe. Transvaginal scanning is safe. Spectral Doppler is safe only after 10 weeks for the embryo. And therefore, please don't display the actual heart by a power Doppler or by spectral Doppler until 10 weeks of gestation. Otherwise, you can use as much. And typically on the top of your screen, you will find MI and TI, which is basically the amount of heat being generated. And equipment now actually puts on a bulb to light up to tell you when you're exceeding those. So life has actually become pretty easy. Now, remember that there are wonderful guidelines available on a lot of what I'm talking about today. And you can use the ISOPARB guidelines, and these are as a free download on the internet. Then, of course, moving on to what these guidelines basically say, remember that they're practice guidelines, which we should all use. They're not only from ISOPARB, but other organizations as well. But also remember that depending on patient load, expertise, and economic considerations, you can develop your own institutional protocol that tells you how to do and what to do, and lets the patient be informed also. Remember that knowledge evolves, and you can't just go to a textbook. You have to now depend on stuff such as a wonderful webinar teaching like this, or YouTube, etc., or even journals to try and learn what is emerging scientific evidence. In Doppler, for instance, now it's becoming more and more popular all over the world to do a 36-week scan to predict complications for stillbirth and growth restriction. And of course, at the same time, pick up non-Doppler stuff as well. So this is emerging evidence, but otherwise you can divide your practice into basic standards or limited standards because of limitations, and those are called institutional protocol. Like I was telling you, there is the mapping, in which case we actually look for the blood vessels as they pump, and there is spectral Doppler, which is the waveform, and this gives you the mathematics, and the mapping gives you anatomy. of flow from towards the transducer is usually denoted as red, and away from the transducer is denoted as blue. Remember that you can quantify by various indices. Almost all over the world, we've thrown everything else out of the window, except the pulsatility index. The ST ratio was used for a long time, but then we realized that as diastolic flow appears zero or disappears, you cannot get an index. The PI, the pulsatility index, can do that. The resistive index cannot do that. The pulsatility index can do that because it takes the mean of all velocities, and therefore you can actually get a value even if flow is zero or reversed. Therefore, what is now used for everything is the pulsatility index and not any of the others. The other place that we do use things, like I said, was peak systolic velocity for the middle cerebral artery and to distinguish the uterine artery level. Remember that the PI is more stable because it just does not approach infinity for those absent levels. As long as you remind yourself about this, you will understand that yes, that is the way to go about it. Remember also that there are now 3D powered Doppler indices where within a volume you have extracted some information, and the machine will give you a VI, a vascularization index, which reflects the number of vessels in that volume, and FI, which is the amount of blood flow, and the VFI, which is a combination of the VI and the FI. And that can be used a lot. I used a lot for simple things like an ectopic pregnancy, which is being managed conservatively. And in that situation, if the patient does have an odd pain or a bit of tachycardia, you want to not still open her up, and it's a couple of days after her methotrexate, you do a 3D before you give her methotrexate, you do a 3D afterwards. If the total indices are going down, yes, you can assess that, yes, we can probably wait because otherwise she is doing pretty much okay. Now, moving on, let's move on to the next big chunk, and that is fetal growth restriction. And remember that Doppler is used for understanding fetal growth restriction, for diagnosing fetal growth restriction, and for delivery decisions in fetal growth restriction. In that situation, we use this very, very liberally. In fact, there is no such thing today as doing a growth scan without doing a Doppler. So how do we go about this? Well, remember that first for growth, you will always, of course, measure a parameter. You will assign normality depending on the software on your machine. You will put it onto a chart and compare with norms, and then centiles and previous readings, estimate the fetal weight and decide whether it is less, and then also do a color Doppler. You must have charts and you must have graphs. That is not part of today's discussion, but certainly something that I suggest that you do on a regular basis. Now, how do I handle this kind of information? I handle this kind of information by saying that, yes, I must understand flow. This is lots of flow. This is less flow. This is flow with more velocity because you increase the amount of pumping from the heart, or it was coming through a narrow vessel and therefore you got more flow. Let me just get back to that one particular chart to show you. Now, you must remember that each vessel gives you specific information. The uterine artery will talk about trophoblastic invasion of the spiral vessels, and only that information. The indices to be used are nothing else but the PI, and it will give you information on trophoblastic invasion. The umbilical artery, which supplies the placenta, tells you about placental villus obliteration, either because of spasm or because of atherosis, and therefore it will tell you about the status of the structure of the placenta. The middle cerebral artery tells you about brain sparing, where more goes to the brain rather than to the mesenteric vessels or to the liver, and therefore is a great way to assess brain sparing and growth restriction. The aortic isthmus used to be used before because it was a stage where there was a steal from the upper limb circulation to the brain circulation and was an indicator of redistribution cardiac output, but we don't use that anymore. We continue to use the ductus venosus as the most reliable venous parameter not the IVC and not the umbilical vein, because they're not so easily reproducible. And the ductus venosus tells us about myocardial function, especially the right side of the heart. And the index is always the PI. So you notice that the index to be used is always the PI. Remember that the fetus should be at rest. There should be no movements or breathing movements. It should be relaxed and shallow maternal breathing. She should not be worked up. You must have an appropriate region of insonation. You set your scale right, but that comes in the preset automatically. The gate size should always cover the vessel, and you don't have to go by millimeters. You will use the PI and always use the chart and not a single cutoff. All charts are gestational age related. So in the uterine artery, you will always look for where it comes out from the infundibular pelvic ligament and it goes into the cervicouterine isthmus. And soon after that, you will get a signal sitting right there. For the middle cerebral artery, you will use it soon after its origin. And for the umbilical cord, you will use it in a free loop except for twins, where you try and use it as close to the twin as possible. For the ductus venosus, you use the right parasagittal view, and it's the area of aliasing that you see here. For each one of these, you will use the actual gate to occupy the whole vessel. Remember also that rules for magnification apply here, and there is something else known as the sweep speed. This amount of crowding will not give you the answer, and typically we would like about 3 or 4 flow velocity waveforms nicely spread out through the screen. That will give you the right answer. Remember that flow velocity waveform should be absolutely clean in order to give you the right answer, not these faded ones. Keep on doing it correctly till you get them clean. Once you've done them, there's no need to repeat them, although most of us take a mean of 3. Remember that irrespective of what the uterine artery is at the time of the 12 or the 22-week window, we will still use it at the time of all the assessment for growth, because that's useful. We will take out a ratio between the MCA PI and the umbilical artery PI as an indicator for growth restriction, and the aortic isthmus is no longer useful because although changes do precede those in the ductus venosus, they have of late been proven to be inaccurate because they are very tricky to reproduce. Therefore, what do we use? We use the uterine artery PI at all times, the middle cerebral artery at all times, the umbilical artery at all times, and we don't use the aortic index, which is the aortic isthmus, which is why I put it down into gray. Now, remember that ductus venosus flow is a great indicator of acidosis and is very useful for making decisions up to 32 weeks of gestation for growth restriction. And it is very important to realize that it's not just a graph that shows what is happening. That's useful for serial follow-up. What's useful is the actual value at that time and whether you are going away from an acceptable centile or not. So if you have a little bit of flow at the bottom, it might still be safe, but absent is not acceptable. And to use cutoffs correctly, you will refer to a chart and see whether the PI is fitting correctly or not. So do remember that, of course, none of these are to be used for an emergency cesarean section. They are to be used in perspective, and we will discuss that over the next 2-3 minutes. And the fact that usually it is the deteriorating maternal condition that helps you to make decision-making with Doppler. Remember that there are 2 types of growth restriction, those before 32 weeks, which is where ductus venosus is used for decision-making, and those after 32 weeks, where the cerebral placental ratio is used for decision-making. For decision-making, remember that you will also be able to differentiate between the SGA fetus, the small for gestational age fetus, and FGR by Doppler. The FGR fetus will show Doppler signs of adaptation. And therefore, when we look at the definitions, we use either a weight less than the 3rd centile for FGR. Otherwise, if the weight is less than the 10th centile, to differentiate between SGA and FGR, we will use either a CPR less than the 5th centile or a uterine artery greater than the 95th centile. Something similar is also been added on by the Delphi consensus, but that was really a group of experts. And the only difference really between the Barcelona group and this is the addition of the abdominal circumference, where they have said, okay, that can also be used as a diagnosis. So don't get confused. Doppler is used in both, and we like to use that. How do we use that for decision making? For decision making, we actually define everything with the help of staging growth restrictions. So if you have a weight less than the 3rd centile, and you have a CPR less than the 5th centile, or uterine artery greater than the 95th centile, then that is mild placental insufficiency. If it's more than 37 weeks, you'll induce labor. Otherwise, you just monitor weekly. If you have absent end diastolic velocities in the umbilical artery, or a reversal in the aortic isthmus in case you're still using it, if you've crossed 34 weeks, the advice is cesarean section. If you haven't crossed 34 weeks, the advice is twice weekly reevaluation. For a low suspicion acidosis, that's when you have reverse flow in the umbilical artery or a ductus venosus PI greater than the 95th centile. If it's beyond 30 weeks and you have your nursery facilities, you will go ahead with a cesarean section. Otherwise, you will like to see them just about every day. And if you have reverse flow in the ductus venosus, sorry, part of this slide has got cut off, but or you have an abnormal CTG, then of course you will deliver at that time without thinking of gestational age. Remember also that this information is to be combined with the CCTG, but with the CCTG, not a CTG, and then the short-term variations would depend on the weeks of pregnancy, and you will find this chart all over the net. Remember also that the other great function of color is for aspirin. This has been beautifully covered by Dr. Alok Varshney, so I will not repeat that except to remind you that the moment you drop uterine artery Doppler, your sensitivity goes really, really low, so you can't depend on biochemistry alone. So you must include uterine Doppler artery in your evaluation, and you must do it correctly. Remember that again, you will use a mean of the left and the right side and not the actual values, and you will ignore the notch because we've dropped the notch. The notch is no longer an indicator. A lot of velocity waveforms in the first trimester are like that, and therefore we will not use the notch. We will only use the PI, and it's a mean of the left and the right divided by 2. For intrauterine transfusions, again, we use a velocity, and we must use norms, and you must use the near flow, and you must use the peak systolic velocity. We've already been through first trimester screening, but I wanted to add that in addition to the nuchal translucency and the nasal bone, you can add on tricuspid regurgitation and ductus venosus flow. And of course, these have to be done correctly, but importantly, to realize that they do increase not only the sensitivity of detection, but also the false positive rate. And that's really very, very useful. But of course, it depends on whether you're doing population screening, whether you're in private practice or you're in a research setting. So in that situation, then you will decide whether to add on the color flow or not. They're not used just only for anomalies, but also for cardiac abnormalities and also for prediction of overall abnormal perinatal outcomes. In the first trimester, as you also saw in the previous talk, we like to use it for structural anatomy. And you see here the right and the left ventricle of the heart and the pulmonary artery in the aorta. So beautifully seen because you had the actual thing right. And of course, there are lists and lists you will come across in the literature on where you use colored Doppler in cardiac evaluation. And again, a full list in twin pregnancies, but essentially you must realize that those are topics by themselves. But when you're looking at these scenarios in practice and in general work, please understand that color is absolutely indispensable. You can also use some of the newer functions, such as the prediction of a heart block, or even for the assessment of arrhythmias. We no longer use M mode. It's tricky to use. We'd rather use colored Doppler, and that's how we go about it. Now, the take-home message, therefore, would be that colored Doppler is now an integral component of almost every obstetrical ultrasound scan. Both routine and problem-solving protocols exist, and technology is now extremely advanced. And so do remember that you are not just as an obstetrician working alone, you work as a team with neonatology and radiology, depending on who's doing your scans, and then you get the right answers. As a summary, You all might want to take a screenshot of my next slide, which is this one, which is a summary of what we like to do at which stage. At 18 to 22 weeks, it's uterine artery Doppler and anomalies delineation. Third trimester is multiple vessel Doppler. And at 14 weeks, you like to do as an aid to anatomy as well, along with uterine artery Doppler. And thank you so much for your attention.
Thank you, Dr. Khurana. Brilliant. And I'm sure students have questions, but we are short of time. So they'll write to us and we'll write back to you. And some other day we'll invite you for a longer session. I think you need an hour for Dopplers. Thank you so much for sparing your time.
Thank you indeed.
Thanks, Guru.
I want to thank you, the presenter and the moderator for this session, Dr. Madam Gujral. Now, for the next session, we have the case presentation on GDM. Now I would like to introduce the moderators. Our first moderator is Dr. Harsha Kullar. She is Senior Consultant in Institute of Obstetrics and Gynaecology, Sir Gangaram Hospital. She has special interest on oncology and worked in various fraternities, including AOGD, IMS, and NARCHI. Our other moderator is Dr. Piki Saxena. Slide, please. Ma'am is a Director, Professor of Obstetrics and Gynaecology, FICOG in MNAMS. She's a winner.
I think we can skip that. Thank you so much.
Thank you, ma'am. Ma'am, I'd like to introduce the presenter today. She's Dr. Mrinalini, second year secondary DNB trainee in our Institute of Obstetrics and Gynaecology, Sir Gangaram Hospital, ma'am. Next, Dr. Mrinalini will present her case.
Let me just share my screen. Is my screen visible?
Yes, it's visible.
Good afternoon, Harsha. Ma'am, the case I'm presenting today is diabetes. This patient was Mrs. X, wife of Mr. Y.
Peter, have you joined from two devices? There's a lot of echo. We can't hear you properly. Join from one device only.
Is it okay? Better now, ma'am?
Yes, yes.
Ma'am, this patient is Mrs. X, wife of Mr. Y. She's aged 30 years, resident of Pithampura in New Delhi. She's a teacher by profession. Her husband is a businessman and a graduate. Their socioeconomic status is around the upper middle class by modified Kuppuswamy scale. She's a primary gravida at 8 months, amenorrhea with GDM on MNT. Her presenting complaint was that she was diagnosed with GDM and was on MNT. She is now being admitted from the OPD due to poorly controlled blood sugar levels. Excuse me. At 28 weeks, she was diagnosed with GDM because the 75-gram OGTT showed a fasting sugar of 118 and the 2-hour sugar showed 190. She was on MNT since and exercise regimen since the last 2 weeks and has been checking her blood sugars regularly at home. However, the recent blood sugars show a rise, and because her sugars were not controlled, she's been advised admission. She's had no history of pain, abdomen, or leaking PV or any abnormal vaginal discharge, no history of bleeding PV, no history of fever, chills, no burning micturition, increased frequency of micturition or dysuria. There's no history of constipation, nausea, or vomiting, and no history of raised BP records during her antenatal checkups. She's never had any headache, blurring of vision, pedal edema, or epigastric pain during her pregnancy. She attained menarche at 13 years of age with regular menstrual cycles and no dysmenorrhea. She used contraceptive barrier before planning this pregnancy. And her LMP, her gestational age from the LMP is so corroborative with the ultrasound. She's 32. She was 32 weeks on the date of examination. She was married since 6 years in a non-consanguineous marriage with no history of OCP use or no use of ovulation induction. She was a primigravida and conceived spontaneously, and a booked patient of Gangaram Hospital. She detected her pregnancy by a UPT test at 1.5 months after her missed period, which was confirmed by a dating scan. She had no hyperemesis or fever with rash, body micturition, drug intake, radiation exposure, or bleeding PV in the first trimester. There was no history of trauma. She was started on folic acid tablets as soon as the pregnancy was detected. The NT-NB scan and dual markers were done in the 3rd month of pregnancy and reported normal. All the other antenatal tests, including her blood sugar profiles, were also normal. The patient was started on iron and calcium since the 2nd trimester, and the 5th month, the anomaly scan was normal. She started perceiving fetal movements around the 6th month of her gestation, and the first dose of tetanus toxoid was also taken then. She continued to be normotensive with no other symptoms. No other complaints of burning, micturition, fever, chills, or bleeding PV. Her weight gain was adequate. At 28 weeks, however, once she was given the oral glucose challenge test, she tested positive and was diagnosed as GDM. Since then, she was advised medical nutritional therapy and exercise regimens, and she has been on that since then. Her fetal, in the 3rd trimester, she perceived good fetal movements. The iron calcium tablets were continued. There was no history of vaginal discharge or bleeding PV or burning micturition, no signs of UTI otherwise. TDAP was given at 32 weeks. Her blood sugar charting, which she kept maintained at home, showed a rise in the blood sugar levels recently. Hence, she's now been advised admission for monitoring and planning of starting on insulin. She had no prior history of diabetes, hypertension, or thyroid disorders, no TB, epilepsy, heart disease, or asthma. She's never been admitted in the hospital before. There's been no history of blood transfusions. She also doesn't give any history of recurrent UTI vaginal infections. There's no previous history of surgery, and her family history is also insignificant. Her personal history, she consumes a mixed diet and currently consumes around 1,830 kilocalories since she's been put on the MNT. The total protein intake was 96.3 gram. Level of activity would be moderate. She has good appetite, no addictions, has adequate sleep, and her bowel and bladder habits are normal. This is an estimate of her diet based on a 24-hour recall. We can see she has a total caloric intake of 18,030 kilocalories, comprising of 96.3 grams of proteins. On her general exam, her pre-pregnancy BMI was 23.4 kg per meter square, which is overweight by Indian standards, but is normal according to ADA. Her present weight is 68 kg. She's had an 8 kg increase in weight gain during her pregnancy, which is good. Her nutrition was good. There was no pallor, icterus, jaundice, edema, or lymphadenopathy. The thyroid gland was normal. Breast showed normal changes of pregnancy. She had normal gait and oral hygiene was good. Her vitals were stable. There was 78 beats per minute was the pulse, and BP was 120/80 in both arms in supine position. Respiratory rate was 18 per minute, and she was afebrile. Her cardiovascular and respiratory system examinations were also within normal limits. The abdominal examination showed a longitudinally distended abdomen with clinically adequate liquor. The umbilicus was midline and everted. Linea nigra and stria gravidarum was seen. There were no previous, no scars or dilated veins or excoriation seen on her abdomen. All quadrants were moving equally with respiration, and all hernian sites were normal. On palpation, the fundal height corresponded to 32 weeks. The symphysis fundal height was 32 centimeters and abdominal girth was 33 inches. The Leopold grips showed a breech and the fundal grip. The lateral grips showed the back to be on the right side and the ligature to be adequate. The first pelvic grip was suggestive of fetal head in the low pole, and the second pelvic grip confirmed that. The head was not engaged and was freely floating. The fetal heart rate was auscultated on the right spino-umbilical line to be around 140 beats per minute and was regular. Her external genitalia was normal. There was no leaking PVO bleeding seen. There was no abnormal discharge also seen. The cervix was closed, the os was closed, cervix was uneffaced and mid position, vertex was high up, and the pelvis seemed adequate. Her preliminary investigations showed the initial blood tests of the fasting and 2-hour postprandial values were normal at the first antenatal visit. At 28 weeks, her OGTT shows a derangement. Her latest scan shows, done 2 weeks ago, shows a single live fetus of 30 weeks in cephalic position with the placenta in the fundal area. The LICA was adequate. Fetal weight was 2.5 kg, BPS was 10/10, and Dopplers were normal. Thus, my case is 30-year-old primary gravida at 32 weeks of gestation with recently diagnosed gestational diabetes mellitus on medical nutritional therapy with inadequate control of blood sugars. And her recent ultrasound and NST done for fetal well-being were normal. The physical examination did not yield any significant abnormality. The vitals are stable. Her fundal height and abdominal girth correspond to the period of gestation by LMP and ultrasound. The baby is in cephalic presentation with the head not engaged. She has now been admitted for monitoring of blood sugar levels and initiation and titration of insulin regimen for optimal glycemic control. So this is my diagnosis of a patient at primary gravida at 32 weeks in cephalic presentation with GDM on MNT with poorly controlled blood sugars. After admission, we have been monitoring her blood sugars, and on the first day after admission, we can see that her, most of her readings were high. So she was started on a basal, basic dose of regular insulin combined with intermediate insulin at night, and the dose was titrated according to the blood sugar levels. And on the last day, we have achieved euglycemia, normoglycemia. So this is the dose that we are continuing her on now. Yes, ma'am. That's it, ma'am.
Renali, can you just go back one slide? The sugar profile that you did in the hospital before insulin was started. I think it was towards the next. Towards the end, beta. Yes, the one you were monitoring in the hospital, na?
This one.
Yes, this one.
So, would you like to change your provisional diagnosis?
Ma'am, she has very high fasting blood sugars, which could be an indication of that she might have been an overt diabetic.
So what is overt diabetes and what are the different terminologies used for overt diabetes? This patient is a case of overt diabetes or GDM? Now you tell me.
Ma'am, according to different criteria, ma'am, she might be considered an overt diabetic if we consider her fasting blood sugars over 127 on 2 occasions. But ma'am, I think like she would fit into the criteria of gestational diabetes more because her initial sugar values were normal.
Beta, the thing is that you all need to remember that there are 2 types of diabetes: diabetes in pregnancy and GDM. If at any time in the antenatal period, during labor, after labor, or in non-pregnant patients, if the fasting is more than 126 or more, or any time, if it is random, postprandial, post-glucose, more than 200, then straight away you need to label the patient as type 2 diabetes. Okay, not type 2, it can be type 1 or type 2, but it is an overt diabetes, which is also known as diabetes in pregnancy and pregestational type, which is of 2 types, type 1 and type 2. So this patient, Bachi, is a case of overt diabetes, right? So Harsha ma'am can ask first, then I'll ask.
Going to manage. Hello, can you hear me?
Yes,
hello,
ma'am.
Vicky.
Yes, ma'am.
So, Mrinalini, how are you going to manage your patient now?
Ma'am, we will keep monitoring her blood sugar levels twice a week or on every third day with a fasting and a postprandial 2-hour blood sugars, and they should be within 95 and 120. If and her insulin doses can be titrated accordingly.
When you're giving her insulin, will you advise her for the diet monitoring also?
Yes, ma'am. Ma'am, she was already diagnosed as just GDM, so she's already been counseled about her diet and exercise regimen. We can further reiterate that to her on the importance of maintaining a proper diet.
So Mrinalini, how frequently will you monitor her glucose levels?
Ma'am, glucose levels can be monitored on every third day with a fasting and postprandial blood sugar. The target should be...
Fasting and postprandial is recommended? You are sitting in a tertiary center. So are you doing only fasting and PP once? What are the
Ma'am, that is once she is well controlled. When she is admitted and we are titrating the doses, we do a 7-point blood sugar level, which is before a fasting blood glucose, before every meal, 2 hours after every meal, and 1 at 2 a.m.
Correct. So, but once the patient is stabilized, then you have to do at least 3 or 4. Which one is
we
more
can do a staggering. We can, ma'am, the postprandial has more is more correlated with the adverse fetal outcomes. We can do a staggering approach, ma'am, where we do the fasting one day, the post breakfast one day, post lunch one day. Over 3-4 days, we can distribute it to get an idea of her control.
Beta, initially you should, what we do in our practice, even in Lady Harding, we are doing at least 4 times. Fasting, and you know, the levels vary so much. They eat more in the dinner time, most of the times, and we see that the levels are much higher in the dinner time. Once, this is only 3 days now, you have control. So you need to monitor a little bit intensively in the beginning. And then you can go on rotating and staggering. And as the period of gestation will increase, the amount of glucogenic hormones will also increase. So you need to titrate accordingly. Sirf ek bar might not be sufficient. That is what FIGO and ADA all guidelines say, except our Indian guidelines. So it has to be dependent on in which center you are doing, how much monitoring a patient. Even our illiterate women are able to do a self-monitoring of blood glucose. That is what I feel. Ma'am, what is your opinion, Dr. Harsha?
I also think that it should be done at least 4 times, because we have to see, because as Dr. Picky has already said, that there can be variation in the blood sugar levels. So that is how that we have to see that she's monitoring the sugars well and keeping her sugars monitored.
Okay.
Beta, what is the importance of doing at 2 a.m.? You have also done at 2 a.m. No? Why do we do it at 2 a.m.?
Ma'am, to differentiate whether the morning hyperglycemia is because of the Somogi effect or just because of physiological increase of blood sugar levels. It helps to differentiate. So according to that, we can either increase or decrease the night dose of intermediate insulin that we are giving.
If she is getting hypoglycemia at this time, at 2 a.m., what will you do?
Ma'am, if she's getting hypoglycemia, then and the morning sugar shows hyperglycemia, that means her night NPH dose is too much. That's why she's having a compensatory hyperglycemia in the morning after having hyperglycemia at night. So we need to reduce her night dose of NPH. If she's having normoglycemia or hyperglycemia at night, that means our night dose of insulin was inadequate. So we need to increase the NPH dose.
Correct. That is a very important point, and we must do it in once or twice in every week. That is what we are doing in clinical practice.
Secondly, I think, Mrinalini, it's very important that whether we are doing 1 hour postprandial or 2 hours postprandial. So which one you will prefer, Mrinalini?
Ma'am, the 2-hour postprandial is more widely accepted, ma'am. The 1 hour is not that much accepted these days.
Why?
So the variation, ma'am. I'm not sure, ma'am. I think the variation is more, 2 hours is more standardized.
Because whenever you're doing this thing, test and all, then you're seeing that in the GTT also, that where the blood sugar levels are high, whether it's at 1 hour or 2 hours. So accordingly, then you'll have to see that whether your sugars, if it was high at the 2 hours, whether your sugars are normal or not, if it is after 2 hours, right?
Correct, ma'am.
Rinaldi, what was the screening or diagnostic test that was used in this case?
Ma'am, we used the WHO recommendation of a fasting 75 gram oral glucose challenge test, and the 2 hour blood sugar was taken, which if more than 140 would be gestational diabetes.
Which is that criteria? That is?
Sorry, 153.
Criteria. What you are saying is the DIPSI criteria, but what you showed was the IADPSG or WHO criteria. That is the International Association of Pregnancy Study Group, which the criteria that you had shown. In that you have taken a 0, 1 and 2 hours. And you have taken 3 readings. Just see here.
Yes,
Am I right?
Yes, ma'am. Correct.
This is not the DIPSI criteria. We all need to follow the DIPSI criteria, which has been recommended by the Ministry of Health and Family Welfare. Okay, and not this criteria. So you should also be knowing what are the drawbacks of the IADPSG criteria and what are the advantages.
Ma'am, the IADPSG criteria was based off the HAPO study, which included multiple ethnicities, but it did not include our ethnicity, the South Asian population much. And we have a much higher prevalence of diabetes than their populations that were studied. So our cutoffs may be much lower than the findings that they came up with. That is one thing, ma'am. And they took an arbitrary cutoff of 1.75 odds ratio for neonatal outcomes. So that was just an arbitrary cutoff, but levels lower than that also, there might be adverse outcomes. So we should be wary of that also.
Very good, very nicely answered. So our DIPSI criteria is based on odds ratio of 1.5. And if you will see the FIGO guidelines, it clearly says that the adverse feto-maternal outcomes are more associated with odds ratio more than 1.5, which is 140. And the NICE guidelines, the old WHO criteria and DIPSI, out of the major 6 guidelines, 3 are recommending 140 at 2 hours. So the explanation that you have given is very good. I'm very happy with your answer. Okay, so what other insulins are there in the option? Which are the insulins which are safe?
Ma'am, we could use rapid-acting insulins like Lispro and Aspart, which will help control our postprandial spikes. Or and in the long-acting, we can use the intermediate NPs that we have, or other long-actings like Dargine and Detamir can be used. Also, there's a mixed, pre-mixed insulin of a 70-30 ratio containing both short-acting and long-acting combination.
So what are the advantages of using rapid insulin over regular insulin? Is there any advantage?
Yes, ma'am. The rapid insulin's pharmacokinetics are a little different than the regular insulin. The regular insulin needs to be taken at least 30 minutes before a meal because it takes a little longer to peak, and the effect stays around 4 to 6 hours, while the rapid insulin can be taken around just 15 minutes before the meal or almost with the meal. It has a very it peaks very fast, and it falls also. The action doesn't linger for a long time, so there is no inter-meal hypoglycemia that we might have to deal with. It is less in the case of the rapid-acting insulins. Regular insulin, we might there is no hypoglycemia in between the meals.
Absolutely right. So, Mrinali, would you have preferred to give her metformin instead of insulin?
No, ma'am. At this stage, when she's 32 weeks and she's already been given a trial of MNT, and her sugars are quite drastically increased, like the 2 hour postprandial was 190 on the OGTT itself. So we would like to go directly for insulin, and metformin would not be a fit option for her at this stage.
So you're very right. What are the, I want to know what are the absolute indications where you need to start insulin? In this patient, you should not have waited for 2 weeks for MNT to act. Why am I saying that?
And because her initial OGTT itself showed a 2 hour of fasting of 118 and 2 hours of 190, which is quite high. So we could have started her on insulin at that time.
So beta, there are certain indications, like if the fasting is more than 110, the PP is more than 120, or if she has polyhydramnios, or she has macrosomia, or any of the vasculopathies, nephropathy, retinopathy, or high BP, then you should not wait for a trial of MNT for 2 weeks. Okay, you should straight away go for insulin. So in this case, we had this problem. We should not have waited. We could have started MNT along with insulin.
Also, ma'am, if a patient is in labor or she's being given a course of antenatal corticosteroids, we need to directly start on insulin at times like that.
Can you control DEXA hikes of sugar on dexamethasone with metformin?
No, ma'am. We need to titrate it according to the level of sugar at that time. We need to continuously check her sugars and then titrate the insulin dose.
Correct.
Ma'am, so in the management, along with her, the target of maintaining normoglycemia, we also need to monitor the fetus if any time that in any development of signs of preeclampsia or any polyhydramnios or macrosomia that we might be developing. If we come across any of these, they need to be treated accordingly, and the mode of and timing of delivery needs to be determined accordingly.
This particular patient, beta, fetal monitoring. And any other investigations would you like to do for your patient, for the mother and for the baby, for this particular patient?
Ma'am, since her sugars were so high, ma'am, we could also screen her for nephropathy, retinopathy, and other vasculopathies.
We must. She is an overt diabetes. We must.
So we must do a fundoscopy, ma'am, and check her creatinine values, check her for microalbuminuria, and check her feet for any diabetic foot that might be developing that she is not conscious of. Also, the baby must be checked. She must be treated as a case of high risk pregnancy, and the baby should be monitored. The fetal growth should be checked every 3 weeks at least. And NST monitoring should be done bi-weekly. We could do BPS or Doppler studies to look for any problem developing in the baby.
Okay, I would have been very happy if you had shown the growth charts. Dr. Khurana so nicely told about all the monitoring. So if you had marked that, we would come to know the velocity growth. So it is very important that serial ultrasounds are done. How frequently would you like to do for screening for polyhydramnios or macrosomia?
Then a minimum of 3 weeks gap has to be maintained between the.
Correct. So which one is more accurate, the clinical examination or the ultrasonographic monitoring?
Then our clinical examination will give us the first clue to go and aggressively treat or do a scan and confirm our findings. But the ultrasound on the abdominal circumference is a very good indicator of macrosomia development.
Both are not very sensitive, but if you do it serially by the same sonographist, ultrasound person, then that will give a better accurate. Any other new markers of macrosomia? AC, we have been reading for such a long time. That is one marker. Any other new markers, beta?
I don't know, ma'am.
Beta, the new ones are bis acromial diameter. That is the Yusuf's formula has been given, and we can do a 3D ultrasound now. So the fractional limb and the subcutaneous fat can also be seen. That also gives a very good idea about the macrosomia.
Okay.
So you were talking about dexamethasone coverage, right? So
Yes,
if in which patients you would like to give and what precautions you will take?
Ma'am, in patients that we are anticipating a preterm delivery before 34 weeks, antenatal corticosteroid coverage is recommended by most bodies. In the late preterm, like 34 to 37 weeks, there is a debate between development of lung maturity and neonatal hypoglycemia that might occur because of corticosteroids. So we need to discuss with the patient and her relatives and do a risk-benefit discussion and then go for antenatal.
what precautions, beta? What are the risks and the benefits you are going to tell this patient's husband and the patient herself about this case when you are planning to give dexamethasone?
Ma'am, we have to tell them that infants of diabetic mothers are prone to respiratory distress because the surfactants is not produced properly because of hyperinsulinemia. So they might need help. They might need help in lung maturity, which is why we recommend antenatal corticosteroids. However, some studies have shown that later on these babies might have neonatal hypoglycemia. So that is a complication that we have to be aware of. And if they would like to still go ahead with it, before 34 weeks, it is mandatory. But after between 34 to 37 or later, we can discuss with the patient and her relatives and then come to a decision.
You said later than 37 weeks. Would you like to?
Up to 39 or 40 weeks, ma'am. If she's well controlled, then we can wait till 39 or 40 weeks and wait for the lungs to mature on their own.
So after 37 weeks, there is very little role of giving steroid cover now. But you are right, between 34 to 37 weeks, late preterm, the Society of Fetal Medicine says, yeah, we can take a shared decision. So, beta, there are also chances of diabetic ketoacidosis. So, how much the doses vary and how frequently you monitor the blood sugars or anything else during this time?
Ma'am, if a patient is on insulin already and we are giving her dexamethasone cover, then on the day that we started the dexa, the night dose of the insulin could be reduced by 40%, and the next day we reduce it to around increase it to 20%. And then after that, around 20 to 10% we increase it, and we gradually bring it back to normal after the effect of the dexamethasone has gone, which is around 3-4 days, ma'am. We continually check her blood sugar levels during this time to ensure that there are no spikes or drops in her blood sugar levels.
Is there any role of doing HbA1c in the pregnancy to see for the control of sugar?
Ma'am, the pregnancy is a very dynamic condition, and we need to know the blood sugar level and the status of the patient at that time. HbA1c has a role in the first trimester or periconceptually, especially in women who are over diabetics, and in them we can help prognosticate the risk of congenital anomalies, because the HbA1c will give us an idea of the past 3 months how her sugar has been controlled. If it has been grossly uncontrolled, then there is a higher risk of anomaly, so we could counsel her according to that, and she could take a call for maybe an MTP also in that pregnancy. But later on in that pregnancy, when we want to titrate the dose or we want to keep checking her blood sugar status, then we need to do tests like the oral glucose tolerance test, which will give us a real-time value of the blood sugar levels at that time. The HbA1c can also be altered in pregnancy because of other factors like anemia or dilution or the high turnover rate of RBCs in pregnancy. And the lab that you do it from could also result in an altered report. So we don't rely too much on HbA1c, ma'am, for gestational diabetes especially.
Very right, Mrinalini, but I think by mistake you said you will be monitoring by OGTT. You will be monitoring by self-monitoring of blood glucose. Not by, you can't do OGTT again, it will be not ethical. And how frequently should we get a venous sample also done? Or there is no need to get a venous sample done at all?
Ma'am, beach we need to do a venous sample also to make sure that our glucometer is calibrated. Maybe once a week we could do send a sample to the lab as well.
And if 1 or 2 readings are coming above the level, what should you do? How frequently the levels should be changing when you need to titrate? Or what do you do when only 1 or 2 readings are deranged higher than the target? You said 120.
Ma'am, they should still be considered because they might be a reflection of hyperglycemia at other times when we are not testing. So we should also consider. Even a single rise as significant.
So if there is 1 single rise, would you titrate? Would you increase the dose? What you need to do is, when you are getting 1 or 2 readings high, just ask the patient, did she take some extra food? Did she have a juice or something different from the diet? And you can titrate the diet, Sometimes, the breakfast, after breakfast, the levels are coming very, very high. So you can tell them that the portion can be split into 2. She can take at 7 a.m. The rest she can take at 9 a.m. Or she can do a little bit of exercise. Try to see all these things, whether she is having some infection so that it is causing hyperglycemia, or she has taken some a different type of food. Yeah, let's say she has eaten something. Dietary history, I think, is very, very important. So give lot of emphasis, spend some time in explaining the diet history to the lady. Okay.
Correct.
So which are the fruits which can be, you will recommend to this woman? She's asking you, ki, ma'am, ab mujhe khana kya kya hai? So what fruits are not to be taken and which fruits she can take free?
Ma'am, we have to explain to her the concept of complex carbohydrates and simple carbohydrates, and things which are sweet like mangoes and grapes, which they will be are outright restricted for her. But other fruits like apples or mosambis, citrus fruits which have low glycemic index, she can take it in moderation. She should take fruits actually in moderation.
Chiku, banana, mango, and lot of watermelon. All these fruits are to be avoided. The others, pears and strawberry, so agar she's from a good class, then she can take all those things.
Guavas, ma'am?
Guavas she can take. Guavas she can take. And everything needs to be in moderation. Bilkul nahi khana is not the dictum. They can take a very small count. And they can reduce the other bit if they want to take once or twice in a week. But of course, what type of milk is very important. You tell them not to take the full cream milk. They have to take a double tone milk. Just see and review their diet every time they come to you. So in the antenatal, when she's coming to you next, so what all things do you monitor during the antenatal visit?
Ma'am, firstly, if she's been checking her blood glucose regularly, we have to look into her chart and see how her blood sugar levels are reflecting. Also, how she's been maintaining her diet, if she's been exercising as she's been advised. If she's checking her fetal movement counts, if there's any leg swelling or any other symptoms that she's developing, if she has any signs of infections like a UTI or any abnormal vaginal discharge, because diabetics are prone to infections, we have to ask for all these histories in every antenatal visit. Also, we need to check her weight gain. If they check her BPs, because preeclampsia and hypertensive conditions are also associated with diabetes. So we have to keep checking and monitoring for all that as well, ma'am.
So what are the other complications which are associated? You named a few. What about the first trimester? If she comes to you in the first trimester, in the next pregnancy, so what are the things you are going to monitor for the baby? And are you going to put her on some other things as well?
Ma'am, if since we already diagnosed her as an over-diabetic, the next time she comes, hopefully she would have done a preconceptional counseling and optimized her blood sugar levels, controlled her BP. And if she was on any oral hypoglycemic agents, we would like to convert it to insulin before she plans the next pregnancy to optimize her sugar levels. We have to target a fasting of less than less than 100 and postprandial less than 140 and HbA1c less than 6 to 6.5 for an optimal outcome in her next pregnancy. Also, we need to start her with folic acid supplementation of 400 micrograms 1 month prior to her planning her pregnancy. Once she gets pregnant, we need to monitor the fetus with the initial dating scan, followed by the NT&B scan or the dual markers, and look for any anomaly, early anomalies.
Any change in the dual markers in diabetic patients?
Then the serum AFP, which may be high in the around 16 weeks, which may be a reflection of neural tube defects. And then later on, we might detect anencephaly early on also, even before the anomaly scan. So certain defects, like Sir had mentioned in his lecture, can be detected early on also. So we need to do very stringent monitoring. Then the targeted imaging for fetal anomalies has to be done at 18 to 20 weeks.
And NT&B scan, you should also look for the uterine artery Doppler and also do the cervical length. Because many times these ladies are having polyhydramnios and they have preterm labor. So do all the comprehensive screening at one time. And one more thing, she was overweight and she's over diabetes. So would you like to start her on aspirin? When?
Yes, ma'am, because she's over diabetic periconceptually, we should start her on low-dose aspirin. She is a candidate for aspirin.
That is something very important in the first trimester itself. You should be, oriented to starting her on aspirin. Should not be too late.
Yes, ma'am.
Then should we be doing the HbA1c in the first trimester? So
yes,
if HbA1c is more than 10, so what advice you are going to give to the patient?
I mean, HbA1c of 10 will has a risk of congenital anomalies of around 20 to 25%. So we must explain that to the patient, and the effect of this hyperglycemia around this time of organogenesis has to be explained to her. And this may result in several problems, maybe placental implantation problems, predisposing her to preeclampsia and also later. So it will be a very high risk pregnancy if she comes early on and we see an HbA1c of 10. She might also want to terminate that pregnancy.
Well, straightforward, you can't say that you get that pregnancy terminated. It's very important that you must do the counseling. So that is very important.
Yes, ma'am.
So, beta, till when will you continue? When will you decide to terminate her pregnancy?
Ma'am, if she's well controlled, that is, her fasting sugars are less than 95 and postprandial 2 hours are less than 120, and the other factors like her fetal well-being, there's no macrosomia, there's no polyhydramnios, the baby is cephalic, there's no malpresentation, the other factors are all normal, then we could terminate by 39 to 40 weeks, not go into post-dated, but terminate her, give time for the baby to mature and allow her to go into spontaneous labor by 39 or 40 weeks. If she has other comorbidities, if she was on insulin and she was uncontrolled, or the baby had
some insulin, isn't she?
Yes,
she's on diabetes and she's on insulin.
Yes, ma'am. For her, if her blood sugars are well controlled and the baby shows no affliction, like there's no macrosomia, there's no polyhydramnios developing, then I could terminate her at 38 to 39 weeks. But continuously monitor her very closely, make sure that she maintains a daily fetal movement count and does her follow-up and all very carefully.
You're very right. The ACOG says that you can continue till 41. But our babies, the placenta becomes mature much faster. And we have all seen that 5 to 6 times higher rate of stillbirth after 38, 39 weeks. So between 38 to 39 weeks, we should take a decision and try to terminate pregnancy. So which route will you use and what precautions you will take? You will take her for cesarean or you will take her for vaginal delivery? How will you decide?
Ma'am, like any other pregnant female, we have to check the other factors like her, the adequacy of the pelvis, her cervical.
There is no fetal-pelvic disproportion. Okay. And the Bishop's is 5.
Ma'am, other factors like if there's any fetal macrosomia, estimated fetal weight of more than 4.5 would cause problems. In our Indian population, even more than 4 kgs could cause problems during delivery. So we might take a call to do an upfront cesarean in those cases. Also, if she has other associated complications like a nephropathy or retinopathy, retinopathy could bleed, proliferative retinopathy could bleed during labor, and also we wouldn't want to put her through labor. We would go directly for cesareans. Now, if there's a malpresentation, in situations like that, ma'am, we would like to go for a direct cesarean section.
So which agents can be used? I said everything is fine. She's cephalic and Bishop's score is 5. So what agent can you use in that pregnancy?
Ma'am, we could use a Serbiprime gel to induce her labor and then wait for and watch for her response.
So you can use any of the agents. You can use Foley's also. You can use Misoprost also. And you can use a Servigel, PG2 gel. Okay, all are fine. So the day of labor, when will you like to induce her?
Ma'am, I would be a little cautious and induce her by 38 weeks. So I don't know.
No. At what time of the day? Sham ko karenge, raat ko karenge. When will you like to do? And
subah
for the insulin and glucose control at that time and during labor.
मैम सुबह को प्लान करेंगे जिस दिन हमें इंसुलिन स्टार्ट करनी है. The night before that we will stop all her injectable insulins, and on the morning of morning of induction, we will check her blood glucose level.
Night you will not stop. You are just giving her regular and NPH, so the action will end. In the
we will
morning,
give her the regular one. The NPH we will omit, ma'am.
You don't need to omit NPH. You are just putting a Cervigel in the morning, na, Pita. She's going to take a lot of time. She's a primey. She will take time to go into active labor. So you will give both regular and NPH in the night, monitor her fasting and electrolytes in the morning, and then tell me what you will do.
And then once we
how frequently during latent labor you will monitor the blood sugars, how frequently during active labor you will monitor?
In latent labor, ma'am, every 4 hourly we have to check our blood glucose levels. In active labor, we have to check every hour and then titrate to maintain a optimal blood glucose of 70 to 100 mg per dl.
Not 100, 120 or 126. ACOG says 120 and the other one says 126. So 70 to 126 or 120 is fine. So you have to titrate it that way. What about giving instructions about she has to eat something, or you will keep her nil orally? Why? And anything else? Would you like to monitor her ketones also?
Yes. Yes, ma'am. If she's been on fasting for a long time, she might develop ketonuria, and labor also predisposes to DKA more. So we have to check her blood glucose and her ketones, urine ketones as well. And we could ask her to have light food. Once we are expecting her to go into active labor, then we might restrict her and keep her on liquids, and then titrate her, keep her on fluids and titrate the insulin if necessary, or sugars accordingly, ma'am.
Latent phase beta, you can tell her to take clear fluids and all, because there are high chances, because the placenta is aging, there may be at any time fetal distress can occur. Okay, so you may have to take her for cesarean. Either you tell her to take things orally, clear fluids, so that spinal can be put and she can be taken for cesarean, or you can give her IV fluids if you think she is very high risk and she may be needing a cesarean. So how do you titrate that dose? And you are correct, we need to monitor her urine ketones. And one more point I just forgot at that time, during the DEXA cover, you have to monitor sugar not just 7 times, 4 hourly you have to do. Because there are very, very high chances that she may go into DKA if you are not monitoring. Or uska beta, about 33% rise is there. So within 12 hours, the glucose levels will start rising, and they may be high till 5 days. So you have to take care of that time very carefully. And here also you have to be very, very careful because if she has hyperglycemia at this time, baby may have neonatal hypoglycemia. So tell me what drips, how insulin, if you want to, do you need insulin in most of the patients?
You might not need insulin, ma'am, because her diet will be restricted. However, she's over diabetic, so maybe her baseline blood sugars itself will be level higher, even if she's has a restricted diet. So our lower level should be 70 mg, and we should, like you said, ma'am, it should be within 70 to 126. If it falls below 70, we could add a 5% dextrose drip, and if it is more than 126, we could titrate it according to a sliding scale and give around, say, 2 to 4 units for every 40 mg rise in blood sugar, ma'am.
Luckily, that is fine. There is a very nice table given in the Indian guidelines. You can follow that. 100 ml per hour ke hisab se you have to give fluid, and as the sugars are increasing, you have to increase the dose of insulin and titrate it. Okay. Suppose she lands up for cesarean, you have taken her for elective cesarean section. Then what all special precautions you will take? How will you give insulin, or will you withhold the dose? Isme kya karna?
Ma'am, if she's a just
things you have to keep in mind for the PAC, pre-anesthesia checkup. What are the problems you anticipate during cesarean?
Ma'am, she might end up in cesarean at the second stage of labor, so that needs to be considered. Also, she might, ma'am, we need to monitor her electrolytes as well, because she has been unrestricted.
Let's come to the elective cesarean. You find that she's had a macrosomia, baby weight is 4.2 kgs, and her pelvis is not adequate. So you have put her electively for cesarean. So this is a very common scenario. So we should all be familiar with, we are all scared ki kya karna hai, insulin dena hai, nahi dena hai. आपका दूसरा case आ गया. So do you need to give her some glucose or DNS? What you have to do? So how will you monitor and how will you decide at that?
Ma'am, if we've planned an elective cesarean, then the night before we stop her long-acting insulins. We give her the regular dose, but stop the long-acting insulins. And on the day of surgery in the morning, we check her blood glucose levels. According to that, we you can give a neutralizing drip of a mixture of dextrose along with insulin, according to the sliding scale, ma'am, given in our guidelines.
Can you be more elaborate? And what are the problems you anticipate? If she's getting, I said, if the other case has come and your patient is delayed, she's not being taken as the first case. So you can add 1/3 the dose of insulin also in the GKI drip, and so that the blood glucose levels are getting monitored properly. In the pre-anesthetic checkup, you have to look for obesity. There is problem in intubation. So anesthesia people have to see very carefully. And you also have to see her BP. Do you think GA is good or do you think spinal will be better?
Spinal will be better, ma'am, from the point of the fetal outcome.
Not just point of fetal outcome, but the corticosteroids, the stress hormone, all those things are released more because of the stress of GA. So all these things are avoided, and the fluid electrolyte balance also get disturbed. So it is much better that we give a spinal anesthesia. And special, have to give antibiotic at the time of incision. That needs to be taken care of. Padding should be good because these women are obese and there are more chances that she may suffer from some nerve injury. So all those things, asepsis, all those things you have to keep in mind when you are taking. And the baby may be big, there may be difficulty in taking out the baby. There may be technical difficulty, there may be, the incision may get extended. So those things you have to take care of. Okay?
Yes,
Post-operatively or post-delivery, what happens to the blood sugar requirement?
Ma'am, if she's a gestational diabetic, usually after the delivery of the placenta, blood sugar levels normalize. We could do check her blood glucose every 4 hours for the first 24 hours. And then on the third day before discharge, we could do a fasting and postprandial 2-hour value and see if her blood sugars are well controlled. If she was a diabetic on insulin like our patient was, we could give her, we could keep checking her blood sugars 4 hourly, and she might need like half the dose of insulin that she used to require prior.
Brindalini, would you like to give a thromboprophylaxis in these patients?
Yes, ma'am, because diabetes is prone to pregnancy itself is prothrombotic state, and diabetic along with that would increase her susceptibility to thromboembolic events, ma'am. So we could give her Tlexane either 40 or 60 according to her body weight.
You can do the risk scoring and see in which criteria she falls, and accordingly compression stockings, early feeding, all those things. You must tell her that after cesarean, as soon as the bowel sounds come, about the early eras. So you should start immediately as soon as possible the oral feeding. And once she takes her first meal, you should put her straight away. If she's a pre-diabetic, like our case, and she was on oral anti-glycemic drugs earlier. So, jo dose pehle le rahi hai, metformin or glyburide, you can start that. Or otherwise, if like in this case, we came to know during pregnancy only that she's over diabetes. So, as you very rightly said, you will titrate 4 hourly, and accordingly, the dose of insulin will just come down quite a bit. 1/3 of the dose may be required. And also, you have to tell her that during breastfeeding, she has to take precaution. She should not go into hypoglycemia. So she must drink, she must take adequate calories, and she must try to breastfeed as much as possible. What are the advantages of breastfeeding, especially in these women?
Ma'am, one is for the baby, we can avoid neonatal hypoglycemia if the baby gets regular feeds, since they are prone to hypoglycemia. Also, ma'am, in a gestational diabetic patient, breastfeeding is shown to delay the onset of over diabetes that occurs in them later on, that they are at risk for. So they should be more aggressively insist on breastfeeding.
Any other importance?
Ma'am, the blood glucose control is better, ma'am, in a lactating mother who's
The
breastfeeding.
blood sugars are really going to come down. Calories are going to come down. So it will help her to lose weight, and it will help her to control her lipids and sugars. And as you rightly said, there has been a study where the women have breastfed and not breastfed at least for 3 months. And that has showed that the progression to diabetes has been prevented to a significant extent. So it is very, very important. Any other, at the time of discharge, any other advice you would like to give her?
Ma'am, we must ask her to continue maintain her diet and exercise, because she's an over diabetic and she's at risk of this persisting and maybe worsening in the next pregnancy also. Also, she's at risk of cardiovascular events, obesity and all later on in life. And ma'am, the baby would also be at risk of all these metabolic syndrome later on in life. So she must be counseled to do an annual checkup and keep monitoring, keep doing her fundoscopies and monitoring her nephropathy, vasculopathy, all the paraphernalia that comes with the diabetic patient. She must be on proper monitoring and follow up.
So, beta, you will call her after 1 year or you will call her earlier?
Ma'am, we will call her for a routine follow-up at 6 weeks, and gestational diabetics need to be checked again at that time with a OGTT. If she is a known diabetic, then we will check her again and see how her glucose levels are, what her blood sugar levels are, and if she needs any modification.
Which OGTT will you do now? And she has come to you at 7 weeks.
Ma'am, the 75-gram OGTT, fasting, and a 2-hour post.
What are the thresholds you will be using at this time?
Fasting of 126 or more, and a 2-hour PP of 200 or more, and a random HbA1c of more than 6.5.
Correct. So we must be very clear. This is different from DIPSI. Don't do the DIPSI test at 6 weeks. Do a WHO OGTT, which is the one which has Mrinali has told us. So her blood sugar comes out to be 160 after 2 hours. Now what will you do? Your patient this is her over diabetes, but otherwise if she was a GDM patient and it comes out to be 160. What will you do?
Ma'am, a GDM patient with the postprandial 160. Ma'am, then this would fall under impaired glucose tolerance. So we could consider putting her on, ma'am, oral hypoglycemic agents till it normalizes, or we could ask her to go for lifestyle modification first with proper diet and exercise if it amends with just that.
She's high risk patient, she has family history, or she's obese and she has had lot of weight retention. Okay, so you can put her on metformin. Otherwise, it has been seen if she does good lifestyle control, metformin and lifestyle control are equally good. We have just 4 minutes left. So, Mrinali, if this patient, your patient, at 32 weeks, you found that she's having macrosomia, still you would like to continue till 39 weeks, or what will be your course of action?
No, ma'am, if she's 32 weeks, I would at least like to cross the 34-week mark and do a continuous monitoring of fetal well-being, maybe twice a week, or increase the frequency. If the baby is well, I could try and continue till 36 or 37 weeks and then deliver by cesarean section. If I see fetal distress at any time or any worsening of the macrosomia, any additional polyhydramnios, then I could consider giving an corticosteroid regimen and then delivering her before 37 weeks also.
You are not correct, Mrinali. See, the macrosomia baby, this means that metabolic mode derangement is there.
Yes.
So you cannot just deliver her after 34 weeks. The lungs will not be mature at all. You have to continue till 39 weeks at least, 38 to 39 weeks. Usse pehle karenge to lungs will not be mature, and it has been seen that the cervix will not be ripe. So she will end up into cesarean section. So all the ACOG guidelines says, and what we do practically is, I ask this question because my resident keeps on asking, ma'am, she's macrosomia. When will we terminate? Should we put gel?
Won't these macrosomic babies be more at risk for a sudden IUD or a stillborn?
Yes, definitely.
Yes, they are.
FGR hai ya macrosomia hai ya polyhydramnios hai.
39 तक खींचने में हम थोड़ा
39, 38, 39 के बीच में कर दो. At least 38 weeks cross करा दो. so that she's in a good term wala thing. Because usse pehle to bahut problem ho sakti hai na. And if she is having very irregular or drastic sugar changes, then you can give her a steroid cover and then only you will terminate. Okay, so you have to be very, very careful in these patients. Two lines more. I want to ask you, metformin kaise shuru karna hai, and which are the conditions where you will not give metformin? And is it safe now to use metformin during pregnancy?
Metformin.
Because I see a lot of private practitioners, even we are now writing metformin. So is it safe? What precautions? And in which cases not to be given?
Ma'am, both the oral hypoglycemics that are in use, the metformin and glyburide, are both category B drugs. We don't know the long-term effects on the baby right now, but they are being used off-label. And our Indian guidelines also recommend its use because compliance with insulin is very less. So there are certain advantages of the oral hypoglycemic agents, and the convenience to use is a big factor. So they are being recommended and used in certain conditions. But there are certain conditions where they will absolutely not work, like an over diabetic will eventually require insulin, or like you said, ma'am, a type 1 or type 2 diabetic, they will eventually require insulin. There are certain conditions like if we've given her a trial of MNT and she's not controlled, it's better to go for insulin rather than metformin. Another very common situation is with PCOS patients on metformin. The metformin is continued through the first trimester, I believe, too, ma'am. But the literature is very divided.
Pregnancy, and there are a lot of papers. This is a very gray area, you know. If you stop metformin, you see that the patient definitely develops GDM, hypertension. So it's a very gray area. There are a lot of studies which say that you can continue it throughout pregnancy. And the important thing I wanted to point out in this forum is that Indian guidelines always said that metformin can be used. The ACOG and ADS guidelines said that long-term safety effect is not known. And none of the regulatory bodies had approved it for use in pregnancy. But the stringent, very strict European Union has just given clearance to metformin after a finished trial in which a number of women were tested long-term, and they did not find any perinatal complications. So they have said that you can use it safely throughout pregnancy. And the NICE guidelines say pre-conception se leke throughout pregnancy you can use. And now these two regulatory bodies are saying, so we have a leeway. But just remember, one last line I will say, in patients who are having fetal growth retardation, or in women who are having preeclampsia, where there is a risk of fetal growth retardation, okay, or preeclampsia, in those women, please do not use metformin, but because it causes less weight gain for the baby, and it disturbs the pyridoxine metabolism, so it can have a negative effect. So it is contraindicated as told by AD also, and it should not be used in pregnancies where you are suspecting a fetal growth retardation. And the indications we just discussed in the beginning, jisme seedhe insulin use karna hai, in those patients also we should not use it. So I think, ma'am, we have finished on time.
Yes, we could. It was nice. I think, Mrinalini, you have done well.
Very well.
She has answered most of the questions, almost all the questions she has
Very
answered.
good girl, beta. Very well done. Sare topics aise karo.
Okay, I want to thank moderators, Dr. Harsha Kullar ma'am and
Dr. Piki.
Dr. Piki ma'am for this great highlight in diabetes in pregnancy, ma'am. It was really informative for us listening also. Now I would like to go to the another rounds, Workup for an infertile couple. The moderators for the next 1 hour, Dr. Tanya Bakshi. She is principal consultant IVF reproductive medicine and oncofertility in Max Super Speciality Hospital, Delhi and NCR. We have Dr. Shweta Mittal. Next slide. And Dr. Ruma Satvik, ma'am, is also a consultant in Center of IVF and Human Reproduction in Sir Gangaram Hospital. And I would like to introduce Dr. Ifat Irsad. She is also second year DNB trainee in Institute of Obstetrics and Gynaecology, Sir Gangaram Hospital. Now to Dr. Ifat.
Hello. Hello. Am I audible?
We can hear you. Please go.
Hello.
We can hear you, Irfan.
Am I audible? Please share the screen. Please, Mr. Vita, please share the screen. I'm Dr. Ifat, and I'll be presenting a case about workup of an infertile couple. Please, next slide. Mr. Vinod, I'm not able to read my slides. So my patient, Mrs. X, 28 years of age, housewife, resident of Karol Bagh from New Delhi, is the wife of Mr. M, who is working as a laborer. She belongs to a lower socioeconomic status by modified Kuppuswamy scale. Her history of infertility is from last 2.5 years. She's a nullipara, presenting complaints that she wants to conceive, and she's trying to conceive since last 2.5 years. History of present illness. My patient is trying to have a baby since 2.5 years, but has failed to conceive despite having a regular intercourse with her partner. After marriage, they avoided the pregnancy by barrier method and the withdrawal method for the first 6 months. She has regular cycles, and they have been living together since marriage. About her menstrual history, she attained her menarche at age of 13 years. Her cycles are for 5 to 6 days and every monthly, about 25 days, regular with an average flow. She has mild dysmenorrhea on the first 2 days of the cycle. Her last menstrual period was on 27th of April, 2023. About her obstetric history, she's married for 3 years. She's nulli gravida, had used barrier method as a contraception for first 6 months of her marriage. Her medical and surgical history, she's a known case of hypothyroidism and is on 25 micrograms of thyronol for 1 year. There is no history of tuberculosis, diabetes, hypertension, galactoria. She has no history of any headaches or visual disturbances, no surgical history in the past. There is no history about the family history. Her mother is a known case of diabetes. Her sexual history is that they are living together, and their frequency of practice is about 4 to 5 times in a week, and there is no history of dyspareunia. About the personal history, she takes a mixed diet with normal appetite. There are no sleep disturbances. They have a normal bowel and bladder. She has a normal bowel and bladder habit. There's no history of smoking, alcohol intake, drug abuse, or she has no drug allergies. About the husband, he's a 30-year-old male who is working as a laborer, and this is his first marriage. There's no difficulty during sexual intercourse. There's no history of undescended testes in the past. There's no history of orchitis, mumps, or any chronic respiratory disease in the past. There is no history of diabetes, no history of thyroid disorders, no history of hypertension, no history of any recent fevers. There's no history of abdominal surgery or any urogenital history in the past. No history of exposure to any chemo or radiotherapy or drug abuse. He's not having any history of drug abuse or smoking. Occasionally, he takes alcohol. About the general physical examination of female patient, conscious, well-oriented to time, place, and person. She has an average build, well-nourished. Palpation was adequate. Her BMI was 24 kg per square meter. Her spine and gait were normal. There was no pallor, icterus, cyanosis, clubbing, lymphadenopathy, or edema. Her vitals were almost normal. Temperature was normal. Her pulse was 82 beats per minute, regular, good volume, and normal in character. Her blood pressure was 110, 170 in the right arm in the sitting position. From head to toe examination, her hairline was normal. No graying of hair was there. There was no hirsutism. Facial features were normal. Thyroid was normal. There was no acne or acanthosis nigricans. Breast examination was normal. There was no mass palpable, and no axillary lymphadenopathy or breast discharge. Regarding other systems, cardiovascular, respiratory, and CNS, they were grossly normal. On abdominal examination, on inspection, she had a flat abdomen with central inverted umbilicus. All the quadrants were moving equally with the respiration. There were no visible mass seen. On palpation, abdomen was soft, non-tender, non-distended. There was no organomegaly, no palpable masses. Hernial orifices were free. On auscultation, bowel sounds were normal. On examination of the external genitalia, on local examination, external genitalia seemed to be normal. There was no vaginal septum. Hymen was admitting 2 fingers. On speculum examination, cervix and vagina were healthy. On pervaginal examination, the uterus was antiverted, normal in size, mobile, bilateral fornices were free. In summary, my patient was 28-year-old female with complaints of primary infertility since 2.5 years with known case of hypothyroidism. On examination, she had an average build with normal general examination, and her pelvic examination of uterus was antiverted and normal in size. So my differential diagnoses were unexplained infertility, female subfertility, or male subfertility.
I think, is that the end?
Yes, ma'am.
Dr. Tanya, would you like to lead the discussion?
Yeah, I'd like to ask a bit more about the history. Do you think there's anything in the history that you missed, something very pertinent with fertility patients?
Ma'am, actually your voice is not well audible. Can you?
Anything you think that is pertinent that would be left behind in history for a subfertile or an infertility patient? You've given the history, a lot of examination you've done. There's a very important point missing in the history. Can you think of something? So I'll give you a hint. You talked about menstrual history and you said regular 25-day cycles, right?
Yes, ma'am.
So whenever you ask a history, a menstrual history, would you like to know that's normal for her? Is 25 days normal? Is there any change in the pattern? When was her menarche? Was the 25 days usual for her? Was it 30 before, 25 day now? Was it 40 before?
She told me her menarche was at 13 years, and since then she is having the cycles of 25 days and 25 days, and they remain there for 5 to 6. She had not felt any change in her menstrual cycle. This was the norm since her menarche. Before when she had attained the menarche, she had some irregularity at that time, but after once they had started on a regular basis, it has been similar from since then. There was no change in the pattern.
Then you talked about dysmenorrhea. Can you tell me a bit more? Is dysmenorrhea important?
Quite about the dysmenorrhea. I inquired about the dysmenorrhea from her. I asked her when exactly you are having the pain. Like, is the pain starting before your menses? Like you have a cramping and you're not able to tolerate that. She told me, no, there's mild pain. I don't need the medicine. I just take the rest. And for first 2 days, when they start normal cramping pain, and then it goes off. I don't usually take the medicine. It was that mild type of
So would you
dysmenorrhea.
like to edit and add again? So if I were to say now you give the menstrual history, how would you say the menstrual history now?
I would like to say like she had a cycle which remained there for 5 to 6 days, and there was no change in the cycle pattern with regular cycles since her menarche, and there was mild this primary type of pain.
Any medication? You're saying she doesn't need any medication?
Yeah.
Right? So it's not a severe dysmenorrhea. Dysmenorrhea can give us a lot of information in history itself.
Yes,
now, 2 other points, Ruma, do you want to add or can I ask? 2 more points in history, actually, I want to ask her.
Yes, please go ahead.
Okay. So the only history that you've given is mother and diabetes. Is there any other history you want to ask a woman's mother when you ask any infertile patient?
I asked about the premature ovarian failure in her mother.
How do you ask that to someone who's a laborer? How do you ask?
I told her what is the age of her mother. She told me she's in her 50s, and I told her when her period stopped. She told me actually I don't know that much, but she had periods. I know she had periods like 4 or 5 years back. She told me like that.
Any other history in the family which is important? You've not touched upon again some important histories?
About mother having the PCOS features, like her mother was obese. She has because she has the diabetes, that is the late this complication of PCOS. She is having a type 2 diabetic patient. So I asked about the PCOS features, whether she has some hair growth on this, and whether she had some irregular pattern of the bleeding. She was not that much sure about that.
Any other history? Family history. I'll again give you a hint. Family history pertinent to people who are trying to attempt a pregnancy. Your center at Ganga is known for it. You have a very big genetics department, isn't it? And that genetics department, I'm sure you do send some people there.
Yeah, genetic history.
What is important in the history?
Yeah, they didn't have such because she was. Yeah, I asked about that.
What history do you ask? Please tell me.
Yeah, I told her, did your mother also had the same problem?
Apart from mother, is there anybody else in family?
She had one brother, and he was younger, not married yet.
So how do you ask for a genetic history?
I told her about the mother only. Mother and her khala, did they have any problems while conceiving and all? She told me no, nothing.
Father, she has a dad also. There's no mention of any history of dad.
Father was fine. He didn't have any comorbidity, so she just didn't say anything about.
So very important in a subfertile, you have to take a genetic history, which was lacking. Something else which we can pass on. Have you heard of multiple pregnancies and twins? People having a history of that?
Yes, that usually asked. There was no history of multiple pregnancies.
You have to ask and you have to write. Very important. So there must be, how do you know? She may be a twin, she may have a twin sibling. We get a lot of patients who have a history of multiple pregnancies on either side, both from the girl's side and the boy's side. So you have to ask the wife and the hubby. Was it a consanguineous marriage or anything in any distant relative?
No, it was not a consanguineous marriage.
Okay. So very important when you take history, especially of the mom, please note of the dad also. Very important to know about anything in terms of miscarriages or any genetic illnesses or any multiple pregnancies, because that gives us the first hint when you're taking a history. So this is extremely important from a history perspective before you move on to even examination and testing. Ruma, any comments?
I'll just kind of, because there would be about 60 or 70 students out there, we are just going to touch upon certain features that you look at in history in detail. So starting with, what's your diagnosis, Sifat?
Ma'am, like she told me from the history, I could not gather any, only she had hypothyroidism, one point that was pointing, and the other thing, they were also living together, and that too they had a frequent contact with each other. So I could only gather, just if I take my history only on the basis, they could have unexplained infertility because they were living together. That is my first diagnosis. But yes, about the male history, as males are not that open to us, I need to send him to the urologist for further examination, whether he
Not straight away.
What is your diagnosis? You tell us. This is a 28-year-old lady with infertility of 2.5 years duration, yet to be investigated. No cause found in history or examination yet. Okay, I get a picture of what we are dealing with. 28-year-old woman with infertility of 2.5 year duration, with no cause found in history or examination, and yet to be investigated further. So if I am looking at, let's say, the age, and why is it important to outline the age of the individual, of the woman? So 28 versus, let's say, 36, would it make a difference in your workup, in your advice, in how to kind of approach the case?
Yes, ma'am. Like there is already a delay in the investigation part, which should have been started after 1 year. They have not conceived. There is a delay. But if he would have been a 36-year-old, we should have started investigating from after 6 months if she had not conceived. So this is.
So tell us about it, the definition of infertility, how it varies with respect to age. Female.
Okay. Infertility is defined and when the couple is not able to conceive for at least 2 years, despite incessant and living together for a whole period of time, incessant intercourse. If they do not conceive, so that means she is infertile. But we have to stop.
Can I just stop you for a moment? Please say regular, don't say incessant. We don't use that word. So just regular sexual intercourse is good enough.
Like regular sexual intercourse. For a couple who is less than 35 years, we need to evaluate from the after, if they have not conceived after 1 year of age, and we have to tell them about the rate of conception. Like in the first cycle, only 20 to 25% of the couples can conceive. After 3 months, there is a possibility that 50% can conceive. After 1 year, around 75 can conceive, and after 2 years, there is a possibility that around 90% can, 85% can conceive. So this figure we have to explain to them. But if it's already more than 2.5 years and they have not conceived, we have to tell them we need to investigate you both.
Okay, just a small correction there. When I would say it's a major correction, when you define infertility clinically, the duration of trying regular unprotected intercourse with the intention to get pregnant should have been 1 year.
1 year.
Beyond 1 year, you start suspecting there's something wrong and you start investigating. For women who are older, above 35, the duration that is specified that they should have tried for 6 months at least before you start investigating. Unless there is a known cause. Let's say, unless there's a known cause, what would it be? Two individuals of the same sex, they cannot conceive, or the male giving the partner, giving the history that there is erectile dysfunction. They have not been able to consummate marriage yet. That is reason enough for you to start investigating the male at this point, or look for causes that might be leading to vaginismus, or other reasons why intercourse may not have happened. So basically, we're looking at under 35, more than 1 year of trying, and over 35, 6 months of trying. Right. Now, the next thing is we are looking at duration of infertility. You have already linked it to the definition of infertility, 1 year or more. And you've also given us a prognosis for pregnancy at certain ages with duration of trying. So longer duration of trying, let's say 7 years of trying and no pregnancy, there is a prognosis for a spontaneous pregnancy
This pregnancy decreases as the duration of intercourse increases. The chances of spontaneous pregnancy also decreases.
So the figures again, when we talk about prognosis, are for women under 35, it is at 85% spontaneous conception rates by the end of 1 year of trying. And of the 15% that are remaining, about 50% of these, that's another 7.5, would have conceived in the second year as well. So if someone has moved from 1 year of trying into the second year, and they are young, and sort of they're not very much into, they're not panicking yet, and they've come to you for advice, is it okay to try another year? And you have done a thorough assessment of history, you've done a thorough examination, you've ordered some basic tests, and they come out to be normal, and we will come to the tests in a bit. It is all right to advise them to try naturally, for a spontaneous conception, right? Okay, now the second question I have for you is, which Dr. Tanya has already covered, but we just want to be specific here. You mentioned the menstrual history in 3 parts. One is the duration of bleeding, which is akin to saying volume of bleeding as well. Second is the frequency with which the lady bleeds, whether between 25, 30, 35, and if there is any regularity to this, right? And then you speak of the dysmenorrhea. Dysmenorrhea has already been discussed. You have to talk about what kind, how severe, and severity is best defined by the need to take medicines, and how frequently, how many days, the number of tablets that one would require. So that should automatically be a part of your history. Now, when we come to the first part, which is to determine the volume of bleeding, it could either be, so when we say 7 days of bleeding, or we say 4 days of bleeding with 4 to 6 pads, which is like definitely a heavy kind of bleeding. What does volume of bleeding indicate? What function, which organ function is it indicating?
If the volume of bleeding is more, that means there is some pathology with the endometrium, and there is some sort of endometrial hyperplasia. So when endometrium thickness is there, the bleeding will be more.
What about the myometrium? Could anything be wrong with the myometrium?
Yes, if there are some intramural fibroids that will increase the overall volume of the uterus, and then the volume of the bleeding will also increase.
Answer. You want to rephrase it to something broader? Volume of bleeding indicates the function of?
The overall surface area of the endometrium.
Just uterus, keep it simple. She's asking you simple questions, keep it simple. We talk of the uterus, ovaries, sperms, so keep it simple. Right now, we're at a very basic level. You're doing well, just keep it simple, think of basics, okay?
So when we talk about frequency of bleeding, think and answer, and it's just a one-word answer. Frequency of bleeding, which organ are we pointing to? Which organ's function are we looking at?
Frequency of the bleeding is about the ovarian function.
That's correct. So you're right that frequency, when we talk about frequency, we're looking at the ovarian function. When we're talking about volume, we're looking at uterine function. But like, human physiology, there will be exceptions wherein frequencies of someone bleeding at irregular, unpredictable intervals could also have a uterine pathology like a polyp or a cervical erosion and all, but we'll keep that aside for a minute, okay? We are not going to go into those 5% cases where this is happening. Tell me what happens when the frequency is less than what is defined as normal. Let's say it was between 24 to 26. Versus when the frequency was, and it's at regular intervals, frequency is 32 to 34. You said it's indicating ovarian function. Which one would you prefer the woman to have? Shorter cycles or slightly longer cycles?
Ma'am,
which one is the preferred frequency?
What would make you worry more? If a woman said, I have very short cycles, it's coming every 20 to 21 days, would that worry you more, or every 40 to 45 days? Which one would you be a bit more relaxed about is what Simply Ruma's asking.
Though shorter cycles are bad, but longer cycles in itself are also bad.
Give a reason. Which one and why? Why? And which of the two would be worse? Both are bad. Okay. But which one would you worry about more? Because they both indicate separate issues.
Yes, ma'am. The longer cycles, more of the this crop of the primary this follicles will be used, and the patient will more eggs are used up, and the patient will point out to the PCOD. So more eggs are used up, and she will be having the delayed cycle. Whereas in the shorter cycle, there is not the right I could say right formation of the endometrium. So she will be having the problem with the endometrium there.
Not really. No.
But ma'am, the secreted phase remains the same in both the cycles. That is the 14 days. Ovulation occurs between 14 days before the onset of menstruation. This will be the same, but the change is only in the proliferative phase. And that will be changed. And in PCOD, the ovary looks like that more of the follicles are used up, and the ovarian reserve will be decreased. This is
so short answers, precise answers, and we are coming back to that. Short cycles is pointing to an ovarian function which is low reserve. Longer cycles, 32 to 35, we're not going to 45 yet, 32 to 35 is better result. So sometimes just based on history, you're able to gauge whether this woman is good prognosis for pregnancy or poor prognosis for pregnancy, spontaneous or in treatment cycles. So reiterating these 2 points about menstruation, we said that volume is indicative of uterine function. If the volume was low, let's say she started saying that I have very scanty periods, it's barely half a pad soaked in the entire day, and it doesn't even go longer than a day. What would you suspect? High volume, we've already said hyperplasia, myoma, or adenomyoma. What about volume rate?
Ma'am, I will think about that. There is some problem with the hormones. Like one of the causes for this hypomania or oligomenorrhea is she might be having hyperprolactinemia. There will be.
See, okay, you have to apply yourself to this. In fact, we are talking about uterine function now. The first thing you mentioned was endometrium. Endometrium hyperplasia is leading to more bleeding. What in the endometrium would cause low bleeding? Scarring, endometrial scarring, could it lead to
the history, Leethina, of the very common disease in our country? You said about that history, you've ruled out.
Yeah, she didn't have the history of infection, like she didn't have the tuberculosis. Tuberculosis can cause the synecdoche, and there will be hypomenorrhea in such patients.
So we're looking at that function as well, in terms of it affecting the lining of the womb, which is what Ruma is saying. So keep your history into perspective of the organ, it becomes easier.
We'll have some more questions, and these have to do with, we come to the, after elaborating on period history, what else did you talk about after that?
Then I went to her obstetric history as usual, then on her medical and surgical history in the past, and then personal history.
Vital history, and you've also said that they did not try for 6 months. Now, this is important information, right? So although they've been married for 2.5 years, they did not try for 6 months. Fertility is not 2.5, it's 2 years. And
they are married for 3 years. They did 3 years. Marriage is for 3 years, and they first 6 months.
Yeah. I'm trying to make is you check with them on whether they were using any contraception and whether their coitus is fruitful or not, whether they are aware of fertile period or not. and how frequently are they able to have sex. So there would be couples, and so this is, of course, you said, from a lower socioeconomic strata. There would be others who work in different cities, not able to kind of meet also. So although the duration of marriage is 3 years, you'd find that their actual months in which they have tried may not have been more than 4 or 5 months. And so that it is important to check with the couple on how frequently do they have sex and how frequently have they been, for how long have they been trying regularly. After this, you talked about past history and past surgical history. So here you took medical history, you took surgical history. What else should you have taken? I thought I did not hear it, or maybe you said it and I missed you saying that. If there was any history of.
Ma'am, she has the history of hypothyroidism and she is on Thyronorm 25 microgram. She didn't have any history of diabetes. She didn't have any history of hypertension. She didn't have any history of surgery in the past in abdomen. And
what I thought was missing was a past, whether this investigation or this complaint has been investigated yet, and whether any other treatments have been given for this complaint yet or not. So past history of investigations for infertility and past history of treatment for infertility. That has to come.
Yeah, I asked about that. I told her whether you were investigating. She told me, they gave me they told me to do the TSH and not about no HSC for the husband. Only female was treated, and she was given one ultrasound that showed, that was also done in the local clinic, and that was not telling much about that. Then she told, I have heard about Ganga, there is some infertility center, only they'd give me this medicine for this. And
to this case, but why is it important to know what all treatments has the lady undergone?
It is important because once she has gone to some doctor and the doctor has started some medicines like ovulation induction, we have to keep a track on those, how many ovulation inductions she has received and how many further we can give, from where we have to start, and whether the investigations which are used for this, for working up this couple, whether they have done, or we need to do. Are we repeating those investigations? Have we reached to some conclusion? What we have to go further, not go back from the very beginning and do the investigations again.
Yeah, that's when you have to assess her response. Right, so the treatment is not just where to start off and assess, but you also assess the response. So for example, you talked about ovulation induction. I think we just jumped the gun, but we'll come to that in a moment. I have one quick question. Any pertinent history you've missed out again, and which you should have told us about, both in the husband or the wife? We are in an era. There is a name given to the last 2 to 3 years. Some new virus, some new era, which can impact?
Yes, ma'am. We had a pandemic of COVID.
Fantastic. Do you think it's important? A, because of its implications, and B, if you guys are not asking, very important is vaccination history, right? We're not over it yet. So can you tell me, is it important to even ask the history? Do you ask it?
In this patient, I didn't ask, but all the
important.
Do ask.
Why do you think it's important?
Ma'am, the COVID has caused drastic effects. What it has done to the fertility of the female, we don't know, and more studies are going on that.
What about the man? I think we have not talked much about the man either. Do you know of any studies which has worked upon COVID and about the men and their semen?
Ma'am, I have not gone through it.
Okay, so it's important that you should know, because there are some effects. And for when we are in this era, it's important to know, because you will get patients who've had even severe COVID. So you need to know if it was mild, if it was severe, if it was that bad that they needed hospitalization. What was the treatment given? You remember the first phase when there was a barrage of medications, antivirals, there was a lot which was given. So when we are in today's day and age, very pertinent to also take the history of COVID, to take the history of your vaccination. So make that as a routine when you're investigating and from your history. So in your medical history, you spoke about thyroid.
You asked about tuberculosis. Please add in COVID as well, and add in about what kind of COVID. Was it mild, moderate, severe, or did it need hospitalization? How many times they had COVID? Suppose they just had, and they've recovered, they've had another COVID. You know, the wave has come up again. What if the husband had COVID about a month and a half ago? Do you think that would impact?
Yes, ma'am. Recent, as it is well known fact, like recent, having a history of recent high fevers, the semen volume decreases itself. So maybe if he has
just going back to your history, make sure what is pertinent to the day and age. We are in the COVID era. We should know about that as well. And that is an important past history as well.
Yes, ma'am.
I think, Ruma, should we move on to testing? What would she want to do?
Just in one line, if you can summarize the male history that you have taken, or maybe 4 or 5 lines.
Ma'am, my male patient was 30-year-old, a laborer. I asked about the working environment. He was working inside some factory, not in the high temperatures, and he didn't have any comorbidities like diabetes, hypertension. He didn't have diabetes, hypertension, or thyroid disorders. He didn't have any history of high fevers recently, or he didn't have any past history of mumps, orchitis, tuberculosis, or any drug on any surgical history in the abdomen or the urogenital system. And he was not on any drug. He was not abusing any drug. He didn't have the exposure to chemo or radiotherapy. And
try and be short, one line, because what will happen is when you're actually presenting, abhi to maage hi nahi pahunche, 3 times, just one line. How would you summarize your case in one line?
He's a young male of 30 years without any comorbidities.
And a young couple pe aa jaye, kyunki couple hai.
Yes.
So now you are summarizing by one line what is your pertinent, like you came and said that most likely till now you think it's unexplained, right? So just with one line, summarize your couple.
Young couple with primary infertility and a known case of hypothyroidism in female, and primary infertility.
Duration is very important, bache. She just told you duration is very important.
2.5 years.
And when you say young couple, remember today we are in era, even I'm young, although I'm not 28. So you must say who is young.
35 years of age. Both of them are less than 35 years of age.
So be specific on age, be specific on the duration, be specific on the type, and no significant factors that you've noted on history or examination, right? So we know in our mind, no, you know, we're not getting any red flags. We can move ahead. So very quickly, what's the test you're going to do now? What are you going to do with her? She's sitting with you in the OPD.
I would like to, because this is the first visit, I would like to evaluate both. I will start to evaluate both of the male and the female partners so that I will reach to some conclusion. Like first, let me go for the male. I will give him, I will tell her to do human semen and the this male semen analysis.
Please tell me how to do it. I'm the man.
Okay. I'll first of all counsel the man that this test is to be done, and he has to produce his sample in the lab where he is going for the testing, and the test is to be produced by masturbation, not by the coitus interruptus, or not by producing in the condom, because condom has spermicide, and as it has to reach to the lab within half an hour to 1 hour, and he has to abstain from the coitus for at least 2 to 3 days. He should take a good diet, and at least he should not have any fever and all, and he has to produce. This is what I will take to the male.
Anything else?
So, I think ma'am, I told all the points.
So suppose I say that I'm not comfortable to produce it in a lab and I want to get it from home.
In such case, if I still have to tell him the duration, it has to reach to the lab, that is less than 1 hour, and it has to be produced by masturbation, and it has to reach at the normal body temperature within 1 hour of this.
What do you mean by normal body temperature? How do I put it in my back pocket? I put it in a jar, in a can. How do I get it?
Best is to put it in a pocket.
Which pocket? I have multiple pockets. I'm sure you have home collection samples, Ruma, and in Ganga. How do you tell them? Is there anything else? Do you have a form that you need to explain and sign?
Yes, so they would have taken the instructions from us along with a sterile bottle and a label, which has been put on its body and not its cap. And they would have been asked to, collect the sample at home, not by coitus interruptus, which she's already said. Put the lid on, screw it tightly, and bring it to the hospital within 45 minutes, if possible, by keeping this not in front of their car ACs, but in their front pockets. So as close to body temperature as they can, 37 degrees. So inside their coat pockets, if they're wearing their coats, or inside their shirt pockets, if they're wearing shirts.
And also sometimes these guys come on motorcycles and, they place it on, the bend of the cycle or the motorcycle sometimes can be very hot. So be very clear when you're asking them how they get, okay? Do you ask them to anything, how they wash their hands, how they collect it? How they clean themselves? So they're very important instructions.
Ma'am, we have to ask them not to use soap bubble. Not to use. The term is.
Okay, very important. So this is the basic how you tell a person to collect a sample. So, sometimes you'll be surprised at how they collect it, because what is very easy and simple for us can be tricky for them. So simple instructions, because this is the most important and the simplest test that a man would be doing, right? So let's say he followed the instructions incorrectly and you get a sample with no sperm. Won't that change their complete treatment?
Yes, ma'am.
Okay, so let's say for once you got a sample and the report comes from XYZ lab, which is not your in-house lab, because you could have done it anyway, and it says no sperms found. What would be your next step?
If this is, that will, first of all, this will make diagnosis in my mind like he has aspermia. I will first think that this is the problem with the male.
Would you make a diagnosis just on one report?
No, I will not make, but I will think this is aspermia, no semen. This is my diagnosis, but I would like to repeat the test. If it is aspermia, I like to repeat as soon as possible, so as to reach the conclusion, and will again counsel the patient and ask him how he has taken the test, what has he done, and all the precautions will be explained to him again, and tell him to produce the sample immediately as soon as possible.
Would you look at the of the collected sample? And is there any importance of semen volume? Let's say there was azoospermia. Okay, there was no sperm in the semen sample. Would you be looking at the volume of the collected sample to decide?
Yes, we follow the guidelines which are given. Recently, they have changed in 2021, like from 2010, the minimum volume required was 1.5 ml. Now it is 1.4 ml. And regarding the sperm count,
one drop in the sample. What if you see there's just 1 to 2 drops in the submitted sample? What would you ask the person? You already said it, whether the collection has been
done properly or not, or the sample did it fall down, or are you?
So there's a word, if there's any spillage. Sometimes it's tricky, right? So sometimes you've got to ask them, did they manage to collect the whole ejaculate? So which is what Dr. Ruma is saying. Sometimes they don't manage to collect the full ejaculate, and that's very important, and that should be noted as well.
So that you have checked now. and he says, no, this is what I produce normally. It is always a low volume ejaculate. Okay. So what do you think one can do, or one would want to now investigate if this is low volume?
Ma'am, I would like to repeat this test and will explain, because on one abnormal sample, the male infertility cannot be diagnosed. We need to repeat the test at least 1 month, and we'll have to tell him the same, and he has to take the regular diet and everything. And after 1 month, if the result comes out to be same, then we can think that he has some fertility issues.
Okay. I think
what is that issue she's asking? So he comes again and only produces 2 drops of semen. Then
so we analyze and we'll see the semen analysis. We will evaluate that and go how the semen what is the semen analysis? If like I was saying, if the sperm count is less than 39 per ejaculate, that means he has less sperm and there is problem with oligospermia, or it has less than 15 per million, less than 15 million per ml. Again, is a problem. And if there is problem in the motility of the sperm, like now the guidelines that first there was the motility used to be 40, now it has increased to 42, and progressive
just the volume, it's so less. What comes to your mind?
There is some obstruction in the male genital tract.
Right, that's very good. So basically, low volume means there is an obstruction. It could be obstruction at the level of the epididymis, at the level of the vas, at the level of the seminal vesicles, or where they combine, known as the common ejaculatory duct, or they could have been a history of surgery in the past, which could have led to what kind of surgery? A bladder neck surgery in childhood, which could
yes, okay. That has led to the obstruction of the post-testicular part of the male genital system.
So what we are trying to stress on here is that you don't always need very complex tests to come to a diagnosis. So much of this is incumbent on a proper history and interpreting the results in a way. You don't need the diagnosis to be written at the bottom, but looking at the semen report, you're looking at azoospermia, where there is no sperm. You immediately come to the volume, which is, so you have established that this was properly collected. The male has confirmed that this was collected in the conditions, there was no spillage whatsoever. And so you immediately come to the volume, it's low volume. Low volume, what are the possibilities, especially with no fructose, that the block is beyond the level of seminal vesicle? Is the organ which produces, is the organ which produces fructose. And if you have fructose present and still the volume is low, there could be, what is the answer here?
If there is it's still the obstruction is above that, and maybe there is some obstruction in the vas deferens, or there is some, he has gone for the vasectomy, or he has done, there is some surgery of the hernial repair and there is obstruction in that part.
Okay, so let's move to the next level, because this is going to take a while.
Let's go to the woman. What's the first test for her?
Ma'am, there will be some blood sampling as well as the ultrasound. First, I would like to see the morphology of the uterus and the ovarian volume, antral follicle count. That would like to see in the uterus, any uterine fibroids, polyps that's not allowing her to get pregnant.
When are you going to do this ultrasound, Ifat?
I will send the patient to the radiologist, sonologist, or radiologist.
Okay, when are you going to send? But as a fertility specialist, I would recommend we do all our ultrasounds ourselves. But okay, you're a student, so that's all right. But what instructions are you giving? Please tell me. When should she go? Today, 22. Should she go today only? Should she go? Is there any day, or she can just walk to a radiologist any day?
Ma'am, like this is the baseline ultrasound I will be telling to her. And I would like to mention on her ultrasound that this is her 22nd day of the cycle. So the basic
baseline ultrasound on day 22, I just gave you an example. I'm asking you, now you are sitting with the couple, you've told the man he's done his semen analysis. To the woman, what are the tests that you're going to do? I think we jumped to ultrasound, which is actually an invasive test, but what? So you've got a piece of paper in front of you. Please tell me what all tests, which day, when to do what?
Ma'am,
systematically.
We'll start with the blood tests. I'll repeat her thyroid profile. I will thyroid profile to see if she's really checked by the dose she's taking. Then I'll do her blood sugar levels, if she has any diabetes. And these are the blood tests.
What is important for fertility? Because our time is less. Can you tell us what are important tests for fertility?
Serum prolactin in a way is important, but it's not usually done. And then
what is the first test that comes to your mind?
No, this is not. I am just telling the blood samples which way we take. And the second test, I would like to tell her to go for the HCG, hysterosalpingo.
After blood test, take a aram se. Let's go back. Aram se. Blood test. Let's start. Blood test. What are the blood tests would you want an infertile woman who's come to you, she should do? आपने thyroid check कर लिया, prolactin कर लिया. आपके लिए फर्टिलिटी को चेक करने के लिए डॉक्टर रूमा ने आपको ऑर्गन्स के बारे में बताया था. हमारा फेवरेट ऑर्गन फर्टिलिटी में इज द ओवरी. इज देयर एनी टेस्ट दैट यू विल टेस्ट?
Yeah, ma'am. There are multiple tests. We'll on day 2 to day 3 of a cycle, we'll do the FSH and LH level of the patient, as well as E2 can also be done at that time. We can also do DHEA, dihydroepiandrosterone and testosterone.
You do that routinely? Can you tell me what do you routinely do?
Ma'am,
आप जब लिखते हैं ना टेस्ट में routinely क्या लिखते हैं? Because she's a laborer's wife, money is limited. You want maximum information utilizing resources that you have and that would add value to the patient. As doctors, we've got to give the best that we can to the couple. We can do 1 million tests, but we want to do simple, we want to do less, we want to add value so that we get her to get pregnant. So what would be the simplest test that you would do for this lady?
FSH, AMH, and thyroid, and maybe the serum prolactin levels.
Maybe anything else that every person who's attempting a pregnancy should do, which I had already highlighted. Gangaram is a center of excellence for genetic disorders. Is there any test we do?
Well, genetic tests are done lately. Like
any one simple test which we have a day for it, that we should prevent this disease. Have you heard of thalassemia?
Thalassemia, we HPLC, we do, but when women gets pregnant, usually the protocol over here is if the patient
you do
gets
thalassemia when she's pregnant. You don't do it beforehand, Dr. Ruma?
Do it beforehand. If I just calm down, and you can list your tests based on general tests and fertility
and
tests.
Specific tests.
Can you now list them? Tell us general tests first and then tell us specific fertility tests.
Well, general, we do FSH, LH, AMH, HPLC can be done. And
not can, but it should be. We're in an audience where we are having a very good medical discussion. We are in a day and age. If she is thalassemic and her husband is thalassemic, we can offer them testing that it is not passed on to their child. So it's not an if, it is a must. Okay. What other tests?
Just a little. She knows it. So general tests are CBC, start with blood group, CBC, NHPLC, fasting blood sugar, liver function, kidney function. That is not essential for a young lady, but for someone who's obese, I would still order liver and kidney. There is thyroid. If you want to repeat it to check her control status, she's and whether she's euthyroid currently or not, and you do her viral markers. Okay, these are general tests, but in specific tests, when you're looking at from the fertility point of view, where you're trying to establish an etiology, you would want to look at, if there's one ovarian reserve test, I won't order FSH LHE2, it will just be AMH on any day of the cycle, but a lot of information can also be gained by one well-done ultrasound. You do ultrasounds at 2 points. One is a baseline, which is in the early follicular phase, where you focus, apart from the uterus, on the ovaries to look at their volume, to look at the antral follicle count, the numbers there. And that is good enough for me to know whether the ovarian reserve is good or not. And if you're looking at uterine function, in this baseline scan, of course, you've ruled out anatomical problems within the uterus. But if you're looking at uterine function, you'd want to do it in the mid-cycle as well. So mid-cycle would be in a 25-day, in a woman who menstruates every 25 days, you'd want to do it by day 11 or 12, which you already specified, Ifat, that women have fixed secretory phases of 14 days or luteal phases of 14 days. So if you had to go in the reverse, like in backwards, 25-day cycle would mean ovulation perhaps by day 11, day 12. So her mid-cycle is day 11. That is when I would order an ultrasound to look at her endometrial thickness, pattern, vascularity. And if I had to do an ovarian function assessment, I would want to do a baseline scan, which is also looking at uterine anatomy in the same book, right? So specific tests in this individual would be AMH and ultrasound. I can stop it there. General tests are from blood group, all the pre-pregnancy tests that we do. You order it. I mean, it's not something that we don't do. Everyone from all across the units in Gangaram order these tests, right? So there's no doubt there. I think hassled by our questioning, incessant questioning now, I can use that word. But so let's go to the next one. So at this point, let's say you found that, okay, let's just go to the, what are the tests? So semen is normal, her ultrasound is normal. You found that her baseline scan is showing an ovarian volume of 7 centimeter cube and 8 centimeter cube on both sides, and antral follicle count of 10 and 11, or 10 and 8, 10 on one side and 8 on the other. You did, there was nothing wrong with the uterus. Anatomically, myometrium is okay. And you haven't yet done a mid-cycle scan, but now she's with you on day 2. What would you like to do?
She has come on day?
Done the baseline scan on day 2. Now what would you?
We have evaluated the uterus, we have evaluated the ovaries, but we have not evaluated yet the tubes. So we need to evaluate the tubes as well. For that, we do hysterosalpingography or saline infusion sonography. Hysterosalpingography is the cheaper test and will give us about the give information about the uterine cavity, the tubes, and tell us about the blockage. For that, we have to plan the patient and tell that we will be doing your hysterosalpingography from day 5 to 10 before the ovulation, and before that she has to be given a course of antibiotic. Usually doxycycline is given for a period of 5 days, and that time it will be a little painful. We will give any painkiller, methotrexate or analgesic to her, and we'll do the test using leech, that cannula, leech Wilkinson cannula, that's the name, and under all aseptic precautions. And urographin is the dye which we use, but it is not to be done in cases like patient is having
HSG. When will you not do an HSG?
If she has acute PID, if she has any allergy to the dye, or maybe in case of allergies, allergy to the dye, or maybe she has conceived, she is pregnant. So in these cases, we will not do the HSG. And if it is done, if at all we have done and we have seen the tubes are patent, this is the test that will tell us about the patency of the tube. If the patient has now the allergy to the dye and all, then we can switch to the next, that is saline infusion sonography. That because in that we inject the normal saline and we see on ultrasound the patency of the uterine cavity, and as the uterine cavity itself and the patency of the tube. But better than
just hold. See, we just have 3 minutes, so you have to be very specific in your answers. I'm going to ask you if there are contraindications to HSG, like let's say a PID or a pelvic mass, what are you going to do next?
Then one is this saline infusion sonography. If not, the better is the laparoscopic laparoscopy with tomopertubation.
Very careful when you answer. I know your hassle, but it doesn't mean you'll give any answer. SIS will also use the same mechanisms that HSG is using. It is also going to push in this fluid into the uterus, into the tubes in the same way that HSG does. So the flare can happen equally with SIS. So in such a case, if you have to still assess the tubes, or of course, in this case, it's incumbent on you to look at the pathology if there are adnexal masses, to try and look at the etiology of these masses, you will want to do a laparoscopy in any which way. So, okay, we will stop it there, but we'll take it further. So let's say you found that the tubes were normal, they were patent on an HSG, right? You've already done the semen analysis, and based on what all the values that you gave us for WHO 2021, things look okay there. And based on your baseline scan, things were all right. Normal uterus, ovaries look okay. You've done some specific tests like AMH, ovarian reserve assessment. What would, according to you, be a low reserve, and what would be a normal reserve, and what would be a high reserve? Let's just take it there. And then one question on how will you manage if everything is normal?
If
values, if you know it, you give it.
Markers for ovarian reserve, just simple, which test, what value?
Okay, for ovarian reserve, for FSH, FSH, if it is more than 10, that means there is a decreased ovarian reserve, and the sensitivity of this is about 10 to 30%, while its specificity is about 80 to 100%. If the value is more than 18, that means the specificity is about 100%. While for the AMH, if the value is less than 1%, that means the sensitivity for this test is about 40 to 97%. And
can you tell me one in which there are units? You know, there are different ways of testing. Yeah. So if you're quoting one
nanogram per ml.
And why it's important, some units given. What is the other unit?
Picomoles.
Very good. So also for everybody to note, sometimes when you see prescription of us doctors and we are in a hurry, we'll write 1 and we circle, or we may write 10 and we may circle. A 10 nanogram is different than a 10 picomole. So we must always write the values. So that's a very good answer. Okay.
Then ma'am, and the specificity for this test is around 64 to 92%. Well, as for
quickly, what's the high value of AMH? What would you worry about? You said less than 1 for low. What is high?
More than 5 will be high.
I think they don't deal with cases of infertility. But the other thing is, how will you, so let's say this was a normal AMH individual, normal reserve, normal tubes, and normal uterine cavity, and normal semen. What is now your diagnosis? What will your final diagnosis be?
It's fertility.
Good. With primary unexplained infertility of 2.5 years. Very good. Now, what is your management? Would you be able to tell us in sort of one phrase? And we don't want to.
I would like to give ovulation induction in this patient for at least 3 to 6 cycles, and we'll see the response in that, and adding to that the ovulation induction with IUI for next 3 to 6 cycles. If not, then we'll go for the IUI.
Do we offer ovarian stimulation with IUI, or do we offer ovarian stimulation alone?
First 3 cycles, I think we should go with on her own cycles, because her age is less.
See, the answer is for all unexplained infertility, we offer the plain ovarian stimulation in a woman who's already ovulating is not going to work. You need to, in order to give her a realistic chance of an improvement in her monthly chance of conceiving. Monthly chance of conceiving for a woman 28-year-old, 2 and more years of infertility is around 2 to 3%, not more. Okay, beyond that point. So now you want to give her a chance to improve her fertility per month, adding medicines. And I don't expect postgraduate students to know this, but adding medicines, but it is important to know this, however, so which is why I'm going to tell you. Adding medicines alone is not going to improve that monthly fecundity by more than 2 or 3%. So it's not very significantly high. When you add medicines with IUI, then you improve that chance from 2 to 3%, whatever her monthly fecundity is, to around 12 to 15%. So if you really want to improve her monthly chance of conception, you offer ovarian stimulation with IUI in a patient such as yours. Okay, so that's the answer. Dr. Tanya, would you like to ask any questions? I think we are done with the time as well.
Yeah, you've done well, but just go through in your mind again specific pertinent points from, remember, she's a wholesome woman. So you, just like any other woman, whether anyone who's planning to conceive or even when they come to you, wholesome, but for fertility, few things which are different, keep that in mind, which you add on in your history. So you took a very good history in examination, just add the points that we've said, keep it simple, think before you answer. Think in your mind justification of how you're going to answer. When you give a value, please add what you're going to say in whatever units there is and summarize with very short lines.
Your history was otherwise quite complete.
Very good. Even her examination was good. Just add in, because genetics, history of any other illnesses which can be hereditary, very important for fertility. And COVID, because we're in this era. And what I'd like to add in your investigations for everyone, please, when you examine a woman, also take a pap smear, right? Because you want a healthy mom, you want her to have an uneventful pregnancy. So please treat the complete unit, the woman, the husband, and the child, right? So just like we had lovely talks from Rh negative, blood group was important, which Ruma said, thalassemia, as I said, pap smear, to sugars. We had a lovely session on diabetes as well. So it starts with us. Thank you, and you did very well.
Thank you, moderator ma'am. The discussion was enlightening in various realms of fertility. And now we want to move to the next session. The next session is regarding drugs in obstetrics and gynecology. And the session will be moderated by Dr. A.G. Radhika ma'am, Senior Consultant from University College of Medical Sciences and GTB Hospital, Delhi, ma'am. Over to you, ma'am. Thank you.
So, very good evening to all. So I think that was a very detailed session on the workup of the infertile couple. So I enjoyed it too. Nice. So today we have the class on the drugs with a twist, because I don't think having a dietetic lecture talk is going to be interesting. So we have the list of students who have prepared their slides. I think what we would do in the next half an hour is basically have focus on important drugs and kind of simulate what happens, what the kind of questions that get asked in the exam. So while you could get a short note in the direction of the effects of drugs or the newer drugs and so on and so forth. So it could be a table viva, the drugs can be discussed anywhere. So there are a few students who have prepared the slides. So shall we start with Vasundhara first? So I said 5 minutes per student. So let us confine all the students to,
I have shared I think I'll start.
Yeah, whoever, please feel free to start. Whoever is ready to start. And please tell us your name and start.